Hello, good morning, everyone. This is the second day of FRC and ARS, the best of ARS 26, the second day, and we will start the first session. And we pleased to be chairing this session, I, Dr. Mushabab Al-Ahmari, and Mr. Ahmed Al-Husseini. And we will start the first session of this day, which is about pediatric and neonatal respiratory care.
Dr. Evans, joining us from US. Please join us in welcoming her.
Good morning. Thank you for joining this morning as we talk about children. So I have the pleasure today to talk about pediatric physiology. There's a pretty robust chapter in your book on the assessment, diagnosis, and pathophysiology of common pediatric illnesses. They will go much more in depth than I will this morning, as each of these could probably be their own individual lecture and a symposium in many cases. But we'll talk about the high-level overview of those things. You'll get a little bit more of that in the workshops as well, but we'll jump right in. So just to level set for the purposes of this course and your textbook, these are some definitions that are important to know. You will see some differentiation in that depending upon what author you're looking at. But for the purposes of this, a pediatric patient is anyone between 28 days of age and 21 years of age. Now, so I've been a respiratory therapist for 25 years and worked with children since about day 3 post-graduation, and I can tell you, if you work in a very robust pediatric intensive care unit or a very large pediatric hospital, it's very possible that you'll care for children, adults, that are over 21 who have pediatric diagnoses, but no adult provider that is able to care for those children. This used to be very, very common in cystic fibrosis, right? So a lot of those children didn't live into adulthood, so adult pulmonary providers didn't know how to care for those children. Lots of new therapies and interventions, so patients with cystic fibrosis are living longer and longer. So now we're seeing those pediatric patients transition to adult pulmonary clinics, which is outstanding. But for a long, long time, we would care for people with CF as old as 26 in some cases, depending upon the pediatric disease state. And that happens with other chronic diseases of childhood as well, where our adult friends just simply do not have the expertise to care for those kids. The other place you see this sometimes is in adult patients who had significant congenital cardiac anomalies, right? So we'll talk a little bit about that today as well. So again, back to these definitions. Infancy is anyone under 2 years of age, childhood 2 to 12, adolescents older than that. You will probably hear this from Emily as well, but children are not small adults. We talk about that a lot. There are many similarities, right? End-tidal CO2 in a pediatric assessment is very similar to that in adults, but from a pathophysiology perspective and an anatomy perspective, there are some really important and key differences that we have to know in order to care for them in a great way. Okay, so in a normal healthy child, that they're just different than adults, as I said, right? So they're not, their neurodevelopment and respiratory centers are not as developed in adults. It takes a longer time to do that. Their airways and alveoli aren't fully developed until they're actually about 8 years old, so it takes some time for them to sort of achieve normal pulmonary function as well. Just by design, kids have big heads compared to their body. Their tongues take up much more space in their airway than that of their adult counterparts. They have more anatomic dead space, again, just because they haven't grown into those airways. They'll use more oxygen, so they're have higher oxygen consumption levels than adults. Probably one of the more significant physical findings you'll see is they have a higher chest wall compliance, right? So that just simply means that when they're struggling to breathe and pulling really hard, the chest wall can suck in, right? Retractions. We see that, right? So you'll see tracheal tugging, intercostal retractions, subcostal retractions, things like that you're unlikely to see in adults, but very common in children because they have such a highly compliant chest wall. As kiddos grow, small children have higher heart rates, higher respiratory rates than adults do. And again, that's just a component of the way that their circulation is. That changes as they age. So basic assessment. So this is, I think Brady talked about this yesterday. This is the I'm standing in the door basic assessment. You should be able to stand at the door and know if this kid's in trouble just by visually looking at them in 10 seconds, right? So that's that visual assessment. Are they head bobbing? Are they nasal flaring? Maybe I can see retractions. Maybe I can see the color of their skin, palpation, and breath sounds. You want to assess mental status, which is very different than assessing the mental status of an adult patient, right? So this might look like lethargy, a decreased mental status. It might look like unconsolable fussiness. They might be floppy. They may not be engaging with their environment as expected. Sometimes the best way to know if a child in front of you has a decreased level of consciousness is to ask mom and dad. Does this look normal to you? Is this how your child typically behaves? The best people that can give you information about a child that you've never met before are the primary caregivers. They know what normal looks like in their child in a way that you never will. So this is so important to engage with them and ask, is this what she's normally like? Is she usually this sleepy? Is she more active? How does she engage with whatever toys in her hand, things like that? You want to look at their appearance, their breathing, their circulation, of course, and vital signs. Really important to lift up their shirt, right, to assess patients, because, again, you want to look for retractions, tracheal tugging, things of that nature, which could be hidden if you don't look under the shirt. Physical examination of pediatric patients does include palpation. Sometimes just by laying your hand on the chest, you can feel rumbling of significant secretions and know something is going on from that perspective. Auscultation is an important tool in adults and kids. Important to note here that findings of wheezing or crackles in of itself is not diagnostic, right? Just like anything else, you have to look at the bigger picture to know what that cause is. If I had $1 for every time I was called to the ER to give albuterol to a wheezing child that did not have asthma, I'd be a very rich woman, right? Because not all things that wheeze are asthma, but sometimes we think that in children. Really important to look at the big picture, right? Viral wheezing is significant in kids. It happens. Sometimes it's secretions that are causing a reduction in the airway circumference, and that's actually what's causing wheezing. So you have to look at the bigger picture to really diagnose that. Patient history, as I mentioned, this is so important. It's important in all patient populations, but engaging with the caregivers, having a conversation about what's going on. Have they had respiratory distress? Have they had a fever? Has somebody in the house been sick? Things like that can help you really get to the heart of what's happening with the baby or child in front of you. And then, of course, it's really important to know if they have a chronic illness, right? So if you have a child in front of you that's 6 months post-cardiac surgery, that's a huge finding compared to an otherwise healthy child. So monitoring. This is where it actually does get similar to adult care. A lot of the tools that are available to adults are also available to children. Sometimes we use them in different ways. They mean different things. But, pulse oximetry, heart rate, respiratory rate monitoring, that's all the same. You will see end-tidal CO2 monitoring. That's becoming more and more popular. Very common in the pediatric intensive care unit for intubated patients. Less common in NICUs. just because those things put so much dead space into the airway. It can be very difficult to have an item this big on a very small 1-pound baby, right? And they're heavy. They can be very heavy. So if you put a device like that on a very small 2.5 endotracheal tube, it might pull it right out. So we don't use that so much in the NICU. Very common in the PICU, however. And then, of course, we use it in some cases for patients with the nasal cannula as well. Transcutaneous CO2 did come up yesterday. They don't use it so much in adults. We use it a lot in kids. It's a nice replacement for end-tidal CO2 in the NICU space for all the reasons I just said that you wouldn't use it. We would use transcutaneous CO2 for those patients. The nice thing and the reason this works so much nicely in kids than adults is children don't have as much adipose tissue. So it's easier to heat up that capillary bed and really get a good assessment of transcutaneous CO2. It correlates usually pretty nicely with blood gas analysis. The other reason we like to use it is high-frequency ventilation. You cannot get an end-tidal CO2 reading on a patient who's on a jet, an oscillator, or a VDR. It's not happening, right? And where do we see jets, oscillators, and VDRs? We see them in kids. So that works really great for that. Near infrared spectroscopy is not very common. It had a moment, but it's not very common anymore. NIRS monitors are they function a lot like pulse oximeters. They sit on, usually you put them on the scalp. They use waveform technology, higher wavelengths than pulse oximetry, but it really looks at venous oxygenation. And the intention of putting it on the forehead is to try to get an analog of cerebral oxygenation, unfortunately, and the reason you don't see it very much, it doesn't really correlate to actual gas values. It's not really, doesn't really work so well. However, some places use it as a trend, right? So if it's 80% and it suddenly dropped to 60%, you know cerebral oxygenation is probably reduced. It's expensive, it's tedious, we don't see it very often, but it is available. Electrical impedance monitoring, or EIT care, still not very common either. Becoming more common. So this became commercially available a few years ago. We'll talk about that in just a minute. Invasive monitoring, et cetera, we have that with kids too. Chest x-ray, still the most common diagnostic testing or radiology testing that we do in kids. If you did this on a patient with severe asthma, probably wouldn't be very helpful. You're just going to see flattened diaphragms and overdistension, right? That's what you're going to see in asthma. You might see something different if they have pneumonia, et cetera, just like in adults. So this is recommended in your textbook for symptomatic respiratory distress when you can't figure out what's going on. Just like in adults, we use it to identify ET tube placement. It's good for that. We typically do it at the bedside. We don't take kids to chest x-ray if we don't have to. And this actually says it's often done daily in the ICU and after transport. It does say that in your book. I'm going to challenge that a little bit and tell you that we're being much more thoughtful about radiation exposure in children, particularly kids that have chronic disease, and we know they may have serial exposure to radiation over their life. So we actually try to minimize the use of chest x-rays unless we absolutely have to. So the idea of daily x-rays in the ICU, it's kind of fallen out of favor. We typically do it if we think we need it. Has something happened? Has something changed? Do I not know where the airway is? That's probably when I'm going to reach out and get chest x-ray to come up. It would be very uncommon, at least in my practice, for us to do a chest x-ray simply because we've transported them. Again, trying to minimize radiation exposure in those kids. CT is another good mechanism to evaluate the lung fields. We do that just like we do with in adults. So it's good for evaluation of lung volumes for children with pediatric ARDS, kids with floppy airways, bronchomalacia, things like that. And then we move to MRI testing for more thoracic pathology. But we don't use it as often. Point of care ultrasound has become a hot topic. Is anybody using point of care ultrasound You are, yes. It's really nice for lung ultrasound if you know how to use it. So the sites that are using point-of-care ultrasound for lung assessment, I love it when the respiratory therapists are doing it. Do your RTs do it or your physicians? The RT, I love that. That's great. The RTs do. So that's great. That's a great diagnostic tool that has no radiation, where I can really assess lung volumes, ET tube placement. I can see what's happening with the diaphragm. Is it moving as expected? And it can be inexpensive, easy to use at the bedside, but the training is the key piece. You have to be skilled at using this. You have to have a good training program to know how to use it, or it's really ineffective and can be used inappropriately, and you can give the wrong information with that. But this is wonderful. I really love this. I'd like to see more places using this, particularly for airway placement. That's kind of a neat tool to be able to say, I'm not sure where the airway is, let me just get out the ultrasound and have a peek. So EIT, I mentioned this. So your textbook says it's not commercially available. That was true when the textbook was written. It's commercially available now from several companies to be able to use this. So it looks like a strap on the chest. It usually has 60 to 7 electrodes, and it's looking at conductivity in the lungs to give you a visual image of gas and gas distribution within the lungs. Again, doesn't require radiation, which is nice. Doesn't require transport, which is nice, and easy to do at the bedside. I think point-of-care ultrasound is probably more popular than EIT at this point, but they're both having a moment. We'll see how this progresses and what it looks like moving forward, but they're both low cost, no radiation, and give good data at the bedside in real time, and can and should be managed by the respiratory therapist. EIT is actually really nice, and we think it will have some utility in doing some personal PEEP setting, right? You can, in real time, as you adjust the PEEP, watch changes in lung expansion and gas distribution. So I think this will be a nice addition, perhaps, to the work that we see in our PICUs and NICUs. Okay, so I'm going to move into some common disease discussions. Fair warning. There's like 2 slides for every disease, and each disease I could talk about for about 4 hours. You ready? Okay. This is going to be like, whoo, speed round. Okay, so asthma is the most common, one of the most common childhood diseases. You'll see this around the globe. It's typically diagnosed by the guidelines after age 2. That is because under age 2, often wheezing is viral wheezing, right? And you don't want to overdiagnose asthma in a child that simply may have a virus and wheezing associated with that. So this can be challenging in some cases. I'm not a big fan of peak flows in any patient, but if you can get a 2-year-old to do a peak flow, I will buy you a cookie, right? It's tough to get small children to cooperate with some of these techniques, so we don't really use them in children. We do physical exam findings instead, vital signs monitoring, breath sounds monitoring, things of that nature. Scoring systems. I would say asthma is probably the #1 place where you see consistent scoring systems used at hospitals, algorithms, RT-driven protocols. This is often where it starts in our team. So scoring systems can be very, very impactful in these patients and can ensure consistent, evidence-based care from patient to patient. Now, the bummer about this is there is no gold standard for a scoring tool in pediatric asthma. Doesn't exist. What happened is every children's hospital made their own, right? So we have one, Children's Hospital of Philadelphia has one, I'm sure Emily's hospital has one, and I bet they're similar, and I know they're not the same, right? There are some validated pediatric asthma score. I think MIPS is mentioned in your book, but again, there is no single widely used tool. If you're bringing one in for the first time, I would recommend just grabbing one of those validated tools that's seen in the literature, you know they work, and implementing that. If you do not currently have a pediatric asthma score, I'd consider looking at that and trying to bring one in. Again, it ensures consistent care. It ensures that the decision I make would be the same that Emily makes, right? And that our kids are getting that good evidence-based care. It also guides our physician partners in making decisions about when to use systemic steroids when to use magnesium, right? So it goes beyond bronchodilator care, but really looks at other adjunctive therapies for asthma. There is evidence that shows hospitals that use standard asthma pathways, RT-driven or otherwise, have better outcomes, right? And again, it's just about the consistent approach. This probably makes sense to you. If you're sick enough to be in the ICU, you probably need more assessments than a kid that doesn't, so that's true. Severe cases do need close observation. We really try to avoid intubating asthmatic patients. Why do we do that? Why do we try to avoid intubation of an asthmatic patient? What? They are difficult to wean, right? They've already probably got flattened diaphragms, right? They're already having a hard time exhaling their gas, so they're overdistended. If we put them on the ventilator, we could make that much worse, right? It's difficult to get them off. So we do intubate asthmatic patients, but that's really reserved for the most significant, severe refractory cases that are not responding to any intervention that we've tried. Typically what we try to do with these kids is manage them as low as we can, right? Oxygen therapy if they need it. High flow nasal cannula therapy works beautifully in these children, reducing work of breathing, washing out dead space, really does a nice job. Whether or not you believe it adds a little bit of PEEP, that might be helpful. Non-invasive ventilation if you absolutely need it, again for the same reason, you want to avoid additional overdistension, and then intubation really as the last decision point. Bronchiolitis. So upper respiratory illness is the #1 cause of admission for children across the globe, including in Saudi. I did look. Bronchiolitis is one of the more common causes of that, those needs for admission. Bronchiolitis is virally induced. RSV is the most common. So much so that in the ER, here in the States, we do rapid RSV swabs to try to see if that's what it is. I will tell you this. Just because it's not RSV does not mean it's not bronchiolitis. There are many things that cause bronchiolitis. Human metapneumovirus, one of them. Parainfluenzas can do this. Influenza A can cause this as well. So really it's just virally induced. RSV is just the most common. So I have a whole presentation on bronchiolitis care, and it basically is just a list of me saying, don't do that, don't do that, don't do that, right? We really want to throw the kitchen sink at these kids, right? Oxygen, albuterol, CPT, none of it works. There's no evidence to support it. Really what we should be doing is just supportive care. It's a virus. You just have to take care of them until it works its way out of the system, right? So if they're hypoxic, you give them oxygen. If they're dehydrated, you give them fluids or orogastric feeds, right? Remember that children are obligate nose breathers. So if their nose is occluded with mucus, they don't know to open their mouth and breathe, right? So we need to keep their nose clear, lots of good suction for those kids, but it also means that they're less likely to take in fluids and eat. So the #1 reason that children with bronchiolitis get admitted are either hypoxia or dehydration symptoms. You treat those things, right? This is probably the most studied disease state with high flow nasal cannula. You probably couldn't walk 3 feet without stumbling over a bronchiolitis and high flow nasal cannula study. They're everywhere, and it has shown to be incredibly effective in children with, that have significant hypoxemia and work of breathing, to reduce that work of breathing and to offset the dead space associated with that. So it works really well. But albuterol, no. CPT, no. Steroids, no. Antibiotics, no. Right? No. There was a moment where we gave hypertonic saline to every one of these kids too. Did anybody else do that? Yeah, it doesn't work. No. It's like we spend our time trying to figure out things to do to these kids when all they need is time. So as you can expect, they arrive in your ER. If they do, tachypnea, accessory muscle use is retracting, maybe hypoxemia. If you auscultate, you might hear wheezing, you might hear crackles, you might hear popping sounds on exhalation. Just depends on what's going on and the significance of the lower airway impact. This says scoring systems are ineffective in bronchiolitis. I will tell you a lot of places still use scoring systems in bronchiolitis. But again, it's not going to guide you to much. Usually what you see in these scoring systems are algorithms for the use of high-flow nasal cannula now. When should I start that? What should that look like? How should I escalate that? How should I wean that? Again, there should be no bronchodilator intervention. So that's why really we don't use them very much. It more likely looks like a high-flow nasal cannula algorithm. Severe, significant cases, that's when you end up on the ventilator. We try to avoid that as well. Pneumonia. Kids get that too, often caused by viruses. Just as I said with bronchiolitis, the care for this is mostly supportive. If they're hypoxemic, I give them oxygen. If they're dehydrated, we give them fluids, right? If it's bacterial in nature, obviously you want to treat that. That's absolutely vital that you do so. But if it's viral, which most of them are, you just treat the symptoms as they present with. Neuromuscular disease. Do any of your hospitals have a neuromuscular disease program for children? No. So common neuromuscular diseases that we'll see in children are things like spinal muscle atrophy, Duchenne's muscular dystrophy, things like that. With these children, ultimately what happens is their muscles become floppy, right? So over time, maybe they can't sit up, maybe they can't hold their bottle anymore. Some of them end up wheelchair bound, but when that happens, their respiratory system is impacted as well, right? There has been some good genetic testing and studying and interventions done on some of these, spinal muscle atrophy and Duchenne's being some significant areas of innovation in the last few years, but Guillain-Barré, myasthenia gravis, we still see those in kids. So with children with neuromuscular disease, we're treating them for their respiratory failure, right? The most common reason that we lose these kids is going to be severe respiratory distress and failure, right? Now, as their disease progresses, as I mentioned, the diaphragm becomes weak, the respiratory muscles become weak, they just become ineffective in breathing, but also have significantly impaired cough reflex and an inability to mobilize their own secretions. So this is when you'll start to see the use of non-invasive ventilation, typically BiPAP, bi-level care, as opposed to CPAP for these kids. Sometimes they'll do SIP ventilation, you'll see that a little bit. The indicator that it is time for NIV is daytime hypoxemia and daytime hypercarbia. We all know that we desaturate a little bit at night, but if you're seeing it during the day, it's time, right? And I don't mean nap time, when they're up and about. That's usually when we start to do around-the-clock intervention with these children. Exacerbations do typically require ICU care, particularly if they already have a trach or they're requiring non-invasive ventilation at home. Typically with these kids, the therapy we give them is to help mobilize the secretions, right? To try to care for them in that way beyond the non-invasive ventilation they get. However, it's very understudied. We don't know the impact of chest vest therapy. We don't know the impact of IPV, really. We don't know the impact of inhaled medications. It's just been understudied. Now, my suspicion is albuterol is probably not doing anything for retained secretions, right? But it's understudied in these kids. But this is where you'll start to see insufflation, exsufflation therapy in some kids. So, not uncommon to try to jostle loose the secretions with vest therapy or IPV, and then do a cough assist intervention to try to help them mobilize their secretions in our patients that have normal anatomy. but again, understudied. But there is data to support the use of insufflation, exsufflation in these patients, and there's a good CPG that was put out by one of the associations that really does push cough assist therapy in these children in late stages when their cough reflex and respiratory muscles have become less effective. Now, depending on the type of neuromuscular disease, you do really have to have a conversation with the family about their goals of care, right? Where do they want their child to be? How do they want them to be cared for? Do they want them to be on long-term mechanical ventilation? How do we want to manage that? Particularly in some of these illnesses that are progressive and really have no therapy to reduce slow progression or to reverse it. It can be pretty sad sometimes. It's why we're so excited when we see innovation in the area around spinal muscle atrophy. SMA type 1 was really a death sentence for children in under a year. That's less true these days because of the interventions. Same thing with Duchenne. So that's really nice to see the progression in this science around this. And these children that, when I first started, would not have survived 6 months are now really starting to thrive and do much better than they ever would have. Pediatric ARDS. So adults use the Berlin definition. We use the PALIC guidelines. So the Pediatric Acute Lung Injury Consensus Conference, those are the guidelines we use for kids. It is a little bit different. We use the oxygen index to diagnose it, to diagnose the severity. So SpO2 over FiO2, it's a nice, easy calculation to use. If your OI is less than 6, following acute insult, you have pediatric ARDS. So just like in adults, this triggers an inflammatory cascade. They have leaky capillaries, disruptive surfactant function. You'll see hypoxemia, atelectasis, things like that. Decreased FRC, increased dead space. We really love not to intubate kids if we can avoid it. So if you can get away with high-flow nasal cannula, that's nice. But severe disease, we really have a very low threshold to intubate and support these kids. They'll be some of the sickest you have in your unit. Like adults, low tidal volume strategy is the way. We do try to use physiologic tidal volume, which is 6 to 8 mils per kilo of predicted body weight. We don't use ideal body weight in kids. That calculation calls for you to be like 5'2". Don't know a lot of 5'2" kids. So we do predicted body weight for them to determine the tidal volume. And then, of course, PEEP is so important. I will tell you, I usually tell people that most neonatologists I know have a fear of PEEP. PICU docs sometimes have a fear of PEEP. You have to talk them into this. It is very plausible to have a child with severe pediatric ARDS that needs high levels of PEEP, 10 or more in some cases. We'll do that in adults all day long, but for some reason, in a small person, it makes them very anxious. But the mechanism, the need to open up the airway is the same. It does say daily chest x-rays. Again, I'm going to challenge that. I don't know that we're always doing daily chest x-rays anymore, but certainly frequent monitoring of pH and CO2. That was the shortest pediatric ARDS talk you'll ever sit through. Okay, I'm going to move on to pediatric cardiac arrest. Unless a child has a known cardiac illness, 99 times out of 100, pediatric cardiac arrest is not sudden. It's caused by respiratory failure and worsening hypoxemia. So this is a child that has been sick for a while, right? It's not common to see someone walking down the street and just a child falling over with an MI like you'd see in adults, right? In children, it really is hypoxemia. So the underlying treatment for this is to increase their SpO2 and to get the blood pumping again so that we can return normal circulation, normal oxygenation to the heart, lung, brain, etc. But if you do see a child that looks healthy, is not sick, and collapses, it's probably cardiac. right? Probably cardiac, but like I said, that's not normally what we see. Most of these kids go right into asystole. It's a non-shockable rhythm, again, because it's caused by hypoxemia, not underlying cardiac disease like us adults who have eaten cheeseburgers for 30 years. So just like in adults, high-quality CPR is important. I think Emily and her team will talk about this a little bit in the workshops this afternoon. But the big point here is organ preservation and post-cardiac care. So we want to make sure that the heart, lungs, and brain are being protected, just like in adults. We want to make sure they have normal oxia. So we don't want to see 150 PO2. We want to see normal oxy in these patients. We want to avoid hypotension, and we want to have tight temperature controls. There's also good evidence that shows outcomes are impacted by glucose levels in kids, so maintaining and monitoring their sugar levels, very, very important in post-arrest care. So, because most of these kids do not have cardiac disease associated with cardiac arrest, the focus in kid care is really in prevention. Treating hypoxemia when you see it, caring for them, making sure they don't become so exhausted that they just become apneic and they move into a cardiac arrest event. Really great systems have come out probably in the last 15 years to help clinicians objectively assess when a child is becoming sicker and sicker and their clinical status is deteriorating. The most common, the most studied, PEWS. Is anybody using the pediatric early warning system in their hospital? Yes. Yes. Very, very common and very, very simple. It really just looks at behavior and level of consciousness, respiratory rate, work of breathing, circulation. So this could be heart rate and capillary refill. Very, very simple stuff, right? But when this starts to change, they become much more tachypnic, much more higher work of breathing. If their capillary refill starts to extend, these are significant warning signs that you're about to fall off the edge. Right? So they're very good tools, well studied. A lot of children's hospitals have implemented them, and pediatric wards as well, because again, the goal with these kids is to keep them out of the ICU, and you certainly want to avoid cardiac arrest. Many places, I know the place where I work currently, we actually use our PEWS score to trigger things like high flow nasal cannula use and other interventions to try to drop those PEWS scores. Okay. Congenital heart disease, I'm going to talk about this in 3 minutes. Could be a 3-day talk. Only 1% of births typically present with congenital heart disease, typically found in prenatal care, prenatal ultrasounds. Sometimes, though, it's not found. Sometimes it's found post-birth. That typically happens when mothers don't have good prenatal care, but can happen otherwise as well. About 25% of these 1% will be severe congenital heart disease and require intervention. As a respiratory therapist, what you need to know is this a ductal-dependent or a non-ductal-dependent lesion, right? If there's a ductal-dependent lesion and you give them too much oxygen, what will happen? The duct will close and they might die. Ductal dependent, right? So you need to know what are the cyanotic, what are the acyanotic, and what are the ductal dependent lesions. And if you don't know, and you're at the bedside, ask, is this a ductal dependent lesion? You do not want to give them too much oxygen, the duct will close. What you actually want to do is give them prostaglandins that forces that duct to remain open, right? The thing you have to remember about prostaglandins, one of the side effects of that is apnea. So it keeps the duct open, which is important for cardiac blood flow and oxygenation, but they may need CPAP, NIV, or intubation associated with that because of the apneic events that come along with it. Typical cyanotic heart disease that you'll see are things like tetralogy of Fallot. Right, that's a big one. Transposition of the great vessels. Acyanotic heart diseases, the most severe is HLHS, which we'll talk about just in a moment here. Well, we'll talk about it right now. It is the most severe cardiac disease that you'll see. These children need to be transferred to a high-level cardiac center immediately if they have hypoplastic left heart syndrome. This is an acyanotic heart disease, but it is ductal dependent. Most of these kids will need surgery immediately, right? And there are 3 stages to an HLHS child's surgery care. They actually become cyanotic after the first surgery, which is interesting. Most of these kids will require ventilation, sometimes require other interventions as well as they're traversing through that surgery schedule. They are at very, very high risk of cardiac arrest, so we have to monitor them very, very closely. Cardiomyopathy is rare. It's very rare in kids. When you see it, though, the mortality rate or cardiac transplant rate in the under 2 years population is about 45%. So uncommon, very severe, very significant, high mortality, high morbidity. These kids will present to you with pink-tinged secretions. They may have crackles from pulmonary overflow, enlarged heart borders, so a big heart, things like that will take you into that. These kids typically, while they're waiting either to improve or get their new heart, need ECMO and sometimes VAD devices. MISC was very hot when this chapter was written. It is very rare, it was quite uncommon, but really it's the post-COVID, post-viral disease state that we saw in children, really in the 21-22 era. It typically resolves on its own within a month or so, but you'll see a child with persistent fever. They will probably have had COVID recently, have a persistent fever, inflammation, and might present to you in cardiogenic shock. Again, very, very rare. You're treating the symptoms as they present to you, and you hope that it resolves on its own. Drowning. So the language that we use around drowning has been changing. It used to be that if I said the child drowned, that means they died, right? And we would talk about near drowning as an infant or child that survived that event. You don't see that so much anymore. The language is changing. Drowning now tends to be an umbrella term, with fatal drowning being the child that did not survive and non-fatal drowning being the child that does survive. In kids, you're going to see this much more commonly in the summertime, warmer months when they're around water. In infants, this could happen in the bathtub, right? Could happen in a bucket. Kids have big heads. They're top heavy. They could fall over into the water. It doesn't take very much. So close monitoring around children with water is important. But the injury that we see and the non-fatal drownings when they come to us is because of aspiration. It doesn't matter if it's salt water or fresh water, the impact is the same. You end up with surfactant disruption, right? Surfactant is responsible for alveolar surface tension and prevention of atelectasis. So if you have surfactant disruption, this is significant. They'll present to you with all sorts of things. It can also launch the inflammatory cascade and look a whole heck of a lot like pediatric ARDS, or actually trigger pediatric ARDS in some of these kids. Cardiac arrest from hypoxemia, these are probably the kids before they've gotten to you. Some of them are arrested in the water, depending upon how long until they've been found, or they arrest shortly thereafter. But again, when they're rescued, the severity of illness depends on how much water they actually aspirated. So treatment, again, similar to pediatric ARDS, that's probably what they're actually presenting with surfactant disruption and the launch of that inflammatory cascade and leaky capillaries. Cerebral palsy, this is the last one I'll talk about. Cerebral palsy is a group of disorders that cause abnormal neurodevelopment. A lot of times we see these kids because they end up with kyphoscoliosis or other illnesses from progressive muscle weakness, and just difficulty in managing their secretions as well. Again, evidence around airway clearance therapies has been understudied in these kids. I would argue if they have a weak cough reflex, You may look to some of the evidence in neuromuscular disease for insufflation-exsufflation therapy to help them mobilize that, but again, really understudied, unfortunately. Most of these kids, when they present to us, will be in chronic respiratory failure due to lung injury, kyphoscoliosis perhaps, diaphragm weakness, and other airway obstructions, again, just from the floppiness associated with that. Care is supportive based on how they present to you. Okay. That was the fastest ever. Okay, so lots of key points here. I won't read them all to you, but just remember that children are not small adults. We do care for them differently. Their anatomy is different. Their pathophysiology is different. And the science and the way that we treat them is different than in adults. And I think I will end there. Thank you.
Thank you, Donna. It was a rushed but very well comprehensive talk. And I appreciate all the effort you did there. We welcome Emily Lomarina talking about neonatal pathophysiology, assessment, and monitoring. Welcome, Emily. Join us in welcoming her.
Thank you so much for that warm welcome. I am so excited to be here. Thank you to Hassan for the invitation. It is my first time in the kingdom, and I've absolutely loved it. The hospitality has been incredible, and I'm really, really excited to be here for the first offerings of the neonatal and pediatric track. I have dedicated most of my life and my career to working with children. I spoke to many of you yesterday, and I want to create a community to support neonatal and pediatric RTs, and I've created that in the States as well, because the work that we do is so unique, and we're working with the most fragile patients, and coming to conferences like this and hearing from experts and sharing your information is the first step. So thank you all for being here, and I'm looking forward to the next few days to continue supporting the work that you're doing and sharing information. So what we are going to talk about today is the importance of knowing and understanding neonatal pathophysiology, how to assess them, and how to monitor them. I don't know which button. I'm sorry? Sorry. And there are many objectives that we are going to discuss. Just so I can tell by raise of hands, how many of you are students? Oh my gosh, oh, this is so exciting. And you're here in the neonatal, oh, awesome. I will tell you in the conversation I had yesterday, if you graduate a program and you are terrified to go into a children's hospital or work with neonates, you are all of us, and that is completely normal. I actually accepted my first role in an adult world because I was so scared of neonatal and pediatrics. And so I'm so excited that so many students here are excited to learn about it, and because it is just more specialized care, so that's wonderful. So thank you for being here. For those that are working, how many of you attend deliveries where you work? A good amount. Okay, good. So that's what this talk will focus on. We really want to, as RTs, understand the maternal and perinatal risk factors that contribute to neonatal physiology conditions, because that is our role in the NICU. Is we have such a specialized knowledge of what's happening with the fetal lung development when the babies are born that will help us provide support for them. We're going to identify the gestational age at which viability occurs, which has changed over the last few years. We're going to list the components that aid with a differential diagnosis for the respiratory compromised infant, because respiratory distress is the most common reason that babies are admitted to our NICU, and is our job as RTs to help with figure out what is actually causing that. We're going to discuss the signs and symptoms that present when a patient has transient tachypnea, or TTN, which is a very interesting diagnosis to treat. We're going to discuss the two predominant factors that contribute to RDS in a neonatal patient. We're going to talk about some X-ray findings, talk about meconium aspiration syndrome, which is a common finding that we have, discuss the prominent reasons that infants with CDH demonstrate respiratory failure at birth. We're going to talk about neonatal pneumonias, the risk factors that lead to pulmonary hypertension, which is also a common finding in our NICUs, and the most common form of chronic lung disease. And why is this important? We know that because of advancements in the last few decades in technology, medicine, and our own understanding of how to best care for these patients, we've seen an increase in the surviving number of premature infants. And we've even seen viability going down to 22, 21 weeks. So that is wonderful, but requires a lot of us with our expertise as RTs to take care of these premature infants. And as we've mentioned, respiratory complications remains one of the most important factors affecting the outcomes, morbidity, and mortality of these patients, because of what we know are the important stages of your fetal lung development while they are growing in the mom's uterus, that if they're born prematurely, that process does not get to complete. So we have to care for them as they continue to develop in our NICU. And so as RTs, our knowledge and our recognition of this pathophysiology is so important for us to be that clinical expert at the bedside and take an active participation role in the treatment and plan of care for these patients. So the first thing we're going to look at is what is most commonly a cause for morbidity in our NICUs, which is premature births. And for those who attend deliveries, what are the 4 questions that you always want to ask before you go to a delivery to make sure you have a good idea of what to expect? Age. Well, gestational age. What do we believe is a gestational age? And we're going to talk about why that's important, because how many weeks they are is going to tell you at what stage of their fetal lung development they are and what we need to prepare for. What else do you want to ask for? Risk factors? Yes. So are there any maternal or fetal risk factors? Does mom have any issues that we should prepare for? Was there any fetal distress? Do they have group B strep? Yep. What else should we ask about? How many babies? How many have run back thinking that there was only one baby? And you're like, oh my God, it's triplets, and you have to get the rest of your team to help deliver. So yes, how many babies? And what's the last thing? Yes, amniotic fluid. That will be able to tell you if what might have occurred in utero. Well, we want the amniotic fluid to be clear. If it's not, what might we suspect have happened? Meconium aspiration. Oh, you guys we're all good. That's awesome. So yes, those are the 4 questions that you want to always ask first that will help make sure you have the best information you have, because once you're in there and that baby is born, we know that the time is ticking and we have to be prepared to resuscitate them. So when we think about premature infants, there's many risk factors for it. And one of the most common findings that we have with the mothers is that they have hypertensive disease. And that's going to occur about 12 to 22% of pregnancies. And when the mom has hypertensive disease, this can cause intrauterine growth restriction, placental abruption, and it can lead to preeclampsia, which is really a marker of several factors, but you usually see 3 main things. First is that they have the hypertension. This may cause placental abruption, this may be seen with proteinuria or a lot of high content of protein in the urine, and they'll have generalized edema. Now, what preeclamptic means, if they're eclamptic, that means they may have seizures. So what our hope is that we protect mom from the risk of seizures. So what kind of medications do we give mom if they are preeclamptic? You guys remember? Say it one more time. Maybe antibiotic, not normally just for the preeclampsia alone. The first is we'll try to treat the high blood pressure, so we'll give antihypertensives. But what's really good for neuroprotection for both mom and baby is magnesium. So if they receive mag, what effect might that have on the baby? Apnea, it can cause a really floppy baby. So another question we ask, if we know that when you ask about the risk factors and they say mom is preeclamptic, the second follow-up question is, when did they last receive MAG? Because if it's within 2 hours of that delivery, we can expect that baby might come out a little sleepy and a little floppy, and even if they're completely normally healthy, you would prepare yourself that they may even have to be intubated for a short period of time, but hopefully with enough vigorous stimulation, they can be supported, and if they do need support, either with oxygen or NIV alone, or CPAP alone. So yes, and so preeclampsia is common and can cause many complications for the baby and mom, and if these are not treated, can lead to severe issues that necessitates preterm delivery to both protect baby and mom. But, it's not just preterm deliveries that pose a risk, also post-term also can inherently create more risk for baby and mom. So these babies, because they're growing longer in utero, tend to be LGA or large for their gestational age. So this can cause a lot of trauma during the delivery itself. So you're gonna see some obstetric OB trauma, so that you're gonna have vaginal or cervical lacerations. You might see shoulder dystocia, and that is when the baby's starting to come through the birth canal and their head passes and their shoulder is actually stuck behind the mother's pubic bone. In a few institutions where I worked, you would hear all the alarms and they would do a code McRoberts. And we know in that moment we have seconds to get to the room to help facilitate the rest of getting the baby out. And the reason we, at least in the institution, one of the institutions I worked at, is because one of the ways that we treat this is called the McRoberts maneuver. And you're gonna bring mom's knees rapidly to their chest, and the reason is you wanna try to flatten that the sacrum to try to create more room for that shoulder to come through. And you actually are going to have to start pushing right above the pubic bone. And of course, there's a lot of risk, and you're very careful to not cause trauma to the baby. And while we're doing that, we're actually gently tracting the baby's head down, very careful not to pull too hard on that head. But you want to get that baby out as soon as possible. And this carries a lot of risk. Of course, there's a risk of nerve damage or fracture to the baby. So this is one of the biggest and scariest emergencies that may occur, that you normally cannot predict. I always say, when we knew when the baby was high risk, we're very prepared for that delivery. We probably know about it at the start of shift or even a week or a month. We're preparing for that. Some of the scariest cases, but why it's so important to have these assessment skills is when it had a very healthy pregnancy, presumed to be a normal delivery, and then when something happens in that last minute, you have seconds to respond with your NICU resuscitation team. Because the baby is in utero for longer than expected, you might start to see some placental insufficiency. And this is when the placenta is going to start to fail to deliver enough oxygen or nutrients to the baby, and we need to start getting that baby out. And what else happened is now if we have meconium-stained fluid, because the baby is a little bit older, what happens in utero? They actually pass their first stool. And that could be caused by intrauterine stress, but because they pass their first stool and because there's a little bit of stress, it's in the amniotic fluid, and then they breathe it in. And because there's increased stress, they might actually take additional breaths and get the meconium actually deeper into their lungs. Now, what effect does meconium have on surfactant? It deactivates it, right? And why do we want surfactant in our lungs? Reduces surface tension, which means if you don't have surfactant, your lungs are going to be really stiff, and they're not going to be able to expand. They're not going to be recruited for effective gas exchange. So now you have a baby who is born, whose lungs are going to collapse. They're not going to be able to oxygenate. And if they're hypoxic, what effect does that have on your pulmonary arteries? Yep. It's going to cause your PVR to go really high, and you're going to have what's known as a hypoxic-driven pulmonary hypertension. So for these babies with meconium aspiration, if it's severe, you may have to prepare. Hopefully, if it's mild, they'll be able to be fine, but if they're severe, they may end up needing nitric, maybe even on an oscillator to help them resolve that. And as I mentioned, knowing the gestational age and knowing what stage of fetal lung development is really critical for us as RTs. So I know we all remember this from school, but I think it's really important to remember what are the stages. So first, as a baby begins growing in the first trimester, this is when you have the embryonic and pseudoglandular stages. This is when your trachea and your esophagus first begin to form into separate tubes. You're going to start to see the very early starting of the bronchial tree, and airway branching starts to occur. And then we're going to get into the canalicular phase. That is between the weeks of 16 to 24. And in this stage, you're going to start seeing more terminal and respiratory bronchioles start to multiply, so that branching becomes more robust. You're going to begin forming these outpouchings that will eventually become alveoli. They're not alveoli yet, but they're going to have these little pouches. But the most important thing is that you're going to start having differentiation of your epithelial cells. And they're going to differentiate into type 1 and type 2. Why is that important? What do type 1 epithelial cells become? The type 1 is going to start becoming your alveolar capillary membrane. So it's going to start creating that blood barrier when the alveoli and your capillaries are going to do gas exchange. Your type 2 are going to become what? Surfactant, yes. So it is in the stage that you first start producing the cells that are going to eventually be able to produce surfactant, which we know is a major and important hallmark in development to allow for the survival of the baby. And then when you get to saccular, this is going to be around 24 weeks to birth. And this is when you get your first primitive alveoli. So those outpouchings then first to form those first alveoli, and your first development of premature surfactant. So this is why early on, 24 weeks seems to be the earliest viability. It's because when you first start producing the earliest surfactant and getting the earliest form of alveoli, although as I mentioned, our viability and many NICUs in the States are now still resuscitating. We're seeing as low as 21 weeks. But you just have to be aware and understand if they're born before 24 weeks, you have to take a different approach because they have not yet produced those cells to produce surfactant and do not have alveoli yet. And the saccular stage is also we're going to start forming your capillary network again, which will support the your gas exchange. So if you were asked on a test, what happens during the saccular stage of fetal formation, what is the most important thing you think that happens during the saccular stage? Surfactant. Good. And then later, starting around 27, 28 weeks until they are born, this is the rest of your fetal lung development. This is when you get more mature alveoli. Now you have mature surfactant. And, alveoli actually continue to grow and multiply until they're 8 years old. That's how risky it is to be born prematurely, because even when they're born full birth, they still do not have all the alveoli to support them, and throughout the first part of their adolescence, their lungs are still going to develop. True alveoli will develop around 32 to 34 weeks. So that's another stage. You have a different frame of mind. If it's 21 to 24 weeks, 21 to 26, I have a different mindset. I know they haven't formed that. Then 26 to 32, I'm kind of worried about, we know we're going to have to support them. And after 32 weeks, you know that they hopefully have, they don't have the quite number of alveoli, but they've started forming that. And even if they're born beforehand, this is why we like to keep CPAP or some kind of non-invasive positive pressure at least until 32 weeks, because we know that their alveoli are still developing, and we want to stabilize, help make sure their lungs are recruited to support them so they don't use all of their energy as they're growing through that, trying to expend it on breathing. So in many NICUs, our practice is to keep them on some kind of support, even if they're comfortable, if they're born in the NICU, until at least 32 weeks when we know this is occurring. And so as I mentioned, the most common and the largest population of infants that are admitted to the NICU is because of respiratory distress, for all the reasons we just mentioned. So the difficult part of us to figure out is Is this because of a respiratory or pulmonary problem? Because that will lead to a whole set of conditions that we have to treat. Or is this because of a non-pulmonary issue? Is it cardiac? Is it neurological? And then that will lead to a different path. So important is knowing almost every patient you're going to see is going to have respiratory distress, and our job is to figure out why. So TTN, or transient tachypnea of the newborn. It affects some patients who are born preterm, and a lot of times it's a late or late preterm patients. The most common risk factor is if they are born via C-section. Because as it turns out, your natural birth and going through the birth canal actually plays several important roles, but one of them is squeezing of that chest wall to get rid of all of that fluid. So if you remember, in utero, the blood flow bypasses the baby's lungs. You have really high PVR, and the lungs are otherwise just fluid-filled. As they begin to transition to infant circulation, the last big thing is they get a big squeeze, get all the fluid out into the lymphatic system, and then once they're born, they take that big breath, and then the PaO2 is going to reduce the pulmonary artery pressure, it's going to reduce their pulmonary hypertension, close those ducts. That is what's normally part of it. But if they don't have that squeeze, some of that fluid can remain in the lungs, and that causes them to have some respiratory distress. There is some recent studies that show it also may result from some factor of surfactant deficiency or dysfunction, or both. And again, the biggest risk factors are C-section without the active labor, if they're preterm or late term, and if they were stressed. And the nice thing is, so this is the baby that otherwise looks fairly healthy. There are no other risk factors except they're probably breathing up to 120 times a minute. Has anyone ever cared for a patient with TTN? Yeah. Good. So they look comfortable except they're breathing so fast. And so the good thing is that it's typically self-resolvable as they begin to develop and their lungs begin to clear. In my experience, it's mostly been able to resolve with maybe some oxygen. At some points, we may have escalated to CPAP. Very rarely have I needed to intubate these patients. And then you otherwise want to support them as we do with all babies, which is thermal regulation, fluid management, and you're just allowing them to get through this transitioning year period as they clear that fluid from their lungs. Now, the X-ray, what you will find is that there's diffuse haziness, streakiness, and in both lung fields. What you will not find, you won't expect to see any lobar consolidation or anything like that. Again, this is just diffuse fluid that's still in the lungs that needs to be cleared. RDS, this is our bread and butter as NICU RTs. And it is probably one of the most common morbidities that occur because of preterm delivery. And the reason for that is that RDS is simply a result of surfactant deficiency, which creates a lot of the issues that we see when the baby is born. So we know that it is of highest risk before 28 weeks because until that point, they have not really had mature surfactant production. Their alveoli haven't really formed. It reduces to, if they're older than 32 weeks, which is why this is less of a risk, to a much lower likelihood. They're still premature. We should still be concerned about supporting them from a respiratory standpoint if they're born between 32 and 36 weeks. And premature infants are highest risk of respiratory failure because of their surfactant deficiency. Again, their lungs are not going to be compliant. They're going to have high surface tension and they're going to collapse. They're not going to be able to recruit and effectively exchange gas. So what happens is when you're born prematurely, not only do you have structural immaturity of the lungs, you don't have the very complex nature of your alveoli, but the inactivation deficiency of surfactant is going to make you very prone to alveolar collapse, decreased pulmonary compliance, a low FRC. And we know that when we have all those things, your PVR is high, so you're going to have a high likelihood of pulmonary hypertension. And with these patients, you take all of those altered lung mechanics, so very stiff, very immature lungs, and you intubate and put positive pressure, what's likely to happen? you're going to increase the risk of all of that ventilator-induced lung injury. These lungs are so delicate and so at high risk of barotrauma, edelik trauma, volute trauma. And when you have that shear stress opening and closing and that cyclic stress, that's going to cause an inflammatory cascade, an entire response that can eventually become chronic lung disease, which is BPD. Thankfully, again, over the last decade, we really understand so much more about how to take care of these patients that I think our ventilator management strategies have improved. We actually moved to intubate less and intubate only when absolutely necessary. It's even strange for me to be walking around our NICU and see several of our severely premature infants just breathing along on CPAP, because when I started my career 15 years ago, almost everyone was intubating their NICU. But we've learned so much to only use intubation when absolutely necessary, to support from non-invasively, and to extubate early, because the risk of positive pressure invasive ventilation can induce so much risk for the development of BPD. I just mentioned this. So again, the biggest issue and what becomes BPD, what makes RDS become BPD is caused by the immature surfactant in the lungs. And again, because your lungs are very collapsible and you have that compliant chest wall, it's hard for your lungs to stay open and for your chest to stay expanded. They are at very high risk of pulmonary hypertension for all of the reasons I just mentioned. They have a lower FRC. You're going to have some areas of overexpansion. You're going to have some areas where they're atelectatic, and so you're going to have some VQ mismatching. This is going to cause low oxygen. This is going to cause high CO2, which is going to lead to respiratory acidosis, which further constricts your pulmonary arteries and further constricts your pulmonary blood flow, and then is going to create that right to left shunting that we see in pulmonary hypertension. In their clinical presentation, and this is going to be true of any infant that presents with respiratory distress. So the first sign of respiratory distress in an infant, and it's a little different from adults, right? When adults are feeling a lot of respiratory distress, what do? To augment their minute ventilation, what will they end up doing? What kind of breaths do they take? Right? They take low, but they really try to augment their tidal volume. With infants, especially premature infants, their anatomy is a little different. Their ribs are actually much more horizontal, and their lungs are really stiff, and their chest walls are compliant. So they can't effectively get bigger breaths. So instead of breathing bigger, they actually start to breathe really fast. So that's why tachypnea is actually one of the first signs that we see, because that's the first thing a baby's going to do to try to overcome any of their distress. Then they will start grunting. And that's a sound when they're breathing, you might hear a and sometimes I know the parents, and they're in the room, they're like, oh, it's so cute, can I get it? I'm like, no, it's not that cute. And what do we end up wanting to do? If they're grunting, that's actually them trying to close their glottis on their own to try to trap their own intrathoracic PEEP. It's them telling you, help, I need help, my lungs are collapsing, I'm trying to save some pressure in my lungs, so they're actually asking you for some CPAP. We're like, yeah, very, very cute. And then we put the CPAP on and help them through that. They're going to see nasal flaring. When we nasal flare, that's actually our body's way to increase the diameter of our nose to allow for more laminar flow, to hopefully get more of that oxygen. You're going to start seeing, Dana mentioned, those retractions, which are really prominent and really easy to see, especially in our premature infants. And they may actually just have some periods of apnea. The X-ray here, there are a few key findings. The first are you're going to have this diffuse, granular appearance, and you're going to have air bronchograms. And air bronchograms, when you look at it, is when you can actually see the branching of the airways. Why can we see that in RDS? What color would we expect it to be? So if you're looking at an X-ray and you expect your airways to have air in it, right? So what color should your airways be? Black. That is what we see. And then you should also hopefully expect your lungs to be filled with air. So the lung field should also be black. So on a normal X-ray, you have your translucent airways. So you have your black airways against your black lung fields. You shouldn't be able to see airways. What happens here is that at some point, when your alveoli start to become filled with fluid, and they now have some consolidation. What color do they become? White. So now you have your air-filled, your black air-filled bronchioles against a white, opaque consolidation, and that's what becomes of air bronchograms. So if you can see air bronchograms, the first thing you should think of is there's some kind of consolidation or fluid in the lungs. And the treatment, again, it's going to depend on your patient. We've really moved away from prophylactic and keeping them intubated. We were really scared to see little tiny 26, 28 weekers breathing without a tube. Now it's become a norm because, again, we're trying to minimize the risk of ventilator-induced lung injury, which can become BPD. And so what we want to do is in the delivery, we often do early application of CPAP. So as they're starting to take their first breaths, you can start to expand the lungs, help to get them to recruit, and help the baby as they transition from fetal circulation to infant circulation. And then only apply these escalation if the patient is absolutely necessary. And we're going to talk about it in our session. If you have a need for surfactant, although there's less invasive ways now, that used to be the only reason we would intubate, which was we would, if they were fine, but we knew because of their fetal development they needed surfactant, we would intubate, give the surfactant, and then extubate and keep them on non-invasive. But the goal of the game is a non-invasive when possible, only intubate when absolutely necessary, and if they are intubated, extubate early. We talked a bit about meconium. So again, meconium is just a dark green substance of their first stool, and it's made up of intestinal epithelial cells, lanugo, and mucus, which is usually passed within the first 48 hours after their birth, but it's passed in utero. And because of stress, the baby then inhales it, and then it could become very deep into their alveoli. And I won't repeat this because we've talked about it a bit, but what I have not mentioned is what happens, another thing that happens when you aspirate and when you have meconium in your lungs is it can create that ball valve effect. And what that means is it's going to be in your airways and it's going to make your lungs really stiff, so air is not going to be able to get out. But then as the baby tries to exhale, they're also not going to be able to exhale. And so you have an issue with both restriction and obstruction. And so what it's going to cause is you're going to have some areas of hyperinflation next to some areas of atelectasis, and that becomes very, very difficult to manage as we are taking care of them. The meconium, other than surfactant inactivation, is also going to cause inflammation, secretions, chemical pneumonitis, and cause many issues for the baby. The X-ray, again, you're going to have all this in the lungs. You're going to see patchy infiltrates, nodular opacities, and again, like I mentioned, some areas with hyperinflation right next to some areas of atelectasis, which is going to cause a lot of VQ mismatch and cause the hypoxia and pulmonary hypertension that we end up seeing. Oh, I do want to mention, let me see if I can go back here. When I first started in my career, our strategy was to not, the strategy was if they were non-vigorous, we didn't want them to take a deep breath in to get the meconium deeper. So if they were non-vigorous, it was do not touch the baby. We would intubate and put a meconium aspirator and remove it. And that was a hallmark of NRP. And since then, I'm going to say maybe 10, 15 years, we've really changed the recommendations. Because if you were ever in that situation, it was the worst 2 minutes of your life. You're staring at a baby and you're told, don't touch them because if they breathe, it's going to go deeper. And what they actually found was that there was not any improved outcomes, and that going that long without oxygen to the baby's brain actually had some adverse effects. And they actually said, if they already aspirated it, it's probably already deep in the lungs. So waiting to not let them take that deeper breath isn't really going to change the impact of it. So now it's treated as with all other normal deliveries. Even if you know it's meconium, if they're vigorous, if they're otherwise normal, you would dry stimulate and take care. If they're non-vigorous, go through your NRP algorithm and intubate if necessary if the algorithm takes you to. So I think that that's a big change and what we've seen in the development of that. CDH, probably I think it's one of the scariest, especially if it's undiagnosed. It's one of the hardest differential diagnoses to make in the delivery room as you're trying to figure out what's going on. But what happens with CDH is that in utero, that muscle, we know that our diaphragm is a muscle that separates your chest from the abdomen. So when you do that, you have a nice separation of your lungs up here and then your abdominal contents. But when the diaphragm does not form completely in utero, this allows your abdominal organs, so your stomach, your intestines, or your liver, to actually move into the chest. And when all these abdominal organs are now in your chest, they're going to crowd your heart and your lungs, and they're going to inhibit that normal fetal lung delivery. And what that can cause, this is going to cause very extreme pulmonary hypoplasia, because they're compressing on those structures, and it actually may cause, may compress the pulmonary artery itself. So you might also have some iatrogenic or actual physical compression causing that pulmonary hypertension. So, and this is really, and the diagnosis and the severity is really of when when this failure happened, because if the fetus, because I'll tell you when the lungs started to be compressed and how developed they are. So this is the biggest issue. Again, is pulmonary hypoplasia. You have compression. You have very severe pulmonary hypertension. And what you will see on the X-ray is you will see all of you'll see the intestinal herniation, and you'll see those abdominal contents in the chest. You'll see very little lung fields for your lungs. And the important thing is the immediate resuscitation. So if you know that a baby is coming in and you know that it's a CDH, what do you want to do immediately after birth? Do you want to bag mask them? No, right? Because what will happen if I'm bag masking a baby? Where there's a high likelihood of that pressure? Where will it go? Into your stomach. So you're trying to bag the baby. And a lot of that is going to have some gastric insufflation, and but where is your stomach? It's compressing your lungs, so it's going to worsen that. And when I say that. One of the scariest things is when it's undiagnosed, is because if it's undiagnosed and you're there and you're trying to bag and it's making it worse and you're trying to palpate and you can't really hear lung fields. I remember one time in one delivery, we were going through all of our algorithms, could not figure it out. And then they ended up they thought it was a pneumo. And so when they inserted the chest tube and they actually got intestinal contents out, we said, oh my gosh, and we completely switched our strategy. But it was a completely undiagnosed CDH, a mom who was not receiving prenatal care for us. And though that kind of rapid algorithm of resuscitation and assessment and figuring out what's going on was vital to saving this baby. And when they do, they often will need the oscillator. Again, you have very, very stiff lungs that were not developed because of this herniation. They're very small, so you're going to need that oscillator to help increase that map and give it in a safe way. You're going to want them to be intubated. These patients will have very severe pulmonary hypertension, and you're hoping that these babies are born in a level 4 NICU with surgery immediately available so that they can begin correcting this. Neonatal pneumonia, it is most often affects premature infants, and it's going to occur in about 10% of them. It's the most common bacterial infection over sepsis. It can either be early onset or late onset. Early is usually associated with some kind of general sepsis, perhaps as a result of the birth. Late onset is normally something as a result of prolonged intubation. And so depending on when it occurred, there are many different culprits of bacteria that can cause this, and they are all listed here. And it can also be caused by a virus. The diagnosis will be very similar to how we diagnose pneumonia in pediatrics and adults. It's going to be confirmed by the X-ray, and you'll see that the consolidation there. You also can get blood cultures, and you can get tracheal aspirate, because when you prescribe the antibiotics, you want to make sure it's targeted to the bug that's causing, the very specific bug that's causing the sickness. On your X-ray, you're going to see the diffuse local infiltrates, hazy and opaque lung fields, and again, that lobar consolidation that we see with pneumonia. And treatment, other than the antibiotics, is going to be dependent on the baby. It can go anywhere from oxygen support all the way up to ventilation. A pneumothorax, again, air leaks are can be common in our NICU, again, because you are taking very stiff lungs with immature surfactant, and they're very fragile. If you're giving them large amounts of positive pressure ventilation, that can increase the risk of popping the balloon, of air leak entering the pleural space and causing challenges. So a pneumothorax will occur as a result of alveolar overdistension and rupture. Your air is going to escape into the extra-alveolar spaces where it should not be. It can be caused iatrogenically, which is just excessive pressure during the resuscitation or the assisted ventilation. It can happen spontaneously just because of that uneven distribution of gas at birth. Sometimes when the baby is just spontaneously breathing, they may breathe in a way, they may rupture an alveoli. Or it could be secondary due to an insult like meconium aspiration or a CDH. And early detection and treatment is critical. Again, when you notice that you're only having unilateral chest rise, unilateral breath sounds, which I will tell you is often challenging in premature infants because of how small their chest walls are. Sometimes it's difficult to notice the difference, or you might think you hear breath sounds because the air it's transferring. So you have to look at your other forms of assessment as well, of like high peak pressures on the vent, if there's a sudden rapid decompensation that can't be explained by anything else. Of course, you will see it on an X-ray, but you want to be able to diagnose it and identify it quickly so you can treat it. The X-ray, you will see the loss of lung markings where they used to be, the collapse of the lung tissue. You'll see that border there with no lung markings of free black air, which is going to show where the pneumothorax is. And the primary treatment is an insertion of a chest tube to be able to release that, or thoracentesis. Persistent pulmonary hypertension, which again is a result of something happening in the process that the baby did not successfully go from the fetal lung circulation to what we expect for the infant circulation. And so just as a reminder of what I'm talking about, so again, in utero, the circulation bypasses the baby's lungs, right? So the baby's lungs are filled with fluid. They have really high PVR, really high pulmonary hypertension, and we intentionally shunt it past the PDA and the foramen of valley because all of the oxygenation and ventilation is going to occur from mom and come over by the placenta, so that you don't need to use the baby's lungs. But what happens at birth is that first big birth, we clamp the cord, and then that baby takes that first big breath, and that's what creates that huge transition that is the focus of NRP. So that first big breath, the lungs are going to begin to open, that fluid is going to start to get absorbed, your PaO2 is going to increase, which is going to cause your pulmonary vessels to dilate, and this happens slowly over time, right? So we're watching the baby breathe, and as they do, you should see your sats slowly rise as this transition is happening. And as your pulmonary vessels dilate, your PVR is going to drop, which is going to cause a significant reduction in your pulmonary pressures. Your SVR is going to increase, and that pressure shift is going to shut that PDA. When that happens, there's going to be an increase of pressure in the left atrium of the heart. The right atrium is going to decrease, and that's going to shut that foramen ovale. And then with that closure, now it's going into regular lung circulation, and they're going out through the pulmonary arteries and oxygenating, and that's how they transition. If something happens and that does not happen correctly, or those shunts don't close in the way that they do, that can create and lead to the baby having persistent pulmonary hypertension even after birth. And the biggest ways to diagnose it, again, a big difference. Usually we call it for more than 10% of a difference between your preductal, which can be on your right hand or on your forehead. Any preductal sat will be higher, at least 10% higher than a postductal sat. And what that means is that you're having some deoxygenated blood that did not go through the pulmonary arteries, perfusing some of your organs. The risk factors for pulmonary hypertension are if they're male, if they're born via C-section, usually before 37 or after 41 weeks of age, or if they're small or large for their gestational age. And again, those clinical symptoms are what I just mentioned. There will be hypoxic. You'll see differences in your pre and postductal postductal SATs. And the confirmatory echo, the confirmatory way to diagnose is through a formal echocardiography. And one of the first ways, if we can manage it, is oxygen, because we know oxygen is an effective pulmonary vasodilator. You may also, if these patients have any issues with lung recruitment, we know that your PVR is lowest when you're actually expanded to your optimal FRC, so you may have to use a ventilator if you need help recruiting the lungs. And of course, for severe cases, inhaled nitric oxide is the gold standard, and it's a very selective and potent pulmonary vasodilator for the treatment of pulmonary hypertension. And BPD, which is the most common chronic lung disease. And when we're treating our patients who are born prematurely with RDS, if we are not careful with the way that we are managing the ventilator, and we're not doing our, if they have exposed risk to ventilator-induced lung injury, it can create and lead to the chronic lung changes that become BPD. So this is the most common form of chronic lung disease in the infant population. Again, affecting our babies largely who are born between 22 to 28 weeks. And this is because the lung development is affected when they're born prematurely. So they are also highly, they may be more susceptible to having issues with hyperoxia, and that leading to risks of ROP. So the postnatal hyperoxia exposure, even if we're using high levels of oxygen, it increases the production of cytotoxic oxygen-free radicals. It's going to lower their levels of antioxidants. And if they have both of those issues, it's going to increase their vulnerability to oxygen toxicity, which may later present as ROP. So we always want to be mindful of your oxygen delivery and give the lowest possible, and we actually have lower saturation goals for these patients to limit that risk. The classifications, there are new classifications that I will not, and I believe they're in your book, but there are different points. We do assess if they were born less than 32 weeks, we have a timestamp, and there's a different definition if they're more than 32 weeks. But what we're really looking at is if they have been treated with oxygen for at least 28 days, we will label them with some kind of BPD at this time of assessment. And then mild will be, some of those babies have 28 days of oxygen, but then they're on room air at the time of assessment, so it's just mild. If they have a need for oxygen at less than 30%, that they will be, we consider that moderate, and anything greater than 30% or needing some form of NIV or trach and positive pressure will place them at severe BPD. The diagnosis is mostly clinical. Again, knowing the history and knowing the assessment.
1 minute.
Thank you. We'll be able to diagnose it. You'll see it on your chest X-ray. And the chest X-ray, again, you're going to see some areas of hyperinflation, multiple coarse densities, which will extend to the periphery. And again, the diagnosis will be made all together with your knowledge of their clinical course, plus all of your assessment with the X-ray, which will let you know, which will tell you and confirm that it's BPD. And the management is preventing, there are different vent management strategies, which I will not cover today, of when a patient ends up with severe BPD on a ventilator. There is some evidence to show that bronchodilator therapy and corticosteroids are important for their care. And also, as with always, we're looking at their fluid management, control of infection, as we prepare these babies to go home. And I'm happy to say that we do have improved our clinical practice over the last several years. Over the last decade, while the incidence hasn't changed, our outcomes and their morbidity has greatly improved with improving of our care while they're in the NICU. Here are all the key concepts. I will not repeat them today, but again, reviewing this is so important in the NICU to really augment the role that you play as a critical care practitioner who are caring for these vital patients. Thank you.
Thank you, Emily, for the great and interactive presentation, and we hope to see you again since this is your first time here. And now we will go to the third speaker of the first session of today, Dr. Jiang, and she will talking about the respiratory intensive care of a neonate. Please, let's us welcome her.
Well, thank you for the invitation to be here. This is, again, same as Emily, it's my first time in the kingdom, and I'm really thrilled to be here. I have a background of training and also practice, both in China and America, so kind of a complex background, but I've been at Children's Hospital Philadelphia I trained there and worked there for more than 20 years. And then back in 2018, I took a position in China and managing one of the largest NICU in China now with 4 units. So I have to say, being trained and practicing in the United States, I'm so used to working with fantastic RTs. And then when I first moved back to China, there was no RT. And I managed to hire 4 of RTs, 1 for each of my unit, over the last 6 years. And that's all I could achieve. And I'm so glad to see all of you here and hear that in this kingdom, you're actually very active in clinical care. So this chapter that I wrote for our training course is about neonates, the intensive respiratory care of neonates. And Emily has already talked about a lot of the diseases in the neonates, and so it's kind of laid down a very good background. Let me see how to advance this. Okay. So the objective of this talk is basically, I think the key thing is actually understand the difference between neonates and adults and also children. So Dana actually talked about children are not small adults. I have to add to that. Neonates are not small children. Okay, especially our preterm neonates. They're definitely not small children. And when we take care of these kids, they are so much more vulnerable. They're fragile. But at the same time, they're very resilient, right? I was talking to Ahmad this morning that you guys routinely resuscitate 24-weekers. It's the same in America and in China now. And Emily said you can go down to 21 weeks. So in China, the smallest baby survived was 21 weeks and 6 days without BPD, without major complications at all. But then at the same time, I'm seeing so many bad BPDs, both in America and in China. I think it's mainly because of the care we provide. They're so resilient. We're so good at saving their lives. However, we're not so good at saving their lives, at the same time not bringing any damage to them. So now I'm seeing a lot of severe BPD kids, and their life and their family's life, it's so hard, right? So hopefully through these talks, you guys can have a better appreciation of the specialty of this, of our neonatology and what we need to pay attention to. So we talk about several things in this chapter. One is the pulmonary mechanics of the neonates. Actually, Dana already mentioned some. And one of the emphasis for respiratory care, for our neonatal respiratory care, is to protect the lungs, right? Because they are fragile and you can bring lung injury easily. And we can talk about the different modalities of the respiratory support in neonates and how do we assess and monitor in neonates and the management of the common diseases. But Emily already talked about that, so it's actually saved a lot of my time. And towards the end of this chapter, we talk about transport and discharge of these kids. And actually, I think that's the RTs play a very important role in these aspects of care. So let's start with our pulmonary mechanics. I think one of the key things that people need to remember when you take care of neonates is that we're just not mature. I tell when I consult the preemies parents, I was like, your baby is basically not mature from head to toe. Okay, but then more importantly is their brain control for breathing is not mature. And that's why we have apnea prematurity. It's a unique disease of the premature babies. But in addition to that, our peripheral chemoreceptors are also not mature. And that actually brings the issue of the carotid body that responds to hypoxia, like hypoxemia, is not that mature. Have you seen a baby with sudden infant death? Okay. We don't know exact mechanism, what exactly caused it. However, one of the theory is the immaturity of the breathing control for these babies, that making them prone to sudden infant death. With that, these babies can have irregular breathing, that really prone to periodic breathing or apnea. In addition to that, I think Donna already talked about that our chest wall and respiratory muscles that are just not as the same as bigger children and adults. The baby's chest wall, even their term babies, is very, very compliant. But when you talk about compliance, we all think compliant is good, right? But here, when your chest wall is so compliant, you don't keep your FRC. So these lungs are prone to be collapsed. And at the same time, our respiratory muscles are not the same as older children and adults. First of all, these babies don't have enough of the type 1 fibers that the respiratory muscle of our preemies and neonates are prone to fatigue. So if they are in respiratory distress for a prolonged time, they're fatigued. And that's why sometimes before you extubate a baby, some people try to see, okay, can they breathe on their own, right? They took out the ventilator support and let them breathe on their own with the ET tube. When you do that for too long of a time, they become tired. And then they fail extubation because they're tired, okay? And also, our neonates breathe primarily with the diaphragm as the main breathing muscle. So the movement of diaphragm extremely important for these babies, not the intercostal muscles. When these babies are into respiratory distress, now they bring in all the accessory muscles to breathe. But the diaphragm, whether the diaphragm is able to move and move easily, that's very important. Emily already talked about the development of the lungs, right? So I won't repeat that. But think about when you take care of a baby that's born at 24 weeks of gestation, that baby is basically either at the end of cunnicular phase or the beginning of the saccular phase. What does that mean? Does the baby have alveoli? Not really. May have a few if it's really towards the beginning of saccular phase. But mainly what the baby has is the terminal bronchi. The terminal bronchi can have respiratory, like breathing gas exchange capacity, but they're not very good. Luckily, these babies don't require much either at birth. That's why sometimes you don't even need to intubate a 24-weeker, that they actually can breathe on their own, and they can do gas exchange, right? But when we talk about the development of your lungs, we also have to remember, in the chest, the respiratory system is not only the lung. You also have a respiratory tree. It branches out like a tree, right? So from the main trachea to bronchus to the smaller bronchus, right? And then to the terminal bronchi. Now, these structure is actually all developed even for a 23-weeker at birth. It's all there. The problem is it's not mature. Okay, so over the time, especially over the first 2 years of life, both the lung alveoli will grow, the lung become more mature, but at the same time, your airway also remodels, the size increase, the length of the airway increase, and the histology and morphology also changes with your airway. Why do I talk about this? If we only think about a baby breathing in terms of the alveoli, that's not it, right? That's not all. The air has to go in from your airway to the alveoli, do the gas exchange, and then has to come out. Okay? So that airway is actually very important. And the airway function actually affects your ventilation quite a bit. If you're, because of our preemies, well, even the term baby, their airway is smaller compared to the children and adults, and the airway is more compliant. It's being affected by other things a lot more than adult and children, okay? Because these airways are so compliant, and they start off with a small size. I'm sure when you guys learn, oops, I'm sorry. How do I go back? Oops. I'm sure when you guys, this is learning respiratory physiology, you all learned this, right? The diameter of your airway is extremely important. So let's say the airway is narrowed for even 1 millimeter in diameter, okay? Then your airway resistance actually increased 16 times. Compared to an adult, it increased about 3 times. This is why we need to keep this in mind. For a baby, when we intubate, we need to try to intubate with the appropriate size of ET tube. Okay, we're so worried about not damaging the airway. So some people tend to put in smaller ET tubes when they intubate so that the intubation is easier. You tend not to damage the upper airway when you're trying, or the subglottic area when you're trying to intubate. However, when you put a smaller size tube, it actually increases your airway resistance by a lot, right? So when we try to determine what is the appropriate size of ET tube, we go by a weight, we estimate, but then you will see clinically, some of the baby would have a leak, some baby have absolutely no leak with same size of ET tube. They may be the same birth weight, right? So you have to think about, okay, I need to put in the largest size tube as safe as possible, right? So it cannot be too large that you can damage your airway, but it needs to be large enough so that your airway resistance is not increased so much. On the other hand, if a baby gets infected, okay, let's say a 3-month-old come in with RSV. What happens for those kinds of kids? When you get a viral infection, their symptom is tons of secretions, right? And that secretion can make the airway even more narrower. Or the edema from the viral infection causing the airway edema, that will make sure your airway diameter is much smaller, right? And with that, your airway resistance is much higher. So that's why these babies with a viral infection like RSV, they're more prone to respiratory distress. They may have more severe respiratory distress than adults. We all get RSV infection. We don't even know about it, right? First of all, we don't test for it. And second, if we get an RSV infection, it's just a common cold. It's not a big deal. But it can be a huge deal for neonates, especially for a preemie. And again, when we talk about the lungs, we pay a lot of attention about the lung function. And our premature lung, like I said before, if you're in the earlier saccular phase, you can have some gas exchange capacity, but because they don't even have much of alveoli, your alveoli surface area is much less. Do you guys know the lung surface area, how big it can be? It's like a football field, okay, for adults. It's that huge. But for our preemie babies, they don't have alveoli to begin with, okay? Their surface area is much more reduced. And also, when we think about how the alveoli develops, it first develops when you start to have the septation, to have the pouches, and then the capillaries comes in. It's initially a double layer capillary structure. And then over time, it fuses in a thin layer. So the mature lung actually, alongside your alveoli, you have one thin layer of capillary bed. So the diffusion distance of the gas is much shorter. But for our preemies, because they don't have mature alveoli, that diffusion distance is much longer. Okay, so you don't have enough surface area, and the gas diffusion distance is much longer. Think how hard it is for these kids to breathe. Okay, so you have to respect them. For a 24-weeker come out crying, it's a lot of effort for them. And in addition, they don't have enough surfactant. Okay, you guys, in the previous lecture, you already talked about what surfactant does. Okay, now when you don't have enough surfactant, what happened in the real time? The bigger airway, the bigger sacs tend to be bigger. The smaller sacs tend to be smaller, right? Because the surface tension is not equal. And these babies, it's hard to breathe to start with. But then over the time they're in the NICU, how many of you work in the NICU? Quite a bit, okay. The days we take care of them in the NICU, we have to help them out to breathe, right? We give them oxygen, we give them respiratory support, either invasive or non-invasive. They get infected, or they already get infected in utero, right? All these things actually put them at a higher risk of their lungs are not developing, or their lung get injured, right? So with that, some of these babies don't grow well, and they don't grow their lung and airway well. So with that, they end up with something called chronic respiratory insufficiency, and they develop BPD. I started the BPD program at CHOP, Children's Hospital Philadelphia, back in 2010. The reason is that we're a level 4 referral center. Whether we like it or not, we're getting these really, really sick babies coming in with BPD. Oh, they're really bad. But I remember at the same time, I used to go to China to teach once a year, and people let me consult on their BPD kids. I used to laugh at them. It's like, this is not severe BPD. What are you talking about? This is nothing. When I got there in 2018, and now I'm seeing equally bad BPDs, and more than I can see in Philadelphia. This comes with the development of NICU care. But I think the main problem I'm seeing in China is the early postnatal care, starting from the delivery room to the early months of the NICU care. There are lots of things are not doing the right thing. Either not the right respiratory care, too much antibiotics, not enough nutrition. All these actually hinders the lung growth and also bring lung injury. So in Philadelphia, if I have a 29-weeker with really, really bad BPD, a lot of times I have to think about something else. Does this kid has a genetic problem? Is it interstitial lung disease versus really a real BPD? But I'm seeing the classic bad BPD of 29-weeker, 30-weeker in China. I wouldn't double think this is a genetic issue. Most of the time it's actually an early care issue, that they did not do the early care well enough. So that's what we talk about. You need to protect these lungs while supporting their growth. And how do we support these lung growth, right? How do we protect these lungs from injury? We all know oxygen is good and bad, right? When you look at the history of neonatology, when oxygen is first discovered, it used like 100% oxygen for everyone, right? And then you start to hear retinopathy of prematurity, basically, problem, oxygen damage for retina damage, right? There is it used to called retrolental dysplasia, I think. And there was a book written about that. And there was a very famous singer in the United States that he was blind because he was exposed to high oxygen when he was a newborn, okay? And then when that happens, people start not using oxygen, and the mortality rate shot up, okay? So it's like this, okay? So oxygen is good and bad. The bad part for oxygen here is the oxygen toxicity, that when you're really using high level of oxygen, it has free radical damage to the lung. On the other hand, when we try to support these babies' breathing, especially when we intubate these babies and put them on mechanical ventilation, the old days we talk about mechanical, like ventilator-associated lung injury, right? What you hear the most at that time is pressure injury, okay? People are so worried about too much of pressure in the lung and cause pressure injury. But see on these slides, I didn't even talk about barotrauma here. I put volume trauma and atelectal trauma. So nowadays, there are animal studies and human studies supporting the evidence. It's not so much the pressure you put in, it's how you expand the lung. So there's a famous experiment, animal experiment. So they put strap on the animal's chest, okay? And you can pump air into the strap, then you really restrict the expansion of the lung. And then they ventilate these animals with high pressure, but low volume, or high pressure and you can achieve high volume. And what they can see is that it's actually the volume making the most difference. When you give high pressure and you let the lung overexpand, the indications for inflammation and lung injury is much higher than even though you gave high pressure, but you didn't let the lung overexpand, okay? So we talk so much about volume trauma nowadays, and this is why when we ventilate these kids, and when you in Emily's workshop, I think this afternoon you guys are gonna talk about volume guarantee, right? So we want to control the tidal volume that we're giving so that we don't let the lung overexpand. But at the same time, you have to support enough. I think one of the mistakes people make nowadays is that we're so worried about volume trauma, we don't even expand the lung enough. So they're actually atelectic. But when that happens, it also causes injury. It also have inflammation cytokines secreted. So you have both too much of lung expansion, not enough lung expansion actually can cause trauma. And running the BPD service over at CHOP and now over in China, I'm seeing a lot of bad BPDs. And actually, I'm most scared of those babies that was not intubated for months, but they struggle to breathe like this, okay? Over time, they develop really bad pulmonary hypertension. Their lungs are actually not good. When you look at their CT scans, there are lots of lung injury there. Very uneven ventilation because you did not support the baby enough. Both the oxygen toxicity and the ventilation trauma actually cause inflammation, cause cytokine release. And also these babies in our NICU are prone to infection. And all these actually bring in biotrauma. So all these trauma actually go hand in hand. So when we try to protect a baby, it's not so much about, I can't give high pressure, okay? It's about whether you can support the baby adequately, but not over support. So that's the key thing. And when we talk about respiratory support modalities nowadays, we actually, a huge component is non-invasive respiratory support. Years ago, when I started my fellowship in Philadelphia, we basically routinely intubate all the babies less than 27 weeks, most of the time. And we don't extubate them. Even at that time, there is inshore method already. People keep on saying, oh, this baby probably will need a second dose of surfactant. So let me keep until that time. And the next thing you know, this kid has been intubated for 3-4 days and the tube is still in, right? But since that time, there's really fast development of non-invasive respiratory support. And actually, non-invasive respiratory support nowadays actually surpassed intubation, invasive mechanical ventilation in the United States. So most of the baby we actually don't have to intubate, or if even we need to intubate in the beginning, we try to extubate them early. And there are different modes of non-invasive support, and this can be a workshop by itself, right? You can talk about it for days. And then mechanical ventilation, you have conventional ventilation, you have high-frequency ventilation. I heard there's no jet here, so for no jet in China either. But in America, high-frequency has high-frequency oscillation and high-frequency jet ventilation, right? So different kinds. And then ECMO, it's also a form of respiratory support. And you can do VV ECMO, you can do VA ECMO. Any of you have taken care of babies on ECMO? Yeah, some. Okay. So the whole goal for ECMO here is actually not to ventilate these babies with the ventilator. We're using the ECMO circuit to do the gas exchange, right? So the lung can rest and get through that difficult time period. Now, there are lots of studies about what is the best way to support a baby, especially a premature baby, so that they don't get BPD. And this is a very famous meta-analysis published early in 2013. And you can see in this study, there's multiple trials about CPAP use for babies are born premature. And the endpoint, the primary outcome is death or BPD at 36 weeks post-menstrual age. And if you can see, if you really look at the first plot, each study, including some of the very famous trials, like COIN trial, support trial, right? Each of the trials by themselves didn't really show CPAP is that effective. However, when you put these babies all together and do a meta-analysis, you can see a small effect of CPAP by itself compared to intubation at birth to reduce the incidence of death or BPD at 36 weeks post-menstrual age. So this has become the norm in the United States. We try to support them with CPAP. But one of the things I keep on emphasizing in China is that I see extremes. I see people tend to intubate much easier. And actually, last November, the Chinese Neonatal Network had an annual meeting and they reported their data comparing to Canadian Neonatal Network and the Chinese Neonatal Network. The Chinese docs much readily intubate in the delivery room compared to the Canadians, okay? But on the other hand, when the baby come out really crying, they do nothing. They don't give support. Remember what I said at the beginning about our physiology here. The chest wall is too compliant. They tend to collapse their lungs. They tend to not be able to keep their FRC. So even the baby, premature baby come out crying, very active, you need to give CPAP early on. So that positive pressure from the get-go is actually extremely important for these kids. Not only afterwards that in the NICU you need to give CPAP. How about other ways of supporting these kids non-invasively? I know our RTs love high-flow nasal cannula. I'm sure Emily has the same feeling, right? Because it's easy to use, okay? The problem here is that when you look at the trials, this is another meta-analysis comparing high-flow nasal cannula with CPAP. And when you look at using high-flow nasal cannula as the initial support, means when they first born, or if you have to intubate a premature baby and when you try to extubate, whether you put the baby on high frequency, the high flow nasal cannula or CPAP, it looks the same. It seems that the high flow nasal cannula have similar efficacy compared to CPAP. But when you read articles like this, look a little more in detail. What happens here, if you really look in detail, in these trials, very little preemies, less than 28 weeks. Most of them are bigger preemies, okay? So if they're bigger preemies, 29, 30 weeks, CPAP is probably, high flow may be okay. But our experience is the same. In the unit, when we try to put these 24-weekers on high flow, they don't last, okay? There are actually several, I didn't put it in the slides, but there are actually several studies when it also depends on your study design. There's one study doing inferiority design and basically trying to show high flow is not inferior to CPAP, and that's what it showed. But also depends on your margin of what you call is inferior, okay? And in another randomized trial, they actually have to stop early because for very small preemies, high flow does not have the same effect as the CPAP. What about NIPPV? Do you guys like NIPPV better than CPAP here or vice versa? You like NIPPV or you're like the Chinese folks, okay? When you look at this meta-analysis, when you compare extubation failure, reintubation rate, rates of air leak, it seems that NIPPV has a better effect, okay? Now, when you look at the BPD, it doesn't show a difference. So it's about the same. What I find is that, my team in China, no matter what I say, they just love NIPPV. But when you really look at the data, it's synchronized NIPPV seems to be better. And clinically, when you go to the bedside, I'm a clinician. I love to look at babies at bedside, okay? And I think this is one of the problems with the newer generation and new education. We tend to look at numbers and not really observing the baby that much. I have seen over in Philadelphia, a baby on NIPPV actually fighting. Okay, when the baby trying to exhale, the NIPPV, that the machine is trying to give a breath. So that kind of fighting is not gonna be good for their respiratory support, not be good for their gas exchange, okay? So yes, you can use an IPPV, but use it well. When your baby is so agitated and breathing so, against the vent so much, it's probably not gonna work that well. And at that time, maybe a CPAP is actually better. It can calm the baby down a lot better. What truly is effective synchronization is NAVA, right? You can use that well, that's great. And I do see in my Chinese unit, they do have NAVA, and it's especially well when you have babies that are hard to extubate, and you go from invasive NAVA to non-invasive NAVA, they're very comfortable. And your success rate of extubation is much higher. That's totally true. But it's because they synchronize very, very well. And then some of the babies, we have to intubate, no matter what, right? And throughout the world, if you interact with neonatologists from different parts of the world and different countries, they actually have different schools of thoughts. In America, we push so much for non-invasive support to the extent, I think some of them drank the Kool-Aid of non-invasive. They don't look at their babies. I once had to transport a baby with chronic lung disease, 5 months on non-invasive support. When they called us for transport, guess what the status the baby was in? The kid was on NIPPV, 100% oxygen, saturating 70s to 80s, with a PCO2 of 120. And we said, please intubate, okay? They would not. The answer we got is, but intubation is evil. That's the exact word they told me. Because being an attending at CHOP, we need to call our referrals every week. So there are plenty of BPD babies we actually ended up intubating. And this answer I get, not uncommon. It's like, but intubation is evil. How can you intubate the baby? Hey, you need to support the baby enough.
5 minutes, please.
Whoa, okay, I need to really go faster. So with that, you really need to do lung protective ventilation. And if everything fails, go to ECMO, okay? And we have a lot of adjunctive therapies. Oxygen therapy we already talked about. We now know from the large randomized trial, and especially the prospective meta-analysis, new prompt meta-analysis, we know that the saturation target we are shooting for is 90 to 95%. We don't want to go over 95%. We don't want to go too low. Surfactant replacement, now we can do non-invasive or minimum invasive surfactant. And when you try to give surfactant, you can give the thinking is give early if you need to. Nitric, very effective in decreasing hypoxic respiratory failure. However, it's less effective when you try to prevent BPD. And other pharmaceutical treatments really need to balance the risk and benefit. And when we are assessing the respiratory support, whether you gave enough, we'll talk about that in the next section about neonatal resuscitation a little more. And then when you have a baby in the NICU that is stable, but all of a sudden decompensate, DOPE is the mnemonic you want to go by, right? Checking your tube, seeing whether your tube is obstructed or your airway is obstructed, whether you have a pneumo, look at your equipment first, and then think about other reasons. And nowadays, we have, in addition to x-rays, I see some people already use lung ultrasound. It's very popular in China now. And also, transillumination can be an effective tool when you're trying to assess pneumo at the bedside. And when you look at x-ray, I think Emily already talked about that, but this is my approach, A, B, C, D. Okay, so if you go by a sequence, you won't miss things. In addition, we can do blood gas monitoring. However, when you're trying to draw blood all the time from the babies, you get them anemic, and it's stimulants for them. So we now do a lot of transcutaneous CO2 monitoring. The NICU tend not to do untitled CO2 that much simply because it adds too much of dead space. And the NEARS, people start using that to look at cerebral oxygenation. And we can do endoscopic evaluation. And I'm gonna skip this because Emily already talked about all these diseases, okay, in much more detail. Now, when you transport a baby and before you discharge a baby, the RT has a critical role here in terms of making sure these babies are safe in transport, okay? But you have to think about a lot more things. You know, you have to think about factors that, you know, the logistics and what does the baby has, and also the logistics, okay? For example, we transport a baby from another city in China to Guangzhou, 5 hours by high-speed train in the wintertime. We have to change the incubator because the transport company provides an incubator doesn't really have consistent heat, okay? So you have to think about that. You have to think about whether your oxygen cylinder is long enough to support. We have a transport bag, so when you're preparing for neonatal transport, you have to think about what are the essential equipments we need to bring. And here it's essential. So I won't bring a flow inflation bag for transport, but I would use a self-inflation bag, right? And again, you need to think about your cylinder for oxygen. And thinking about making sure the baby is stable during transport from A to I by this sequence. And during transport, pay attention to the breathing, airway breathing. Make sure your airway is patent. It's a critical thing that RT needs to do. And then when we discharge, you need to prepare the family for discharge. And when you discharge a baby, we all have discharge criteria for our NICUs. But then when you're trying to discharge a baby on home oxygen therapy, we tend not to change any support at least 2 weeks before the baby is discharged, because you want to make sure this is the level of support the baby is going to do well. And then you have to assess the family, really anticipate the need, what they need in the family, okay, and also educate the parents really well. And once they're discharged, we need to do multidisciplinary follow-up depending on the baby's needs.
Time.
So these are the key points of this chapter. But I think the bottom line is our preemie is different from a term baby. A term baby is different from a child. And you need to gear towards their physiology and make sure we support them enough, but not too much. Thank you.
Thank you, chairs, very much for your chairing this session. We will see you after. Thank you very much. Dr. Zhang mentioned that she loves to work in the bedside. She loves neonate. So am I. Actually, I met my wife in labor and delivery. Ever since, always my specialty have been neonatal and neonatal specifically in preemies. Now we will go on a break, and please be back at 10:45. Please sharp, come back. There are two very important lectures that will set the stage for your afternoon workshops. Please be back on time. It's very important. Thank you.
Great pleasure to welcome you to our second session for today, Pediatric and Neonatal Respiratory Care. We will continue with the topic Neonatal and Pediatric Resuscitation presented by Professor Zhang. Professor Zhang, welcome again, and the stage is yours.
Okay. I guess people will trickle back in over time. So we're going to talk about in the next section about neonatal and pediatric resuscitation. Before I start, I kind of like to know from the audience here, how many of you have gone through NRP training? I see some hands. And how about PALS? Okay, great. So some of these things we talk about in this chapter, you probably already get familiar with. And what we want to do in this section is basically talk about the initial steps of resuscitation of an infant or a child, and especially talk about the steps of resuscitation of a newborn in the delivery room, because that's something unique to neonatology. And also describe the dynamic of well-functioning resuscitation team. Well, when we talk about resuscitation, we talk about someone that's in trouble, right? They're in cardiopulmonary distress, basically. And we need to help them restore breathing and also circulation with our resuscitation efforts. And these efforts, like how we supposed to do is basically, we go by the international guidelines. Honestly, in the world of neonatology, there's not a whole lot of unified guidelines because the evidence is not that strong. But we do have the international guidelines for neonatal resuscitation, and that's NRP. And then for pediatric resuscitation, we go by PALS, right? That's advanced life support in pediatrics. But all these, the basics is actually BLS, basic life support. And these are developed, all these are developed by American Heart Association and also American Academy of Pediatrics. When we try to resuscitate babies or a child that they're in distress, they're in arrest, we need to use different type of equipment. And how well we can use the equipment make a huge difference, right? And there are lots of equipments that we use commonly. For example, in AmbuBag, we use it for adult, we use it for a child, we also use for a neonate. But size matters here, right? Apparently, you cannot use an adult AmbuBag in a neonate. Okay, that's very straightforward. So we need to choose our device, the correct size, correct type of device when we try to do a good resuscitation effort. Now, one of the most common device that we use in terms of respiratory care is the barrier devices. Now, I don't know whether you have the experience that you walk along the street, somebody just collapsed next to you, and you have to resuscitate someone. When you have nothing, the worst thing, the only thing you can do is probably mouth-to-mouth resuscitation, like you try to blow air directly into the mouth. But I once went to the PAS, Pediatric Academic Society meeting, and there was a booth actually giving out these little cylinders that you can carry in your bag. And that's actually a thin layer of barrier device that you can use on the street. Okay, that's very smart. But then in the hospital, we don't have to do that. We usually have our ventilation masks and other barrier devices that we can use. And this is not only to use so that we can provide the best resuscitation, that give the best pressure and best seal to these when we try to bag a patient, but also to protect ourselves. And the most common type of respiratory support during resuscitation is the bag and valve mask resuscitator. Here, there are two types that we commonly use for pediatric resuscitation. One is flow inflation bag, and one is self-inflation bag. Now, these can be used with or without an oxygen source, okay? But there are differences between these different devices. And in the units, we actually use something called a T-piece resuscitator more than these devices now in the delivery room. But all of these, you need to choose the right size mask. The mask cannot be too big that you cannot create a good seal, and you cannot cover the baby's or the patient's eyes, that's too big. But if it's too small, it also have difficulty creating a good seal. So you need to have a mask that is in the right size for the baby or the child you're trying to resuscitate. And we will talk about that more in the workshop this afternoon. And then sometimes we use these pharyngeal airways. So I tell you a story. One of my colleagues, he was our fellow. And right after he graduated, his first call as a neonatal attending, had a baby born unexpectedly. A baby with teratoma actually growing out of his mouth and nose. And that baby was scheduled to be an exit procedure, means that they use placenta bypass, trying to put an airway in the baby safely, right? But the mom came out in the middle of night unexpectedly. So the baby has to be born without exit procedure. How are you gonna put an airway in? There's no way you can intubate, okay, because things are growing out of the mouth and the nose. So my colleague at the brand new attending actually put in an LMA in this mouse, and so that he could ventilate this baby, okay. So you have all these airways, that artificial airways you can use to help. Now there are pharyngeal airways here that when we have a baby with a big tongue that in the way, we can put a pharyngeal airway there. So you can do oral or nasal pharyngeal airways, but it's very important you use the right size because a wrong size would not fit well. Now when you look at an oral pharyngeal airway, we measure in a way that from the corner of the mouth to your earlobe, right? And you can use these oral pharyngeal airways that in a baby that you want to kind of have more opening in the upper airway, basically push the tongue away. So for these kind of baby, we have a baby like, born with a Pierre Robin sequence, okay? The tongue is obstructive. You can put an oral pharyngeal airway in those kind of baby temporarily. However, if this is a child that is really conscious, this is not something very comfortable. So you really should not use it in a conscious or semi-conscious child. Or you already have injury to the jaw, the mandible or the oral cavity, you would not be able to use that. And you have to size it well. And then you can also use nasopharyngeal airways. And this you can kind of go in through the nose. And again, you have to measure the right size. Now, the most simple way, sometimes you don't have this, right? When we have the nasopharyngeal airway, we can use. But I have times that I don't have this. What I did is just an ET tube. Put an ET tube through the nose, but you don't intubate with that. You put it at the airway opening, trying to use that. But that's not really, sometimes it's not strong enough that it has kinks, that it may not work as well. And then you have advanced airways. You all know that we may need to intubate a baby, that we may need, the example I gave you, my colleague put an LMA in this baby, so that these are advanced airways that are more secure, that can provide better ventilation, okay? Now, there's a difference in the neonates and the and the child. Most of the time, we don't intubate a neonate with a cuff tube. And that's why in the neonatal ventilation world, we don't have true volume ventilation because it has some leaks, okay? However, when the neonates become older, sometimes we have to put a cuff tube in. I do that all the time with my BPD babies. They're now several months old, and they have leaks and it affects their ventilation. Then I may put a cuff tube in. In general, we use uncuffed tubes for neonates up to about 2 months. But in reality, most of the time, by that time, we're not intubated, and you don't need to change the tube into a cup tube. However, if this is a baby with chronic lung disease and continue to be intubated, you might need to put in a cuff tube. And the other type of advanced airway is the LMA I already mentioned, right? Now, this is nice because you don't really need to have very good visualization. Like when you are intubating, you have to see everything, right? This one, like my colleague did, tumor grow out of the mouth and the nose, he can't see a thing. There's no way he can put an ET tube in. Then he slide a LMA in, right? So sometimes you don't even need a very skilled person that able to intubate a baby with, or a child with difficult airway. You can actually put an LMA in. Okay. Now, what we just talked about are the airway support. Now, there are babies with cardiac issues. They have arrhythmias, or they have cardiac arrest, right? Now, what we use in those situations is the external defibrillator. And I'm sure you guys have all used it and seen it, right? Because a lot of public places would have a defibrillator like that, like a simple one, okay? Now, in the hospitals, we all have the hospital-use defibrillators, and that's a required equipment in our NICU or PICU because there are times you have to use it to resuscitate sick infants or children. Now, there is a difference, again, in size, okay? For babies, you may not be able to use the adult size, so you have to go with your baby side, okay? And you can use sticky pads to place on the back and the chest or the back, or you can use paddles, okay? But most of the time when we talk about resuscitating a small preemie, those paddles are too big for them. So you have to choose the right side. And when we talk about resuscitation, we need a team. It's really not a one-person job. Okay, and then the problem here is we go through NRP training, we go through PALS training, we have individual skills. But then when the team is together, you may or may not work very well together. And it also depends in a cold situation, what kind of personnel you have available. And this is why routinely in the NICU or the pediatric ICUs, we do simulations. We try to simulate teamwork. And this good teamwork with effective communication is the key to a success resuscitation. And I tell you another story. I did fellowship at Children's Hospital, Philadelphia, and there were 4 of us in our class. Well, I did 2 fellowships together. One is the regular fellowship, one is the research fellowship. So I graduated half a year later than my class. My last rotation at our preemie unit, my classmate is already an attending. And we kind of take turns. He was attending on the other team. I was the fellow on the second team. And he had a first-year fellow. So one day I went with them for a resuscitation because it was a young fellow, so I went to help. And I watched the team dynamics. I was like, wow, this is terrible. You know what happened? It's because my colleague He was a young attending. He was too nervous. So he wasn't shout out the right command. He wasn't direct to different people. So he wouldn't say, Janet, you do this. He would just shout out, somebody do this. So everybody actually dropped their own job. So some people supposedly put the leads on, some people put the CPAP on. They all dropped what they're doing to accommodate him as the leader. 2 minutes later, nothing was on. Okay, so that's what you have to give direct communication from the leader to the specific individual. And without that, your teamwork it falls apart, and you don't have a specific role. And I have also seen teams during the resuscitation, they get too nervous. They didn't do the closed loop communications. Okay, so the leader said, gave epinephrine, but it wasn't really given. Because on the other hand, and the nurse didn't hear it, and didn't give it, and didn't read back to say, I've given this, right? So when you don't have that kind of good communication, it's gonna be troublesome, and you may not resuscitate effectively. And also, as a leader, sometimes we're too nervous, and I may not noticing something happening around the team. So during that time, team members sharing what they're seeing, that's what's called situation awareness, to the leader and feeding back, that's actually very important. And sometimes also, when we talk, when your team have different people with different skills, sharing your knowledge, but don't just go ahead do whatever you want to do, but share the knowledge with the leader and talk about it. It's important. So at CHOP, we do a lot of simulation for our fellows and residents, and I can see their difference throughout the years. First-year fellow versus third-year fellow, their ability to lead a resuscitation is completely different. And they form a habit in a difficult situation when the resuscitation doesn't go very well. They form a habit of talking out loud. So this is what we have done, this is what's happening, this is what I'm thinking, I'm going to do this because of that. Okay, so then the whole team actually know what you're thinking about, and everything goes more smoothly. So the team dynamics, it's that each team member, you have their own skills, you have your own strength, and you have your own limitations. So you're, as a leader, you really need to know your team member. So if I'm part of the team and my leader put me to give medications, I'm really not very good. I'm not a nurse, right? I can do chest compression very well. I can intubate somebody very well, but I'm not the one giving medications. And vice versa, you cannot put a nurse in a situation that you say a nurse put in an IO, because they're not trained in that, right? And then once your resuscitation is done, we have a habit at CHOP do a in-time debriefing. So any major resuscitation, we do a debriefing right there. And what we talk about is, what did we do well? And what did not go that well? Did we need some equipment that wasn't there? How difficult was it to get that to the team? And then we have a checklist that we go through. Then next time people look at this and they try to get all the supplies in, and we try to improve our system. And then we have another debriefing. Like actually we have monthly debriefing in our NICU for all the codes that didn't go very well, that we go through all the code sheets and with the code team and talk about it, and what can we do better next time. And during the resuscitation, assessment how the baby is doing or how the child is doing is extremely important. And also the assessment, the first thing you need to assess is actually your surroundings. So whether you're in a safe place to resuscitate, okay? And if there's a fire going next to you, you wouldn't want to do a resuscitation right there. If you find that the location is not that safe, then you really need to try to move to a safer place quickly. And then check the response of the child. Now, it's a little harder to check for a baby because it won't talk to you, right? But consciousness, we can still assess. Most of the time, I think you all learned from BLS, you tap on the shoulder, right? Are you okay? Are you okay? Okay. Now, you don't do that in the baby, but you watch whether they have spontaneous movement, whether they have their eye opens, whether they have responses to stimulation. So if somebody trying to put an IV, a baby doesn't even cry or not even blink, that's a bad sign, right? And can they make noise? And the next step is check for breathing and pulse. This is also different in a baby and an older child. So we mostly check brachial pulse in the infant, but for a brand new newborn in the delivery room, we can also palpate the pulse of the umbilical cord. Sometimes it's not that easy, but that's a pulsating cord that it can help you. And this assessment of breathing and pulse should not take more than 10 seconds. And if you don't appreciate the pulse or breathing, then you go ahead, do your CPR. And then the last step here is to check for disability and exposure. So for children, you guys use a lot of different scales, right? I think one of the common scales that people do is the Glasgow Coma Score scale that in the PICU, right? And you will also use other scales. In the neonatal world, we don't use this as often, but then we kind of do assess the severity of the baby and look for signs of shock, decreased consciousness, and look for whether they have trauma, hypoglycemia, seizure, etc. And also exposure is very important to assess, that whether this baby has trauma, any bruising on the body, any rash, all these can be clues to the diagnosis that you can come up what's wrong with the baby causing the arrest. So this is an algorithm that you can go by. This is in the textbook. Basically, the most important thing is to, when you find a child that is not responsive, first call for help. You don't want to do this alone. But then you need to also at the same time try to take care of the child. If the child is not breathing or has no pulse, you need to start CPR as quickly as possible. Now, depending whether you're one person alone or you have somebody else to help you, you're doing the breathing and chest compression in a different way. And this is taught in the PALS. And then assess whether this baby has a shockable rhythm using defibrillator. And if you need to defibrillate, then do that, right? After your initial assessment, you're kind of running this code, you're trying to resuscitate somebody, you have to have ongoing assessments. And you have to look at the different systems and also get more details from the history and your physical exam. And sometimes you can have blood gas drawn, you can have other laboratory results coming back to help you, okay? And all these can be clues of what causing this cardiac arrest or that baby that you need to resuscitate, because the etiology is very important in terms of how you can perform a successful resuscitation. When we try to perform resuscitation in the child, securing an open airway is extremely important. We all taught how you place the head, and we can practice that more in the workshop, right? And again, if a baby is not doing well in terms of breathing, go through that mnemonic of DOPE and try to think about whether your airway is obstructed, whether this baby has a pneumo, and whether you have equipment failure here. I do have one time that I was called to the bedside at CHOP, and the nurse said, this baby is breathing 120 times per minute, an intubated baby, and the baby is desaturating and it's not doing well. But in reality, all it happened is the flow sensor was soiled and the ventilator is auto-triggering. So that's your equipment issue. So when you assess that and you find out it's an equipment issue, you solve that problem, that baby is now breathing nicely. And if you have you already secured your airway is open, now you need to provide ventilation support, okay? Now a lot of times in the emergency situation, we do back valve mask first, right? And we do rescue breaths, and if needed, we can do rescue breaths with chest compression, and depending whether you have one person or two person together. Going from breathing, airway, breathing, now to circulation. If the heart rate is not good, less than 60, or you have no pulse, you need to start chest compression. And also depends on whether you're talking about resuscitating a baby, a newborn, versus a pediatric patient. We do synchronized breathing chest compression in the neonates. So we basically shout out 1 and 2 and 3 and breathe, right? So that's how we do it in the neonatal resuscitation. But for PALS, you don't have to do that. So you have to kind of gear towards what kind of patients you're resuscitating, how big is the patient, and whether you have one person or you're two-person resuscitating. And for chest compressions in the baby, this is the standards that we often use. So honestly, I never use this two-finger technique. I'm not strong. This gets me too tired quickly. I do the second one, the two-thumb circling technique, okay? And that provides much more support, and you're not as tired. Now, I don't know, like for you guys trained in NRP, have you guys been trained in a new NRP? The nice addition? Because some of you, yeah. So there are some changes in the 9th edition, which just came out not too long ago, compared to the 8th edition. So this textbook is still written based on the older one. And for whatever you're gonna train from now on, you need to be based on the new one. But I think the most important thing here is you provide effective circulation support. You have to have enough depth, right? Stable. And whatever way you feel that you're doing the best, you can do that way, but according to the NRP instruction. Now, when you need to use the AED to deliver a shock, I'm not going to go through the exact doses here because that's in your house, right? But you need to make sure you use the right kind of pads and, really deliver the right doses. And a lot of the newer defibrillators in our NICU, actually we at CHOP, we kind of form a habit. We put that on. Sometimes not even to deliver using it to shock, but actually provide you very good feedback in terms of your chest compression depths and stuff. And putting all these together, there are lots of aspects in terms of resuscitating a neonate or a child. But we have to remember, you're not treating one organ. You're not just treating the lung or the heart. You're supporting a whole person. So you need to put all these together, and you need to know your environment, you know your resources, you know your team, and when things do not go well, you need to really think hard. What are the reversible causes that I haven't taken care of? And here on the right upper corner, you can see a table of the reversible causes of cardiac arrest that we need to think about during resuscitation. I think this is the most nerve-wracking for a team leader, that when I lead a resuscitation effort for a newborn, it's great that things goes what I wanted and the baby gets better quickly, but sometimes it doesn't. So then you really have to think, okay, what is the problem here? And what are the things that I haven't taken care of? Is this really, this baby can be totally just cold, and the circulation is bad because of it being cold. So you have to take care of the hypothermia issue. And then you can go by the rhythms, like algorithms here, to think about whether I just start CPR and when do I need to shock, it's not a shockable rhythm, what do I need to do? When do I give medications? And shock is something that we need to resuscitate a child all the time, right? It's quite often. And you have all learned there are 4 types of shock, and you can categorize the shock into compensated or non-compensated shock. Now, these 4 types of shock, recognizing what type of shock it is actually very important. The first type is hypovolemic shock. And when the baby is in shock, the symptoms often is tachypnea and tachycardia, weak pulses, right? Or your cap refill is not good. The baby may be hypotensive. But recognizing what type of shock can really help you to determine how you're going to treat this baby well. For example, if you're in the delivery room, have a baby come out white as a ghost. Okay, we call it white as a ghost. It's very anemic baby. Now, this can be a baby that just born with a history of placenta abruption, massive bleeding, and that's a hypovolemic shock that you're dealing with. Okay, so then the key to resuscitate a baby like that is simply give volume, because the baby do not have enough circulating blood volume to supply. And the best treatment for that is to give volume. So if you can, give blood as fast as possible, right? So we're spoiled at CHOP. We have O negative blood all the time in my NICU at CHOP. We grab that, okay? So if we go to a special delivery resuscitated baby and we need blood, we can just grab those, okay? Or in the unit. Or next door to at our preemie unit, there is a high-risk delivery unit, and we developed what we called massive hemorrhage pathway. So blood can be available within 10 minutes, okay? So that's most effective. But before you get blood, you gave volume. You just gave normal saline, okay? Because the baby has not enough circulating volume. But then the other type of shock is the distributive shock. So, for example, baby in sepsis, okay? It's called distributive because the blood volume is redistributed to elsewhere. It's leaking. So these type of babies can become very edematous quickly. So what I have found in China is when baby become more edematous in front of your eyes, people don't want to give volume. They said, I need to restrict because baby is edematous. But the key thing here is also to determine whether your circulating blood volume is enough. It can be all leaked out, and the baby is really edematous, but intravascular volume is not enough. If that's the case, you probably still have to give volume, okay? So you have to think about what is your etiology here. And if it's somebody allergic to peanuts and now have an anaphylactic shock, the key thing is to give epinephrine as fast as you can, right? So it's not a volume issue here. So think about that. And then cardiogenic shock. You frequently see that in babies, in children with congenital heart disease, or you have a myocarditis type. Last year, we put a baby in Guangzhou on ECMO because the baby had enterovirus infection. Mom had enterovirus. Baby was born, basically was in cardiogenic shock. Came in as PPHN baby because really low SATs, right? But when we look at the baby on the echo, the heart is like scraping like this. Okay, it's really not beating, and it's not, having enough stroke volume to go out of the heart. So those are cardiogenic shock, and then you need to think about this could be a potential reason that you might have to treat that first. And then obstructive shock is actually not uncommon in a NICU or maybe in the pediatric ICU too. We can have a baby all of a sudden have a massive pneumo or pneumopericardium. Or I have a baby last year in one of my sites had a UV line, and the UV line leaked. And this baby had basically pericardial effusions, and the heart is basically not beating because of that. Okay, so all these are obstructive issues that you have. That baby has cardiac tamponade. So the treatment for that is emergently drain the fluid, emergently drain the air in the chest, right? So without that, you're not gonna really effectively resuscitate the baby. And this is basically another rhythm that you can look at, algorithm you look at for looking at different type of shock, and you can treat it accordingly. And I'm not sure if you can really see this clearly. This is an algorithm that when you face a baby, a child with bradycardia, and how you think through, right? So basically, you need to think about how bad is the bradycardia. Does the baby has the patient has a change of mental status? Is there symptoms of a shock? Is the child hypotensive? And depending on the answer, you basically react differently. And then this is an algorithm you think through when you face a patient with tachycardia, right? And when you have a baby with tachycardia, you have to think about, okay, is this just sinus tachycardic, or this is something else? Is this VTach? Is this SVT? And you have to treat it like differently. So here, for this type of resuscitation, an evaluation of your QRS complex with a EKG is very important, okay? And then, because a lot of times when we just using our leads on our monitor, that may not be on the standard position. And the rhythm you come up with may not really tell you whether this has a P wave or not, whether the QRS is really widened or it's not actually just because your lead is not in the right position, right? So situation like this, the better way to do it is do a rhythm strip with your EKG machine. Now, when we talk about neonatal resuscitation, we have to think about, again, neonates are not just simple, smaller child, okay? We need to really have neonatal specific focus, and that's why we have a completely different program called NRP from PALS, right? It's very different. And we need to assess what's the problem with this child. And a lot of times it starts from the delivery room. And that information of whether this is how preemie this baby is, whether the mom has prenatally has any has problems, the mom is GBS positive or negative, the mom has infection. There are times that one time I had to put a baby on ECMO because mom has E. coli sepsis, and mom was in the adult ICU, almost died. This baby culture was always negative, but eventually we thought it was the toxins that got into the baby. Okay, so these kind of information is very, very important, and there are, again, different algorithms that you can go by, and for neonatal resuscitation, we really need to go by the NRP recommendation. And NRP updates every few years. And currently, it's the 9th edition. If you haven't gone through that training, new training should go by the 9th edition of NRP. And this is the saturation goal here. It's based on the previous textbook. So if you look at the 9th NRP textbook, that 1 minute saturation of 60 to 65 disappeared. It starts from 2 minutes. I think the main reason is we really don't know what is the goal saturation for a baby at 1 minute, okay? And this, but also we need to remember, this is a saturation target we use for all baby, although these numbers come up from healthy term babies. So we actually don't truly know what is the target should be for a healthy preterm baby, or if you call them healthy, right? And for the NRP recommendation now is that we start 21% oxygen for all the term baby resuscitation. There are people, though, challenge this, but at least at the present time, the recommendation is to start at 21%.
3 minutes.
But for a small preemie, you may want to start higher than that. So a lot of times we set our oxygen content concentration at 30%. But whenever you need to do chest compression, you need to go up to 100%. And the medication use is also different in a neonatal resuscitation. We're much simpler. Just use epinephrine. We don't give bicarb, we don't give atropine, we just use epinephrine, okay? And then use volume expanders like saline or blood if you need to. So both pediatric and neonatal resuscitation has its own textbook and program that you have to go through. There are lots of details to it. A talk for 45 minutes is not going to cover all of that, okay? So if you take care of any newborns, you need to get an NRP training because this has a lot of things unique to our newborn. But if you're taking care of both neonates and pediatric patients, you need to go through both. For example, I have to do both NRP training and PALS training because CHOP unit, we call it a newborn and infant intensive care unit. We take care of kids up to 1 year. So I have to have PALS training too. So there are lots of things here that are key concepts that in the neonatal or pediatric resuscitation. But I think the bottom line is, as RTs, you're gonna participate in resuscitation, whether you like it or not. Do your role well. Know your equipment. We rely on our RTs so much. Whatever they hand me to bag, whatever they hand me to intubate, those are the things they already prepared, they already checked, right? So in the workshop, we're gonna really talk a little bit more about how you assess these equipment. Okay, those are your roles. And also, you're a very, very important part of the team. And you can, an experienced RT can give a lot of good suggestions to the resuscitation leader. And not only you're skilled in what you're doing, but you're also experienced and you can give really good feedbacks so that the team dynamics is much better and that the efficiency of the resuscitation is much better. I think that's all I want to talk about today. And I'll be happy to see all of you in the afternoon workshops. Thank you.
Thank you. Thank you so much, Professor Jiang, for the valuable and informative presentation. And now we would like to welcome Emily again who will be speaking on neonatal and pediatric ventilation. Emily, welcome again, and the stage is yours.
All right, we are going to talk about one of my favorite things, which is mechanical ventilation. And what I want to start off with is why this is important, is that generally, and I will say, and I've been in neonatal pediatric care, it is my bread and butter, it is what I am the most passionate about. And unfortunately, pediatric lung injury and mechanical ventilation is fairly poorly studied. With the majority of the investigations that we do have, they're observational and retrospective in design. We have very few randomized control trials to actually drive the management care. Although I will talk about today in this lecture and in our workshops a few things that I'm very excited that will come out soon that I think will help give us some of the most robust information that we've had as far as neonatal and pediatric mechanical ventilation. But up until now, most neonatal and pediatric mechanical ventilation practices have been arbitrarily, and I'll say poorly, adopted from adult protocols, from what we know from that population. And as we've said many times this morning, pediatrics patients are not small adults, neonates are not small kids. So I think what we are really going to have to focus on is very personalized management strategies and where we need to focus our research on. And I will also say I've worked in 3 of the largest and best children's hospitals in the US, all with great outcomes, all that had very different mechanical ventilation strategies. But the number one thing that makes them stick apart is that they had RT-driven protocols. So that seems to be that we will talk about all the different modes, all the technology that's available, but the number one thing and the best thing that you could do when you go back to your hospitals next week is to really emphasize the need for standardized decision-making, build RT-driven protocols, and ensure that you have a shared mental model between the nurses, RTs, and physicians, and driving the mechanical ventilation comes from you, the RT, and your expertise, because standardized decision-making and one strategy is what's best for our patients. And so let's talk about why we intubate overall. I will say generally in neopeds, we are slower to intubate. We really do try our best to optimize non-invasive care before intubating. But our indications are not very different from the adults. The goals of mechanical ventilation are very similar. You want to improve your oxygenation, you want to improve your ventilation, you want to improve your work of breathing, and you want to re-expand any collapsed alveoli that might not be supported by non-invasive. And so the indications are if they're apneic, if they're not breathing, if they're not oxygenating well, if they're not ventilating well, they're working so hard at the present moment that they're not going to be able to sustain that work of breathing for much longer, so we're anticipating future respiratory failure. And if there's any airway management issues, can they maintain their secretions well? Do we have any upper airway obstruction and any need to protect the airway? Your book does have a nice chart that goes into the very specific diagnoses between neonates and pediatrics, but again, what you need to assess if you need to intubate are those 4 things in order to know if you want to advocate for mechanical ventilation. So there's 2 ways that we can give pressure to our patients. I'm actually going to start on the left side there, so negative pressure. Currently breathing sitting in these chairs. What system are your lungs under right now? Negative or positive? Negative, right? So as our brain sends our signal to our diaphragm, it's going to contract. That's going to cause a negative intrathoracic pressure, which is going to cause our chest wall to expand. And that difference in pressure is going to cause you to actually take in the breath. So our natural way of breathing and our organs really like to function under a negative cycle environment. So when we intubate or putting someone on non-invasive and we transfer them to a positive pressure, what are the kinds of things that we should be worried about? Which organ really struggles in the positive when you have positive intrathoracic pressure? Your heart. So you do want to, so that is one thing that you want to be careful of, and that's something that when we make sure that we're watching out for our intrathoracic pressure, high levels of PEEP, that you want to make sure that you are supporting your patient hemodynamically, because we know that that can impede venous return and essentially, and ultimately reduce our cardiac output. So we most often think about positive pressure ventilation. We can do that non-invasively through a mask. We can do that invasively through an ET tube or a trach. There is a form of negative pressure. Show a raise of hands if any of you guys used a negative pressure cuirass in your units. I see a few hands. And when we have chosen, I'm going to say the evidence and the data is not very clear, but I do also have experience with it. I will say when you're thinking about using that as opposed to positive pressure, it is usually because you are worried about something from a cardiac perspective. So when I had used it, it was largely in our CVICU. It was for our post-Fontans, and you were really, really concerned in those post-op days about putting any additional increased PEEP or increased pressure. They wanted to extubate them a lot faster, but knew we need to augment their breathing. So if you put a chest outside, it actually creates like a subatmospheric pressure, almost like a suction vacuum, and it's going to actually be outside your chest wall trying to augment breathing, but without that negative pressure. So cardiac patients is one population that I've used it a lot in, and also our neuromuscular. So these are patients who perhaps we were trying to avoid tracheing long term. Maybe they were on either nocturnal or 24/7 BiPAP, but we knew that if we didn't want to have to go so high up on those pressures that for some parts of the day we might put a cuirass on them and help open their chest a little bit to help improve the effectiveness of their NIV. Again, so these both are available, much less experience and knowledge about the negative pressure side. And this is just a diagram kind of showing what it looks like. Your positive pressure is typically going to be applied directly to your airway, either non-invasively or invasively, and the negative is usually going to be around your chest, trying to help augment those breaths. So this is the breakdown, and so this is the fundamentals of mechanical ventilation. And I actually want to start from the bottom and go up to the top. So the first thing is, and I always want to look at the anatomy of the breath that's delivered by mechanical ventilation. And we know that there's always three phases, right? Something has to start the breath, and so that is your trigger. That could be flow triggered, so this or pressure triggered, both of which require the patient to generate the breath. Once it senses that, then it'll kick in. Or it could be time triggered. So if we set a mandatory rate, for easy math, I'll say 20, we know that whether the patient is breathing or apneic, every 3 seconds, it will be time triggered. And so you have some variable that's going to turn the breath on. You're going to have some variable that's going to limit the breath, and that will go up into that. That's going to be your control variable. So you'll want to either deliver a set tidal volume or a set pressure. And then you're going to have some variable that's going to cycle it off. For the most part, that could be our I time. And on pressure-supported breath, what do we usually set on spontaneous breaths? That will tell you how long the breath will be. What sets the I time on spontaneous breaths? I can't hear very well. I think someone said it, but this is when you're setting your E sensitivity, and that's usually a percentage of your peak expiratory flow. When it drops to some percentage, it'll drop off. So it's less dependent on a fixed I time, and rather on the flow demand of your patient. So that's the breath. Those are the three parts. When we think of the control, we can really only control for two things. And that is what every single breath, I want to ensure that the breath delivered, at least on mandatory breaths, that our patient will get. I can control for pressure. So if we want to ensure that every breath is going to be a total PIP of 20, you will set that. Or you control for volume, tidal volume, and you will set that. Or I think flow and volume are interchangeable. If you're on a volume control mode, you're essentially setting both of those. Because we know that if you set your volume and your eye time, your flow is going to be determined, because by nature we know that tidal volume is flow times eye time. Depending on the mode that you're in or on the vent, whatever you set will determine the other. So if you're controlling for volume, you are also controlling for your flow. And then what's really important is what are conditional. So we know what we set. What's important for you as the RT is what's going to change breath to breath that's going to tell me more about my assessment. And that's actually one of the most important things for you as RTs when you are assessing your patient and you're reporting out at rounds or you're giving handoff. And I always say, I hate the words vent check. I don't know what you're checking. I can look outside the room and I can check the vent and see it's on. That's not our role. You're going to go in there, you're going to watch a few breaths, you're going to see how the patient is doing, you're going to auscultate, you'll look at your x-ray, you'll look at your gases, you'll know your patient's history. The numbers from the vent is one part of a large story of your patient. So when you are reporting at rounds, I don't want you to tell them what their setting's on. They all know that. That's in the order, that's in the chart, they can look from the outside. I also don't want you to say they're on the pressure of 20, tidal volumes of 10 mLs. What were they yesterday? What were they 4 hours ago? Is that better or worse? Do you think, should we get ready for extubation? Are we escalating? Does that match what the x-ray said? What did your morning gas look like? So our job as RTs is to put the story together. Your ventilator assessment is one part of the tools that you can use to really show your expertise of your clinical assessment and be able to provide the team with what your recommendations for care is. And this breaks it down a little bit longer. I won't spend too much time on this, but of course, if you're on pressure control, you're always going to be setting a PEEP or baseline level of pressure in the lungs, your eye time, your PIP. One thing about pressure control, and this will actually, I think it's better shown here. If you're on pressure control, which is on the other end there, it is always variable flow. It's a variable flow waveform. And what it wants to do is it's going to be a square pressure waveform, because it's going to pressurize really quickly and maintain the amount of pressure throughout the duration of the breath. What that means is you're going to have a really high inspiratory flow at the very beginning of the breath. It's going to get the breath all the way up to get your lungs to inflate, and it's going to hold that breath. As it's doing that, as we know as the dynamics, as your pressures begin to equilibrate in your lung, your flow is going to start heading down to 0, and then it'll be cycling off. In volume control, like I mentioned, that is a constant flow. It could be what I learned from Dean yesterday is I've always said square waveform, and very rarely has it ever been a square. So yes, it's a rectangular square waveform, just means it's constant flow. There are different flow deliveries. You can now set it at decelerating, but the only thing is just know that your flow will be the same for every breath, because you're essentially setting flow when you choose your tidal volume and your eye time. And that way, so you're going to have constant flow, and your tidal volume and your pressures, because you have a constant delivery of flow over the breath, this is going to be your pressure is going to slowly rise to the top and then go into exhalation. So it was a little misleading to say you could only control for one or the other. And there is a mode that is more adaptive, and you have a little bit of control of both. And this is these are considered your modes like PRVC. On the Draeger, you can call them volume guarantee. They are all the same to describe this type of mode. And the best way to describe it is if you are driving and you put your car in cruise control, right? When I say I want to go 30 miles an hour, if you're driving uphill and you're chucking along and your car is only giving up 25 miles per hour, what does it do? It's going to accelerate, get you closer to 30, and then make sure that you're going that way. And then if anything gets better in the road and you start heading downhill and, oh no, I'm speeding up, now I'm at 35, I'm 40, your car will automatically start braking to get you to target back whatever miles per hour you want to go. So this is similar to PRVC. So one thing to remember, it is a pressure mode. So everything that I just said, variable pressure, square pressure waveforms, that high inspiratory pressure right at the start of the breath, that is all applicable. The only difference is it's going to measure the exhale tidal volume, and if that is not what you put your target to, it's going to slowly either titrate up or down. It's going to titrate your flow to get you closer to whatever tidal volume you want. So let's say I want to target 10 mLs. It's going to shoot out a test breath, and on exhalation, it says, oh, I only gave 8 mLs. Over the next few breaths, it's going to increase your flow slowly throughout those breaths until the exhale tidal volume is 10, and then we'll say, wonderful, I'm going to keep ventilating on these settings, and over time, if your compliance is improving or you gave really great airway clearance and your resistance has improved and your next tidal volume is creeping up 11, 12, it'll say, oh no, that's too much, that's too high. It's going to slowly wean your flow over the next few breaths. One thing to keep in mind, it's a very smart mode. It sounds brilliant, right? Like it's like an RT, like a little RT little fairy standing at the vent, really targeting to offer safe tidal volumes. One thing to watch out for is that the vent isn't smart enough to know if your tidal volumes are changing because of improvement in clinical status, or if it's because the patient has a high drive to breathe. So let's say you have a patient on, and they might be agitated, or something might have changed that they actually start to take a really big breath in, or they're flow hungry. So let's say you're targeting your tidal volume of 10, and because of this big breath, they get 20. The vent says, well, that's awesome, they're doing better. They don't need much support, so they wean the pressure out from under them. And then the next breath out, so your patient gets even less flow on that breath. What's that going to make them do? They're going, what are you doing? I need an even bigger breath. So they're going to struggle even more, and they're going to get more flow hungry. They're going to take, and the exhale tidal volume will be even larger on that breath. So we can wean out support from your patient without inappropriately actually increasing their work of breathing. And I'll tell you, I most often see this in our NICUs. When you have a patient breathing 60 and a newly born premature infant, and they're breathing really fast, and they go through these episodes. When you get to the bedside, it looks pretty exciting, right? It looks like they're almost on CPAP. And I've actually heard both RTs and neonatologists say, like, oh, wonderful, they weaned overnight. They're basically on CPAP. I think we can extubate. But I said, look at your patient. If they're breathing 80, retracting to the spine, and their SATs are going down, does that seem to match the assessment of having weaning those pressures? No, right? You would have to always take it into context of what your patient looks like. And the other thing, particularly in our NICU population, and I would say generally if this is happening, it's not failure of the mode, it's not failure of the vents, because the other thing our teams like to do is, oh, switch out the vent, it's broken. No, it's not, and then they do that, or they take a vent that doesn't have as many as alarms, that makes everyone more comfortable. It's mode asynchrony. It just means your patient's current clinical status is not appropriate, so we just switch the mode. We can go to pressure control and ensure that until we fix the underlying issue, that's okay. One thing to remember that we're adding into our algorithms, particularly for our NICU vent protocols, is, has your patient grown, and did you go up on your tidal volume? That is one huge difference between our NICU patients and our adults. We can expect adults or pediatric patients to basically need the same tidal volume for the duration of their stay. But as a neonate is growing, if you're not doing your daily weights and updating your tidal volume at least weekly, if not more, what that also might be telling you is that you are under-supporting your patient. So we actually do that first. We'll do the whole assessment. Okay, I don't think they're ready. I think this is no longer matching them. We'll assess. And before we switch them to pressure mode, we ensure, is our tidal volume even accurate, or was this our patient telling us that we need to titrate up? And that almost always fixes it. They are telling us that they need more. And I've always said for a long time, like, there's no great evidence to show that volume versus pressure is better in on any mode, or assist control versus SIMV is better. But one of the largest bodies of evidence with high-quality meta-analyses, Cochrane reviews for the premature infant, for the for extremely low birth weight infants is the use of low tidal volume strategy on volume guarantee or PRVC in the assist control mode. We've never had that much robust information telling us for this population, and it has incredible results. Across many multiple high-quality randomized control trials, we see reductions in severe BPD, reductions in the rate of IVH, reductions in air leaks, duration of the ventilator, any reduction in all the composite outcomes of death and BPD. And so that is one mode that if you're in a small baby unit or in NICU, that you want to be in the assist control mode, and that's really when they looked at studies looking at the work of effort, of breathing effort, that assist control really had dramatically reduced the work of breathing for the patients. And I'm laughing because yesterday there were some talks in the adult track about how SIMV is silly and we don't need it, and I'll share, and I'm curious when we talk later in the workshops, at least when I started my career in our PICU, SIMV is used often. And we do believe that we're weaning them. I don't think we're weaning, but if we reduce the mandatory rate, it gives us a better idea of a pressure support trial until we take it off. It's not right or wrong. I think that's just a practice that many people have adopted. But again, so SIMV, people are always confused when they hear that we still use SIMV. But again, I will say in the premature population, you want volume guarantee, PRVC in the assist control mode. And we'll actually, one of our scenarios will go through a protocol that's written in that and how to troubleshoot different things that you're seeing. This is just showing the physiologic mechanisms. So just to remind everyone, your conventional vent or your bag or whatever you're using to introduce that positive pressure is going to go flow through the ET tube to your conducting airways, which is going to be carried by convective flow to the alveoli, and then to your blood-gas interface where gas exchange will actually occur. And all parts of breathing is differences in pressure and gas flow. So again, this is what I talked about earlier. Our natural cycle of breathing is caused by negative pressure. Your diaphragm contracts, it causes negative pressure in your intrathoracic pressure. It's positive out here, so that's what's going to draw air in for normal breathing. And again, and after you take a breath, your alveolar pressure is now positive, and so your exhalation is going to be passive by that elastic recoil. So all gas flow is occurring because of these differences in pressures. When we think about our breath patterns, and this is a nice graphic that is showing kind of every single setting, every part of the vent is interrelated. This is just showing, if we're worried about ventilation, what is the number one thing if we want to control CO2 that we think of, I need to make changes to affect this on the ventilator? I hear respiratory rate, what else? Tidal volume, right? So what is your minute ventilation? Because and you can trend this very nicely. I always say I don't need a gas to know what I need to do next on the patient, because your patient is giving you so much data that you can assess of what you need to do next. But if you watch their minute ventilation, which as you mentioned is now broken up into your tidal volume or your rate. And so if you need to make vent changes, you are often trying to adjust one of them to do the best thing for the patient. But your rate also will determine many other things. So if I'm on a rate of, again, I'll use for easy math, I set a mandatory rate of 30. What is a total cycle time of every breath, of every mandatory breath? 2 seconds. And I will also say, I think this is one of the differences of why assist control wasn't used initially, because we naturally, our patients breathe 60 to 80 on a natural basis, right? So when you only have a 1 second I time, you run the risk of not having enough E time to fully exhale. And when they're breathing that fast, you can easily cause auto PEEP and overdistension, but we just have less time per breath. So let's go there. So we set a rate of 30. I now have a 2 second total cycle time. We'll set our I time. And the biggest thing is, do we have enough E time to prevent ventilator and induced lung injury, to allow our alveoli to fully exhale so that we don't end up causing air trapping? And then are we maintaining our IDE ratio in a way that protects that? So just be mindful of that when you choose your I time. You also have to make sure that you're setting an appropriate E time for your patient. And what's important to know is your time constant. So the time constant is the amount of time it takes for your lungs to inflate and deflate at least 63% of your tidal volume. And this is going to differ from patient to patient. If you have really stiff lungs, think of a very stiff balloon. You don't need a lot, right? You do one quick blow and it's fully pressurized. So if your lungs are very stiff, you'll have a very short time constant. Whereas if you have patients with a lot of resistance, so maybe they inflate really well, but actually what you're worried about is that it's going to take a long time to exhale. And the rule of thumb is you need at least 3 times your time constant for enough E time to exhale 95%. So when you're setting your rates and you're setting your I time, you also have to think about what is my patient's disease state? Is it obstructive? Am I concerned about the fact that they're going to air trap? And is this rate and this I time going to allow me at least 3 times my time constant to make sure that they can fully exhale? And I just went over this. If they have 4 compliance, your time constant is usually pretty short. And so you don't need a lot of time for inhalation or exhalation to fully exhale. What we're concerned about is the areas of high resistance. So you have to be mindful of what am I setting my rate to? What is my total cycle time? Do I have at least enough time to fully exhale the 3 times the time constant to be able to exhale 95% of your tidal volume? So we'll talk about triggering, which is also very tricky in our tiny patients. When the vent is waiting for flow or pressure to drop below a certain point to give a breath, especially for a 500-gram baby, you really need to be very, very sensitive to it. Otherwise, if it misses those triggers, what is it going to cause? Increased work of breathing. They're going to be trying to struggle and breathe, and the vent is not going to give them the breath. It's going to be a delayed breath. It can cause a lot of asynchrony if you don't have adequate tools to be able to measure those really small changes in pressure and flow to adequately have a triggering mechanism for your patient. And so and you can see that here in the graph here. You can usually see the trigger as some dip in the pressure or flow waveform before the vent kicks in. And what's really important about this is your pneumotac, or your proximal flow sensor. Raise your hand if in your institution you currently have proximal flow sensors. Keep them raised if you're constantly having issues troubleshooting and it causing you many headaches and problems and you want to throw up. Okay, great. So I will say you are not alone. Your challenges are not unique to you. It is the great thing about a proximal flow sensor, because in other vents, they're measuring triggering back at the vent. They're measuring tidal volumes back at the vent. However, for our patients, for a 500-gram baby, 2 mLs of tidal volume is already 4 per kilo. That is why it's so important to have it. Adults wouldn't care if they're having a tidal volume of 200. What do they care if it gave 198 in the next breath? It's such a small part, but 1 ml of difference in the tidal volume is already 2 per kilo, and we've already talked all morning about how safe tidal volume delivery, protecting your lungs from ventilator-induced lung injury is what prevents BPD and chronic lung disease. So that is actually the most important part. So it is great because the invention of them dramatically improved the outcomes for our small baby unit, dramatically improved our strategies for safe tidal volume delivery, dramatically improved synchrony of these vents because it could feel that small change in trigger right at the airway. However, the technology is so sensitive that we know in condensation, if there's aerosolization, anything happening can completely wipe that out. And if that pneumotac is in any way compromised, they can't trigger, the tidal volumes are not accurate. So I will acknowledge that. We can talk about more and share practices in our workshop. But what I will tell you is if you choose to switch it out, you just lost every benefit of what I just told you about it. You could switch it out to make you happy or the nurses happy or physicians because it's not alarming. But now you have completely exited our safe tidal volume delivery and improved synchronous. So I will say it's best to help you and your teams come up with the troubleshooting, have really good practices of how often you calibrate them, how often you switch them out, how you ensure aerosolization does not affect it. But please, 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 especially in your small baby unit, we should be using proximal flow sensors. And here's just another diagram of everything we've talked about, of the phases of our breaths. You have something that triggers and turns it on. It will inhale until whatever limit we set, and something, whether it's time, will cycle it off into exhalation. Nava. So I want to talk a moment about this. So, like I mentioned, when you decide to take a breath, we have chemoreceptors in our brain that are sensing changes in pH and CO2. It's going to say, hey, I want to take a breath now, sends a signal down to your phrenic nerve, excites your diaphragm contracts, that negative pressure causes you to take in the breath, and then your flow sensor will trigger then and give yourself a breath. The thought and the theory behind Nava is that using a specialized NG tube that has why is the word escaping me? That has those electrodes, there you go, that lie at the level of the diaphragm, is that it can actually trigger once your brain has decided, once it sends a signal, it's going to trigger then. And so that's one proposed mechanism and benefit of Nava, that it says it's improved synchrony because it has improved triggering capabilities. And I'll share with you, and there's large meta-analyses that show that that actually is true. So if the challenge is you want more synchrony, Nava and this triggering capability is great. But it's not just triggering. The other thing it does is, I'm going to use an example, we set a tidal volume of 50, 30 times a minute, and we expect our patient to breathe like all day long for 24 hours, right? How many of you are breathing the exact same tidal volume for the next 30 breaths that you take at the same interval? No, right? Sometimes you're going to take big breaths, sometimes you're going to take small breaths, sometimes you may pause a really long second, and then you might breathe really fast. So the other proposed benefit of Nava is that we don't set any of that. It's just going to trigger and give a breath in proportion to how big or small the size the signal from the brain is. So it allows more physiological variation in breaths, both eye time and size of breaths, that they presume is more comfortable and more synchronous with what the patient actually wants. So that is what has been told as a benefit for it. Raise your hand, how many of you have or use Nava regularly on your units? Oh, okay. So so there's not a lot. So we'll talk a little bit more in our workshop about it. If you are interested in using it, I've used it in a lot in institutions. I don't have it now in my current one. And again, I think it is such a different mode of ventilation because you as a clinician cannot set anything except your PEEP and your Nava level. Because guess what? Your patient decides everything else. You have zero to little control over tidal volume, zero to little control over their rates, because what you're counting on is their own neural control over their breathing is going to drive them into whatever rate and volume that they want. And I have a little more information that we'll show in the workshop, but they actually showed that as they did a study in premature infants, and what they did is they slowly went up on your Nava level. And as you would assume, if you got more support, your tidal volume would increase. So they saw that. They said, I'm going to go up from 1 to 1.5, and tidal volume increased, PIP increased, and it was fine. Then they went up from 1.5 to 2. Same thing, tidal volume increased, your PIP increased. But every patient at some point demonstrated what they called a break point. So as they went up on the Nava level, they actually saw that tidal volume stayed the same, and when they looked at the EDI maximum, they actually started driving it down. So the babies were saying, I don't want that big of a breath. I'm just going to not try to breathe as much. So it was showing that there's this offloading of respiratory muscles that becomes so sufficient that your body will never make you want to take a bigger breath than it needs. And at some point, having the Nava level so high actually just caused them to have no signal, and they went apneic because they drove down their CO2. So there's also some proposed thoughts of, is this better at ventilator lung protective strategy? Instead of us choosing the tidal volume and preventing that overexpansion, will our patients on NAVA actually do that themselves? And there's a few studies not robust in pediatrics. There's one large randomized controlled trial in the PICU that had promising results, one prospective study in premature infants, but overwhelmingly the systematic reviews don't show robust results. However, individually in centers, and ones that can do it well, have shown anecdotal evidence that it's great. I will share what I really love is for NIV-NAVA. We talked earlier today about the challenges, right? The mask doesn't fit, there's a large leak, it's not synchronous with their breathing. If you have them on NIV-NAVA, you don't set an eye time, you don't set a PIP, it's based off when they want to breathe, the vent gives them pressure, when they want to exhale, they do, and it's very synchronous, so it's helped a lot with post-extubation in our NICU. It's also helped a lot with severe BPD, who need really high PIPs and are so uncomfortable on the vent that we just sometimes choose to paralyze them because it's too hard to manage them. You flip them over to NAVA, they can trigger, they can get the vent, they can get all the breaths that they want, and because they're able to not be on sedation or paralysis, they can grow up until the time that they're able to leave. The hard part thing is you can't take NAVA home, so transitioning them now to a home care vent also becomes a challenge, but I will say there's been small pockets of centers that have really great strategies, but not overwhelming evidence to show that we need to use it over our conventional methods. There's three types, low frequency, or that's what I would call our conventional vents, high frequency, which, if we think about our conventional ventilators, if you think about your pressure volume curves, you worry about, if you don't set your PEEP high enough, you're gonna have edolect trauma. If your pressure, your volume's too high, you'll have volutrauma and barotrauma, and that cyclic opening and closing it's gonna cause the biotrauma and it cause all of that ventilator-induced lung injury. When you have that, the whole mechanism behind high frequency is we're just going to make sure that the alveoli stay open at this high mean airway pressure that will set, and it's a gentle wiggle with very small tidal volumes, less than dead space, and it's a form of protective lung strategy, often thought of if you have air leaks, PIE if you're in the NICU, or I will say a lot of times we use it as a rescue. So if you're trying to manage your patient on conventional and you're starting to near those dangerous pressures or dangerous volumes and you still can't ventilate or oxygenate effectively, you may have a trigger to go put onto high frequency. Low frequency or conventional is the most commonly used. Again, I mentioned high frequency, and we're going to talk a little bit about proning. We don't have great evidence of what's better, proning versus, high frequency versus conventional. But I'm excited to share, if you haven't heard about it, there's the largest multi-center international study called Prospect, which is a study that's looking specifically at severe pediatric ARDS. And it's aiming to answer both questions at the same time. Should we prone or should we supine? And should we use oscillator or conventional? And when they were randomized to the study, they got any kind of combination that were followed, and each arm had very strict RT-driven protocols for the management of each. I just got the email this week that we have stopped enrollment. I'm hoping that we'll be able to publish the results of that soon. I know that's something, I think it's been on for 7 years that we've been collecting this data, and that will give us a whole lot of information specifically about pediatric ARDS. We will be covering part of that protocol in our workshop. I did get permission from the study investigators. It is publicly available, but I wanted to show, because they're all based off the PLEAT guidelines of best practice. So you will have access, and we will be talking through how to actually manage a patient using those guidelines. But very exciting news, again, for our population that does not have robust information and evidence for how we manage these patients. It's a very exciting study. And as far as management, if we want to improve oxygenation, you guys know we're going to go for FiO2, our PEEP, your MAP, and one great way to improve your mean airway pressure is just have a longer eye time. Stay open for longer. And for ventilation, we just talked about this. If you need to affect it, you should affect your tidal volume or your frequency and ultimately your minute ventilation. Here are some, this is from the book that you can review. I'm not going to spend too much time because we're going to talk about some specific strategies in our workshops. And when we think about mean airway pressure and what affects it, so mean airway pressure is the average pressure kept in your alveoli over the time that is going to help maintain your lungs open for alveolar recruitment for effective gas exchange. It's the area under your pressure curve. So if you think of anything that will make that area bigger, that is what you should think of if you need to increase your MAP. So the biggest thing is if I just increase my PEEP, I just raise my baseline, automatically that's probably the biggest thing and the most effective way to increase your MAP if you're trying to. And then we think of I time, the longer time under that curve, under that high pressure. To a less extent, if you're trying to use your I wouldn't necessarily increase your PIP if your goal is to increase your MAP, but just know that if you do increase your PIP, it will increase your MAP, and of course, your E time will affect it as well. The patient vent system is, I actually think it's a little bit more than this. I always teach my students as they walk into the room, the first thing is like, look at your patient, is there anything immediate that you have to address right now? And if they look stable, and the assessment is good and the monitors are good, the number one thing that I think most RTs forget, I say trace your system. Are they on a vent? Are they a high flow? Look at the machine, trace whatever circuit is going to your patient, trace it going back to the machine, and that alone, I think, would catch so many things. That's actually part of our bedside safety checks that we do when we're doing handoff, is they're getting the assessment of the patient, and both eyes, RTs, check the system really quickly. So is your ET tube in a good place? Is the circuit set up? I mean, to no one's fault, we know that we're busy. Sometimes the inspiratory limb is switched with the expiratory, or they realize there's no filter, or something. You need to make sure your system is correct. And the vent, one thing to keep in mind, and a lot of the hard part of what we do, is we not only have to manage all of these different diagnoses, adult, pediatrics, and neonates also have all different equipment with very different specifications and rules about when to use them. So like circuits have a tidal volume limit, or it might be a pressure limit. Even if you're doing different modes on the vent, you have to remember what's the pressure capability of this, what's the tidal volume. And so what I will just say is, if you're a leader of a department or if you're making these decisions, try to make decisions that make it easy for your RTs to make the right decision every time. Don't make it complex. So I personally have never used all 3 vent circuits because there's overlap in the pediatric. So what we will do, a common one, and the vents that we use, I think the tidal volume minimum for the adult circuit is, I'll say, 100. So as long as they can draw 100 mLs, but I know when an RT is getting ready for an intubation, they're not actively thinking, well, what's the ideal body weight? If I want to get 6 per kilo for it, it's going to be this volume. So make it 4 kilos, say 15 kilos, because if you're getting 6 per kilo, that's at least 100, that's close to 100 mLs. Make whatever you choose, there's no right or wrong. Set up the system so the RTs can make the best decision and do it safely. Because it's already hard to choose the right thing. We'll go past this. Suctioning, I will say you can do closed, which is best practice in standard care. I don't know how open suctioning, but we're really trying to prevent it. It can increase the risk of adverse events. We know that anytime you disconnect the patient, you know how quickly your lung de-recruits, and it's often funny. And when they de-recruit, you have to use such large pressures to re-recruit them. And it's funny, when I've been trying to advocate for that to stop the practice, I always hear, but their SATs improved so much greatly after it. And I said, if it improved after bagging with bigger pressures, you probably need to adjust your vent settings. If it just took 3 breaths to make your saturation improve, imagine if you just optimize your current vent settings. So I would say advocate for that. For positioning, something very big in our NICU to prevent IVH, because they're very prone to the changes in their cerebral blood flow, is for the first 72 hours of life, they must be supine, must be midline before you can start positioning them. Prone positioning, and again, we'll talk a little bit more in our workshop. The entire thing is similar of why we think why we wanted to use it for our patients. If I'm supine, where's most of my circulation going? Your perfusion. It's going to your dependent or dorsal areas of your lungs. However, if you're in a supine position, you have compression of your sternum and your organs, so most of your ventilation is actually going to be in your anterior part of your lungs. So if you're ventilating your anterior, but you're perfusing the posterior, you're going to have some form of VQ mismatch. The thought is if we can prone our patients, and now your lungs, especially your dorsal area of your lungs, are no longer subject to that compression, you're going to ventilate that, which is getting our most perfusion. So you're going to improve oxygenation by virtue of more homogeneous distribution of ventilation and improve VQ matching. We want to make sure that a big part of the recovery, or the hardest part of the recovery after intubation and being paralyzed and being on sedation, is actually the muscle loss of both of the body and of your diaphragm. So as much as possible, we've all seen the videos. It's wonderful when we can get. In our CVICU, we had a kid on ECMO who was able to ride his tricycle. I will say we all know it's really challenging. It's already hard. I know I love it and I want to move more towards it, but it's really hard to reason with pediatric kids not to pull out that tube or not to pull out that life-saving catheter. So while that's the gold standard, if you can work with PT to just start doing early either passive or active range of motion, and getting them to move, it'll help their recovery much better. In the neonates, it's a lot harder to do because they can't really follow your directions, but all of that is the repositioning, kangaroo care, all the things that we're doing. We sometimes call it the rotisserie because at least if we can move them side to side, it'll help improve their outcomes. Many complications, and our goal as RTs is to do everything we can to prevent these from happening by using all the tools that we're using this week and we'll discuss in our workshops. But again, remember, your goals is because of your very unique understanding of the pathophysiology of pediatric and neonatal lungs. Your job is to manage your patients in a way that prevents this, for the best of your degree, from happening. Monitoring is always very important. I would actually move everything to non-invasive except for blood gases. But when we can, we want to use non-invasive ways. TCMs, end-tidal. We know that end-tidals are more challenging to use just because when your tidal volume is 2 mLs and the end-tidal needs 0.5 to read, you just took away a third of that patient's tidal volume. We'll talk about, though, in our vent strategy, sometimes you can target higher, compensating for that dead volume if you do have an end-tidal in place, or the flow sensor. What you want to be careful of, similarly, you don't want to get a lot of blood gases because even 1 ml of blood is a significant portion of the circulation for our neonates. And as I mentioned, you don't need, I will say something maybe controversial, you don't need a blood gas to know what next to do with your patient. You know your vent site, you know how your tidal volumes have been trending, you know what's happened with your minute ventilation, you saw your morning's x-ray, you're assessing your patient. You shouldn't need to wait for a blood gas to tell you what to do. It should be used for monitoring to make sure, but we have all these non-invasive ways to ensure that we're going in the right direction with our patients. I will keep going. And weaning, I think the most important thing, and we have less robust tools in pediatrics and neonates and adults, but in the most recent policy guidelines, it's basically just have a protocol. We're still learning about what the best protocol to follow is, but as long as you establish something in your unit that is a standard way for decision making, and we'll talk about a few ways that we can do that, is ensure that you are having some method, some protocolized structure for both assessing the readiness for an SBT, and that can be if you're on a PEEP level of, I'll say 6, FiO2 of 40, if they're SBS, which is our sedation score, as long as they're not obtunded, as long as it's 0 or positive, if they don't have anything scheduled the next day, and every single shift, your RTs should be screening them. For the first part, while they're sick, they're not going to fit one of that criteria, and then you just skip past it. But if every night they're screening it and they say, oh my God, we fit all 6 criteria, you should have an automated RT-driven way to then perform the ERT, and then if they pass the ERT, advocate to extubate as the next day. We tend to have a trend of wanting 6 ERTs to be comfortable, or what we like to call sprinting, because somehow seeing someone pass an ERT 6 times is better than 1 time. And we know that only prolongs mechanical ventilation, prolongs the risk of adverse events, and is unnecessary. There's good evidence to show that 1 passed ERT shows great extubation success. And we're going to go over some values and sample ERT protocols to help you build one at your institution. And similar, weaning from the oscillator, which is going to be one of our stations, is if you can get down to an FiO2 of 40% with your MAP less than 17, those seem to be safe settings that you can easily transition to your conventional to continue weaning off. And as extubation, which is always the goal, once an ET tube is in, you should be assessing every second, every day of when you can take it out. There'll be some post-extubation care, and again, the Polisi guidelines actually have some really great recommendations of should we consider any kind of non-invasive support, or if they can extubate to room air. And the recommendation is if they're at risk for upper airway obstruction for any means, and that could be if they had multiple intubation attempts, we know that there was some trauma caused during that. If you use a larger than normal ET tube for their size, if there's any anatomical anomalies, lack of an airway cuff leak should not prevent you from extubating. It has very poor predictive value, very great success value, meaning if I have an air leak, it is really likely that my patient will pass extubation. If I don't have an air leak, it might still be really likely that they pass extubation. So you don't want to necessarily keep them, but you can do some prophylactic things, and they recommend steroids at least 6 hours before, and consider going straight to CPAP high flow or some way to support them through that extubation transition. That was a lot of information that I hope we go, so thank you for bearing with me before we go off to lunch, and I'm excited to see most of you in our workshops this afternoon.
Emily, and all the speakers of neonatal today, you passed the test of doing a whole chapter, a whole term of lecturing in 45 minutes. So thank you, Emily. Good job. Thank you. Thank you, Dana. Thank you, everyone. Now, I would like to thank our chairs, Dr. Fagihi, Dr. Al-Garni, for chairing this session. Thank you very much. We value your time and effort. Okay, for you who register for the neonatal course, after lunch, exactly 1:15, please be in the basement and follow your group. Just go with your group to and there is a sign there or a roll up to say which group, what workshop. You will go for about 1.5 hours and then break and then go back again. But at the end of the day, please come back here for the post-test. This is very important. And thank you very much for all. And the best of ARC will commence at 1 o'clock here. Actually 1:15 in this place. Very exciting session coming up for today and tomorrow for the best of ARC. Can I have the QR? Also, for our, as a support of our colleague, Dr. Hajid Al-Otaibi, if you can take an image of this QR code, he is doing a research as usual. Almost every month there is a paper coming out of him. So take an image, and maybe later you can support the profession by filling this. Thank you very much. 1:15.
Okay, good. Thank you. Welcome, all of you, for coming. We're going to begin by introducing the experts that we have invited to speak with you today. But I want to talk to you right now. This is for you, your enjoyment, and you can ask any question you want to ask. We'll be comfortable with it. We will do our best to answer it. But we're going to get started. And I want to emphasize that your reaction to questions or to points that are made are very important. So feel free to ask anything you like. My colleague, Dr. Noor, is going to introduce our panelists right now.
Hello, good afternoon, everybody, and welcome to this panel discussion with our panelist, Dr. Douglas Gardenhire. Welcome, Dr. Doug from Georgia State University in Atlanta. Dr. Brady Scott from Rush University, Chicago, and Dr. Ghazi Al-Ataybi from Arabian Gulf University, Bahrain. In this panel, we will focus on international collaboration and respiratory care education, and we will bring some question around education pathways. Then we will move into research, faculty exchange, and professional practice. So welcome our panelists and everybody.
So, and if I might, we may cross some boundary lines between education and collaboration and clinical, et cetera. But at this time, then, we would like to have Dr. Doug Gardenhire. Tell us about what's going on and your relationship, your university's relationship with Taiwan. And we're really interested in, and many people in the room may be interested in, the dual degrees.
Sure. So we currently have a dual degree program with Taipei Medical in Taiwan, along with Manipal Higher Education, used to be Manipal University in India, and we run 2 dual degree programs through there. So students in respiratory therapy, both of those programs get their bachelor's degree and then continue on to a master's degree in respiratory therapy at those universities. When they're finishing those master's degree, they then apply through the universities, and if accepted through their university, they would then come to Georgia State University, where they would enroll in their second master's degree program. So our program being a clinical-based program, it's a 21-month program in which they, again, come over and go through the entire curriculum of 21 months. At the conclusion of that dual degree program, they graduate with a degree from their respective university and Georgia State University. And then on top of that, our students will then sit for the National Board for Respiratory Care and then gain their credentials through that. There's an exchange of a fee that is, again, granted through those universities with between the student and the home university, which then the funds are transferred to Georgia State University, in which we use those funds to provide graduate assistantships for those students, and those students become graduate assistantships, which then receive free tuition and will then be able to be paid as graduate assistants at around $400 a month for the entire 21-month program, about $10,000.
What about the certificate, Dr. Doug? Is it a dual certificate? The name is Georgia State University, or?
No, it is not. That's a great question. No, they're 2 separate degrees. They get the master's degree from their home university, and then they get the master's degree in respiratory therapy from Georgia State University. So 2 separate master's degrees.
Yes, excellent, because we have experience here with the Ministry of Education, with University of Birmingham in the UK. They refused that University of Birmingham give the certificate for master program that conducted in Saudi Arabia. But your idea is excellent, that they have a dual certificate from both institutions.
Yeah, and what we usually try to do is we can, as a U.S. institution, we can accept up to a certain amount of hours, and we do that. We accept some of the hours that they've already taken and apply those to their degree, their master's degree at Georgia State, to try to reduce their workload by a little.
Okay, excellent, thank you.
So have you gotten far enough into it to talk about joint research possibilities?
There are possibilities, because the students are doing the research based, so they're doing thesis-based work. So there is a collaboration there between the faculties, and so that has been very fruitful in trying to understand and do the different work. Because they, again, in some of the other universities there, they're much, again, different and again, a deeper, more of a biological, molecular science, I think there, specifically in Taiwan, than maybe what we're doing here in respiratory therapy in the research that we're conducting.
Well, I really want to congratulate you, because when you say it, it sounds so easy. But
Right.
for years, and for our audience, it's the NBRC and qualifying for the exam is an interest of many, many people, most if not all. And so it almost appears as a logjam, and this is a real niche that you have discovered and moved forward on.
Yeah, this is a great a little piece that I think, I know there's some potential log jams specifically with some of the funding in Saudi Arabia currently going on. So this is a way of, again, of finding a different funding source if there is at a lower cost.
So if you have any questions at this time before we move on, and we can come back to it, you let us know. The next individual, yes, sir.
Yes, I want to tell you that those items you have in the agenda items in here are very long. You probably will need half day to talk about them. However, what he just mentioned now is basically to tell the audience that this is what we have.
Setting another agenda.
And if we have educators in here, they need to approach him if they are interested in such collaboration. Again, there are many items in here, so continue the good work. Thank you.
Thank you very much, Mr. Hassan. Now I would like to move to Dr. Ghazi Al-Ataibi. Please, Dr. Ghazi, let us about your experience with the curriculum collaboration at University of Dammam with South Alabama University.
Okay, Bismillah ar-Rahman ar-Rahim, as-salatu was-salamu ala Rasulillah. Good afternoon, everybody. First, I would like to thank the organizing committee for inviting me to be part of this fantastic events. Hassan and the group, thank you. A few years back, we had a good experience in collaborating with South Alabama University, University of Dammam at that time, which is now IAU, Imam Abdurrahman bin Faisal University. And that collaboration involves two basic things. Number one, faculty exchange. One of the faculty from South Alabama University flew over here and stayed for a couple of weeks or sometimes a couple of months to participate in teaching and also to participate in revising the curriculum, developing some cases for the problem-based learning. And the other thing is teaching. They were involved into teaching courses as they are here. And I think at that time the collaboration was for full academic year, where we had 3 faculty came consecutively from South Alabama University to participate in that collaboration. I think that collaboration was brought experience to our curriculum. At that time also we were on the verge of converting into PPL or TPL, and we were working on the structure of the curriculum, and we were working on the building cases, and those expertise came from South Alabama University. They provide help into constructing and writing and revising some of the clinical cases for the program. And I know that now they already started that curriculum. It's up and running now. So it was a good experience.
Yes.
And I hope that experience will be repeated in a different level and different scale.
Thank you very much, Dr. Ghazi. Yes, you are right. The first batch will be graduated this year, inshallah, from this curriculum. And they are progressing very well, and they are gaining a lot of skills from this new curriculum.
So, any of our audience have specific questions or comments they'd like to make at this time? All the mics on the floor are sound activated, and you're welcome to use them if you have a question. If not, we'll move on.
Everybody's asleep after lunch.
Yeah. Wake up.
Already. What do you want?
Okay, so we'll next move to Brady Scott. And I wonder if you would comment on if there's a linkage, and I think there is definitely a linkage between what's happening in AI education right now and what's happening in our programs that offer simulation learning and things of that nature. So can you comment on those some of those ideas?
Sure. So I think it's not new that simulation is embedded in a lot of our curriculums. I think that that there's an opportunity for nowadays simulation includes augmented reality and virtual reality that I think that allows us to be in the same room together even if we're on different continents. In terms of artificial intelligence, I think right now in academics, at least in my experience, I feel like that we are still trying to get a better understanding of the use of artificial intelligence and how we can improve student learning versus having artificial intelligence do things for them. And I think that that's kind of where we're at. I'd like to tell you that we're farther along on this, but I think we're actively learning it. I have a little bit of a talk tomorrow on artificial intelligence, but I think what we're going to find is we are going to be able to utilize artificial intelligence to meet the students on some things. Like, for example, there's a little bit of new data that's not great, but some local institutions are finding that AI created lectures are actually, the students enjoy them more because they're doing them as podcasts and other ways that students are consuming them. So I think that what we have to do is talk as a community a lot about how we are not trying to get around AI because it's here. It is what it is. It's so available to our students. We have to utilize it and its strengths in order to improve learning. That's where we're at with AI.
So, did you comment on distance learning?
No, I didn't. I can. In terms of the simulation aspect, I think that I think there's room for all of us to consider how simulation can improve the student experience, and I think we can do that. You know, I think a lot of times we think about a simulation curriculum designed around tasks, drawing ABGs or those things, but the reality is we can also focus on simulation curriculum evolved around the affective domain of learning, you know, behaviors and communication skills. And I think that, again, I think one of the things that's exciting for me and something I've been exploring a little bit, and I've actually put some research grants in and I have not been funded on them yet, maybe I will, is actually creating a virtual classroom, even at the virtual bedside, where literally students from Dammam could be in certain situations in the same ICU as my students, working on problems together. And I think there's a real potential there for the future. I haven't done it yet, but I do believe that exists.
And as you approach that and you look at that, it also opens up exciting possibilities for faculty exchanges that will change the way we do business.
Yes. Yeah, I think so. I think that, you know, at some point in the future, I think even accredited RT programs are going to be officially allowed to utilize simulation as part of the curriculum. So I think this is going to be more and more embedded into how we teach our students.
Take the other two.
Okay.
Could I talk about some difficulties if you want?
Yes,
Different
please.
experiences? Okay. Well, I had experience working with many collaboration projects as a dean of the college and later as a vice president of Dammam University and currently as a vice president for academic affairs at Arabian Gulf University in Bahrain. Most of these experiences are in different disciplines, non-RTs. I'm not going to talk about the details about these projects, but I will talk a little bit about the challenges. When you embrace a collaboration program, whether it's completely dual degree, just like the program you explained, or just a collaboration in one aspect, like the one I explained with South Alabama University, we faced many difficulties. I think one of the major challenges is the cost.
Yes.
Collaboration involves high cost, and some universities are not ready to pay for that cost. And even if they are able to pay it for 1 year, they will have a problem sustaining that program for a longer period of time. The other thing related to clinical training, clinical privilege. We used to send medical students from Arabian Gulf University to do some training in the States or in Canada or in some European countries. And the issue is that the clinical privileges are not given to them because they are in the internship phase, considered to be students for a legal reason and liability. Therefore, they spend much of their time in observation instead of doing an actual work, clinical training. The other thing that we faced is the credit transfer system. We tried one time to work with the university from Finland in a dual degree program, and we end up closing that project because we did not reach an agreement about how credits are transferred between the two different universities. You know, in Europe they have different system into transferring credits, and mostly in our region we use the credit system, American credit system. So that's also one of the challenges that we faced during those programs. On the other hand, we have very successful stories in working in one of the MBA program with the French university. It's a full-fledged dual degree program where the MBA is given is taught at the Arabian Gulf University with the help of ESSEC University in France. They teach 40% of the program, and we teach 60% of the program. And that program is running for at least 10 years with the support of the French embassy in Bahrain. So that's one good example of the good collaboration in a dual degree program. And they don't give 2 certificates, they give 1 certificate issued by both universities. I think that's an advantage also, to have 1 certificate issued or 1 diploma issued by 2 universities.
Thank you very much. Yes.
I would just like to comment. I think those are some great things. But I said, if we're looking at cost, one of the great things we have now, the internet, that we've been very successful with at our university is virtual exchange. So having that agreement, virtual exchange, I know there's some time differences, but 8 hours is much easier to deal with than either 12 or 16-hour time differences. So we're again using students from around the world, where we're able to have our U.S. students along with those international students in whatever country they are in a virtual classroom together, learning together, and again offering different certificates, which again we have, not necessarily degrees, but there are some of those options, which can cut those costs for institutions.
Great.
Okay, thank you very much. Moving to our next question, it's for all of you. So whomever want to answer, he can do so. As respiratory care continue to expand in the Middle East and particularly in Saudi Arabia under the vision of 2030, international collaboration become very essential, especially in research. So what opportunity exists for joint international collaboration and research in respiratory care? And what are the important topics that you want to do research on international level between universities?
Well, I can start.
Yes, please.
I think as a profession, we need to look at the medical profession as watching how they collaborate. For example, in Europe, the European physician model, they're wonderful at collaborating across countries to enroll people in prospective trials. I will tell you that this is, in my opinion at least, it appears that they're much more likely to collaborate across institutions in Europe than they are even in the United States. And so I think that what we need to do is think about how we need to collaborate to solve respiratory care problems and to collaborate together to enroll enough patients to answer questions effectively. For example, I am currently working to build more of a collaboration in at least 2 institutions here in the kingdom to help enroll in a randomized control trial. The type of trial that I'm designing is relatively slow enrollment. I need large numbers, and I also want it to be representative of a bigger, larger population. Yes. So I think that if I can get that collaboration, I think that the project will be more robust. We can get it done in a reasonable amount of time. not 10 years, right? I don't want to run a randomized control trial for, 5, 8, 6 years, which is the reality of the pace of enrollment. And so I think that having this kind of collaboration is beneficial for the profession in general and our patients that we serve.
Yes.
This goes in both directions, right? The primary investigators can be Saudi investigators, but collaborating on projects and doing those things will answer more questions. We have to realize that in the respiratory care profession, there's a lot of things that we do that are not based in strong evidence.
Exactly.
And it's very easy to figure this out if you read any of the AARC clinical practice guidelines. If you read the clinical practice guidelines, which are very well done, you'll see that there are many things that we recommend that are based on weak or moderately strong evidence, not strong evidence of like randomized controlled trials. So I think that there's a lot of things that we could do together to increase enrollment into these studies that will shorten the time to analysis and to get the project actually done, and it will benefit our patients around the world.
Yes, thank you very much. Anyone want to add? Yes, please.
I think collaboration in research is much easier than collaboration on a curriculum or educational programs for many reasons. Number one, usually research is supported by institution. Usually there are grants for research, so it's easy to come up with a project and secure a grant from your own university and communicate with any university or any research groups in the States or in Europe and anywhere in the world and get that collaboration. The other motive is related to ranking. All universities are pushing their staff to do a collaboration research because, again, this is going to be reflected in the university ranking. And the appetite for research is very high, the faculty, so I think this is a great motivation for every faculty to work on research. And I know many of our colleagues and friends, respiratory therapists, working on projects with the collaborators in the United States and other countries of the world.
Yeah, I would say if you're thinking about research and how to do research, I think it is just finding that individual to make that collaboration. As Dr. Scott mentioned, he's associated with a medical center. And so again, some institutions are better aligned to be able to provide some of that clinical data that you're looking for. But I think others, if you don't have that direct connection to a clinic and having your own hospital at your own university, there's other ways to do that. So as we just heard just a minute ago, again, finding a problem and how can we work on that between students and students or faculty and faculty at different institutions. And ultimately, to me, one of the easier things to do, even though very difficult, but without doing clinical trials, is looking at systematic meta-analysis. That's something that's very easy to do, cross borders, that can be, again, very high impact.
Okay, thank you very much. Especially that nowadays in Saudi Arabia, we have a big fund and big support from the government regarding international collaboration and research.
I just simply wanted to add, I think that by collaborating, we can create projects that are designed in such a way to make a tremendous impact. Yes. So if you think about in 2013, the Perceiva study was a prone positioning study that was published in the New England Journal that literally changed global practice, right? Yes. One of the first things we looked at, it was done in two countries, 28 or something different centers. That kind of information changes practice, right? Yes. So yes, I do have a hospital that I'm associated with, but having a single center is not enough, right? Yes. We have to collaborate with each other to collect larger bodies of data to create projects that actually drive patient outcomes and change. Exactly. And I think that if we keep centered on us putting together our brains and our resources, we can drive, think about the future and how that will change our practice from here on out. And then ultimately change for the positive patient outcomes.
Exactly. Thank you very much. You,
Yeah.
you just mentioned excellent experience of the European countries.
Yes.
They write the guidelines together. They write the scope of practice together.
Yes.
So we would like, as a respiratory therapist, because we belong to US in our profession, so if they allow us to work with them on the guidelines, on the scope of practice, on the
Yeah.
competencies, writing competencies that work for both countries with their with their authority as well, national authority.
Yeah.
So moving to you, Dr.
Yes, and I would wonder, and at this time, are there any questions or comments on any of the material talked about? Okay, there's a bonus in it if any of you react.
Everybody's still asleep after lunch.
Yeah.
Maybe we should make everybody get up and stretch a little bit, or just kidding.
I wanted to ask any of you, as we work through this, have you yet contacted anyone at the NBRC, for example, regarding building a model that had great potential of being approved?
In terms of what kind of a model would, just any kind of model?
Now, similar to the one that you have, to qualify individuals who really want to sit for the exam and get that credential.
Oh, yes. I think, ultimately, it depends upon if that's the goal of yours. I can look out there and I can see several individuals that have come to the States and have gone through different curriculums to be able to sit for the national boards. One of the great things that, again, in doing that is any of the programs that, again, are collaborated with in the U.S., as long as you're going through that clinical-based program, whether it's at the bachelor's, master's level, that clinical entry part will allow you to sit for the national boards. Once you sit for those national boards, then you'll be able to have those credentials and are eligible for state licensing across the U.S. And with that would then allow you to move into what's called OPT, or optional practice therapy. In the United States, a student visa can be converted for 1 year post-graduation from each degree. So if you have a bachelor's degree and you're a registered therapist, you have a license, you can practice in the United States clinically for 1 year. If you come back and receive a master's degree and you graduate from that program and you're a registered therapist or are able to become a registered therapist and have a license, you can practice for 1 year. And you can do that all through the doctoral level. So there's opportunities with programs in the U.S. to be able to sit and stay in the U.S. to learn from having more, I think, some U.S. clinical-based experiences, which I think is really good for a lot of different students to be able to see how things are done there and, again, be able to put those in practice as you return to your country. The other additional piece is individuals who do have the ability to be state licensed is that if you're in a degree program, you can do what's called CPT, which, again, is a continuing practice therapy that allows a student that has a student visa to be able to be processed, to be able to work outside of the university in a hospital as long as they're licensed.
Okay, thank you very much. Moving to our next question about faculty exchange. What strategy have been successful in implementing faculty exchange or visiting professor in respiratory care programs? Do you have any experience with faculty exchange and visiting professors?
We do. I mean, no matter what international agreement that we make with any university, it is by law. It's part of our standard practice that it includes faculty exchange. And so that exchange it makes the ability for faculty from that university to come to the U.S. and vice versa. The problem that we have in those agreements is ultimately funding, which we heard about that already. The funding, if there's a funding model that allows for the travel and the stay, if you will, for those individual faculty members, continues to be the highest difficulty that we see, and why we don't maybe have as much exchange. I think it has to do with the funding.
Yes, we have a great experience in Dammam University, in College of Medicine with Monash University. We have visiting professors from them. We have faculty exchange. So I think it can be also with respiratory care as well.
Yes.
Dr. Ghazi, would you like to add something?
Yeah, but we have several examples, Dr. Noor. Monash University in medicine, Canberra University in industrial design, and we have several examples. Now, and I think the example I gave about the collaboration with South Alabama University was an excellent one, but it was very expensive. Now, I think the use of virtual classrooms now, with the use of technology, will make it easier, will make it almost with a very low cost. And this is the model we are moving into. Most of the faculty, visiting faculty or external faculty teaching at Arabian Gulf University now are doing this through the virtual classrooms. So that's easy for us, that's easy for them, and that's cheaper for us.
Exactly.
I think this is this model, everybody is moving towards that model. Speaking of faculty exchange, I was thinking about how many respiratory care programs in Saudi Arabia now. I don't know, around 15, maybe 17? Around 15 programs. And I understand that some of the programs in Saudi Arabia are calling faculty from other colleges or university to teach in their own because of the shortage of faculty. So if we implement the virtual classrooms, which is available now in different modalities, I think this sort of collaboration, faculty from Dammam can teach in Riyadh and Jeddah and everywhere. I'm not sure if this is happening right now, but I think I was reading about something called COIL, Collaborative Online International Learning. If we use this model as a COIL in a collaboration within the RT or RC programs in Saudi Arabia, I think we will save a lot of money, and at the same time will bring up the quality to the highest possible. I remember King Saudi University, one day they tried to do this model with Saudi universities, and they took the initiatives, but unfortunately that initiative was not materialized because of the legal issues. But exchanging faculty can be done easy now with using technology.
There is also, thank you very much, Dr. Ghazi. There is also a good example with Saudi Electronic University, with Colorado University. They have hybrid education and faculty teaching through virtual and distance learning. So I think it can be copied into other universities in the kingdom as well. Would you like to wrap up?
What's that?
Would you like to wrap up?
Yes, I think unless there's any questions from the audience or comments from the audience, we're going to start to move to the next section. And we want to thank you, gentlemen, each and every one of you, for your comments and direction. And I hope that many of the things we're talking about actually come to fruition. Thank you very much.
Thank you very much, our panelists and our audience. You will be staying for the second one. You are in the second.
Yeah,
also.
yeah.
Yes. Thank you very much.
Yeah.
Thank you, Julia.
Mm-hmm. Okay, we're trying to straighten out our time difference between the schedule and the. Oh, yeah. Is that right? Oh, thanks. As soon as we get our faculty wired up, we'll make some introductions and move forward. What's the plan for dinner tonight? That's a faculty dinner. Did you get the note on that? I think so. Yeah, this is a real nice dinner again. I'm pretty sure I did. I just didn't make note of it. Yeah, it was just recently. Okay. I suspect they'll have champagne, right? Only if. Only if. Okay.
Oh.
All right. We're going to move ahead, and I'm going to make some introductions, and then we're going to explore some of the services management issues that come up in respiratory care. And I'm going to ask, and when I call your name, if you'll stand, I would like to have Dana Evans
Stand.
stand.
Oh, all right.
All right. Dana is the president of the AARC and has agreed to join us in this discussion, which we'll come to in a moment. I'd like to move from Dana then to Carl Hingston. Carl is the immediate past president of the AARC and is also chair of the American Respiratory Care Foundation. So we will move forward on questions there. And then friend and colleague, Emily. And Emily is the director of the RT Pulmonary and Asthma Program, Children's Hospital of Orange County, California. So thank you for being with us, Emily. And I'd like to also introduce you to Mr. Dan Garrett, who is the executive director of the AARC and is sitting on this services management portion of today's meeting. And again, as we specified in the first session, if you have a question or a comment, or there's areas you think you can contribute, please let us know. It's supposed to be interactive. With that, Dana, I know you have another presentation regarding the future of the respiratory care profession, but we'd like to hear some of your thoughts on that at this point in time.
Oh, sure. So I think the respiratory care profession, I assume I'm in a room of people who will agree with me, is incredibly bright. There's so much good that's been done, but so much more to come. So from my perspective, I think the focus in the future is adherence to evidence-based medicine. We just heard Dr. Scott and others talk about the paucity of evidence in a lot of the work that we do. So along with that comes with more research, more clinical-based trials, randomized control trials to really build that evidence pool so that we're making sure that what we're doing for patients is not just what we think is right, but what we know based on the evidence is the best choice for them. I think in alignment with that, that goes with our clinical practice guidelines and meta-analyses and other things that we're starting to see become published more and more regularly. The other thing that I'm very excited about is the growth and expansion of the advanced practice respiratory therapist role, which we could talk about all day, but I think there's some exciting opportunities moving into the future to utilize these hired, master's prepared respiratory therapists who have a degree in advanced practice respiratory therapy to serve as physician extenders and really caring for our patients in a way that has not happened before. I mean, who better to care for our pulmonary patients than respiratory therapists? So I think, we could talk about this all day, but I think there's just so much on the horizon for us. But when I think about the two big things, it's evidence-based care, the way we approach medicine, and this extension of this new profession in the advanced practice respiratory therapist.
And can you comment on threats to the profession, perhaps, territory and competition between other services?
Sure. I think the biggest threat to our profession, so I'm not sure how what it looks like in the kingdom, but in the U.S. we have a significant shortage of respiratory therapists. We do not have enough respiratory therapists to meet demand, and we know that there's a large portion of our profession planning to retire. So we need more programs, bigger programs, fuller programs, more people entering the profession than we have right now. And I mention that as a threat because if we don't have respiratory therapists to do the care, someone else needs to do that, and we don't want to lose the ability to function at the level that we would like to be. We certainly don't want to lose autonomy. We don't want to be able to have to hand off services simply because there aren't enough of us. So that's probably one of the biggest things I see. And there are some payer issues and other things that are very specific to the U.S., but I think the shortage of respiratory therapists is the biggest challenge I think of when I think about our profession.
Well, thank you, Dana. Now, because you've been involved for a number of years, department structures, past and present, do they have some role to play in the future?
Well, in the U.S., there's been lots of different department structures. So I've been a formal RT leader for 16 years, and I currently oversee 28 hospitals across 2 states in the U.S. It's about 1,000 RTs. And our model is the same at all 28 hospitals, but we've seen decentralized departments. That's probably the most common secondary model that we see, aside from centralized departments where one RT leader would assign respiratory therapists throughout the hospital. Decentralized would mean that a respiratory therapist was not employed by the RT department, but was employed by the NICU or the PICU or the medical ICU. And I think models like that are extremely detrimental to respiratory therapy because they've lost their team. Right? There's no one to call upon, no one to support you when you really need that. I think we all know that there are days where we all have to go to the same unit at the same time to support multiple emergencies, and I think when you decentralize, that's a huge problem. That's really the only other true viable model I've seen in terms of department structure. I say viable, but I don't actually think it's viable in the long term. Most places I know that have done that have eventually gone back to a centralized model because it allows for respiratory therapists to work in multiple areas, but also support each other when the need arises and volume and acuity suddenly spikes.
And I'm not going to let you off the hook here. Relationships with medical staff, administration, and other services. There's a lot of variables that come into that, but perhaps you would like to share your thoughts on that.
Yeah, I think if you want to be successful as an RT leader, you have to be as close as you possibly can to everybody in the C-suite. The chief executive officer, the chief operating officer, the chief financial officer. These are people that should know you by name, and you need to have a good relationship with them. Our CFOs, I get to deal with 28 of them at 28 hospitals. Our CFOs know who I am. It's important that they know who I am because later when I ask them for money, that's not the only time I call them, right? We have lots of great conversations and we talk about cost savings and how we can be more efficient and effective in the way we do care. And I have different conversations with our chief operating officer about business effectiveness and being thoughtful about billing and other things. So I think that the secret to being successful is having a strong relationship with these individuals before you ever need anything from them. That's true of medical directors. And, we all have department medical directors, but there are medical directors of every unit that we work in as well. And so I make it a habit of meeting with them regularly and insisting that our site leaders meet with theirs regularly as well. So again, they understand the expertise, the value, the importance, and the competence of our respiratory therapists long before we ever need them.
One very critical individual, the medical director for a respiratory care department. Could you expand on your thoughts on that, Dana? And we can ask other members of the panel up there the same question.
I think we should. I think we should. Why don't you jump on that one,
Yeah, I'll
Carl?
jump on that. I'll give you a break. So in the United States, the respiratory care medical director is one of the few services that the Joint Commission and CMS actually says needs a medical director. So that's provides a unique advantage to respiratory therapists. That being said, the relationship and the quality of your medical director is tantamount to the department's success. The medical director serves as your voice often and sometimes your arbiter to the medical staff. Mm-hmm. And so you need to have a strong medical director that understands not only the clinical aspect of respiratory therapy, but understands some of the business challenges that respiratory therapy leaders face. So you need to have a strong relationship with that individual. You need to have a collaborative relationship with that individual, because at times that individual is going to have to go support you in conflict in other areas, and is going to be your, for lack of a better word, the avatar that's going to fight your battles.
And so that relationship with the medical director, you and the medical director and your staff is pretty tantamount.
Carl, to sort of follow up on that, where do you think leaders have leverage in terms of culture, data, compensation, scope, et cetera? Where would you say the point of that leverage point is?
So the leverage comes from, I will say, as a leader in a healthcare system, whatever department you are in, you want to be seen as a person who solves problems, small problems and big problems. So data is the weapons, if you will, or what you will use to convince the other healthcare leaders to your needs, whether it's quality of care, quality metrics, the need to better pay your respiratory therapists. You may come to them with the salary analysis of your competitors, the agency costs that you provide, the overtime costs, and say, if we increase our wages X amount, then we will reduce overtime costs. Or if I provide these services, then we'll have a cost savings. I'll give you an example from a project that I did in the past. Is we did a project where we started scoring, because of the hospital I worked at the time, we didn't provide all the nebulizer therapy to floor patients. We developed a scoring system where we would take the most high-risk patients, and we would see those patients, and we would deliver those nebs for those patients. And this was tracked by the hospital. We did a pilot project around 6 months. And I recall very acutely the day that we were going to go meet the data analysis and look at the results, and the off-going night shift was like, great, we can finally get rid of that project. And then we went and met with the analyst, and he was like, oh my gosh, you guys did such amazing work. We published the results, but ultimately, because respiratory therapist was out on the floors intervening on patients, we dropped respiratory-related rapid responses by 70%. There was a detectable detectable decrease in readmissions and COPD length of stay. There was associated cost savings with our intervention that we weren't allowed to publish those results, but was pretty substantial. And pretty much after that project, whatever we asked for, we got, because we had solved the problem. And this I always talk about when departments talk about how respiratory therapists is really in the critical care. We provide value to the hospital wherever we go because of our assessment skills, because we have a natural tendency towards problem solving. We're often called into patients in crisis and we're trying to solve the problem, called into an ICU room where there's a ventilator malfunctioning and kind of solve it. So respiratory therapists are natural problem solvers, and it's leveraging that skill set with data that gives us credibility with the healthcare leadership. That really is the difference between departments who thrive and departments who struggle.
Thank you. I want to pivot a little bit to workforce and retention, and I think I'll direct this towards Emily because of your high energy and pep that you bring to the profession. What strategies have truly improved recruitment or retention in your organization, particularly around, since we have a workforce shortage, what have you found, if you found, what your sweet spot is for recruitment and retention?
Yeah, thank you. And it actually goes back to the first question of when we asked Dana, what is the biggest threat? And my mind actually went to the biggest threat, but biggest opportunity we have is this is all dependent on the leaders that we have leading our teams at the bedside, right? Like the APRT is great. We have all these RT-driven protocols, but if in your institution, your team is disengaged, you don't have a leader who can inspire that greatness, if they just want to do their vent check and leave, it doesn't matter if we work on all of these things, if we're not giving leaders who have to now inspire 100 RTs to do well so that they can convince the bedside teams that they have this critical care, that they are passionate, that their patients will do better. And so I think one of the biggest opportunities we have is to really invest in this new generation of leaders. Because as we all know, I know it happened to me, we were the best at the bedside, we got picked up, plucked, and put in a management role, and no one told us what to do. right? You give me my patients, I will take care of them, I'll be the best at the bedside. You put me in front of 160 RTs and tell me what they do, I am responsible for how great they do at. So inspiring and influencing others' behavior and their success is so much harder and has its own set of skills and competencies. So I really want to say, if you're a leader, if you're thinking about it, it is skills and competencies that you have to learn and study and develop in, because being in charge of others, it's a privilege. It's incredible to be able to inspire RTs, and there is science and there's skills, and so you can't accomplish this if your team is disengaged, if you have a toxic culture, if they don't feel inspired to go above and beyond and operate at the top of their license. And so there's a lot of that, and so I think the first thing we need to do is inspire and give our new leaders the skill sets they need to be able to drive this behavior. And I think it comes down to, my thing is, think about the best leaders in your life. Think about the mentor that made you the RT you are. Did you know their budget? Their productivity? How many papers they published? You probably remember how they made you feel. You probably remember that just because of the way they interacted with you, you felt driven, you felt seen, you felt valued. If you made a mistake, the way that they empowered you, and you by yourself changed your performance and behavior. Those are the leaders that we remember, and those are the leaders that produce the RTs who are going to do the great things at the bedside and in research and in education. And so I think if we focus on our people, take care of them. Do you know them? Are you connecting with them? How do you address poor behavior? And how do you address if there is a mistake? Are you creating a psychologically safe place to learn and grow? Are you creating an environment where we don't eat our young? That's a claim, but how are you treating your new grads? How are you treating the new people who come in? And how is your staff giving each other feedback so you all grow? Those are all the departments we want to stay in. A department that has high turnover and is switching out RTs continuously will never have great RT-driven protocols, because we need consistent people. So I think it starts with the leader and giving them the skills, connecting and caring about the people who are in your watch, and growing as a leader to inspire greatness.
That's great. Dana, where, with COVID in the rearview mirror, so to speak, in terms of burnout, where do you think we're overestimating or underestimating in terms of burnout?
Who in this room does not feel burnt out? Right? Nobody raised their hand. I think that's the reality of the situation, right? And I don't think COVID has anything to do with it. I think COVID made us all reevaluate what was important in our life. And really made us step back and think about where I dedicate my time and what's important to me. But I do think all of us go through phases of nearing or actually experiencing burnout, and there's great data in the literature to support that inside of COVID and also out of it. And so I think this goes back to what Emily said. As an RT leader, it's my job to create an environment that reduces the opportunity for you to experience burnout. It's my job to make sure that we're creating an environment where work-life balance is where it should be, that I'm not making it you feel like you need to come in 7 days a week because we're short-staffed, that we're being thoughtful about workload, that we're being consistent in our approach and the way we make assignments and things of that ilk. But I do think we all go through it at one time or another, and sometimes it could be because I'm working in the ICU and I've had several bad outcomes and I'm just really feeling it and it's hurting me. Personally, because of what's happened to those patients, and that can do that, and we all have to think about recharging. I personally no longer like to be told that I need to be resilient. I don't need to be told that anymore. I understand that we have chosen a profession that is emotionally taxing as much as it is physically taxing because of the work that we do. But I don't need anybody to tell me to be resilient. I know that. But what we do need to do is think about the ways that we individually can recharge and reset. And that's different for everyone. I know Emily likes to run, and eat French fries. That's what she does, and and I like to be with my family, and everybody's a little bit different in the way that they do that, and I think you have to understand what is your recharging point, what is your reset point, and that's between you and no one else, right? That's very personal, and making sure you have time for that. But as a leader, my job is to make sure that you're not doing the work of 3 respiratory therapists today, and certainly if it happens on a random day, that it's not happening regularly, because that is the fastest path, I think, to burnout and emotional distress in the way, and moral distress, right? Because if you're a respiratory therapist who has the workload of 3 respiratory therapists, it is extremely unlikely that you're going to be able to give the best care to every single one of those patients. And I think that causes moral distress, particularly if something goes wrong, because you blame yourself, you weren't available, you weren't able to do the care you wanted to provide. And that's on me as a leader to make sure you have the resources you need, and to sell that story to our chief financial officer, et cetera, to make sure we have what we need to balance that. But I think it is unrealistic to think that in the profession we've chosen that you'll never experience burnout, because it's the nature of the work that we do. The question is, how do we mitigate it, how do we reduce it, and how do we reset and recharge?
Carl, what over the next 5 years, what type of leadership skills do you think are going to be essential as that we evolve over the next 5 years?
So leadership skills that I think should be essential for the next 5 years. When we think about respiratory care leadership, we have to recognize that we have turnover in our leadership cohort, and we are not providing good education to them, good mentorship to them. And what we need to be providing them is how to lead others, essentially basic leadership skills, how not to do a burnout, how to create an environment where people feel like they make things happen at work. But there's also some hard skills that leaders have to have, budgeting, productivity, doing performance for business proposals. Those are hard skills that we need to start developing for our leaders. We are having a lot of leaders that, like, as Emily says, because you got picked up because you were good at doing clinical care, you're going to go and now be a leader and be somehow successful. Well, that's not how life works. A lot of the skills that make successful leaders are being able to do a project, having integrity, being trustworthy. So developing those skill sets for leaders, I think, is essential. I also think it's essential to start preparing our current cohort of leaders to seek employment in the executive office suite. I think there's a lot of, we now are seeing more respiratory therapists going into that role, seeking those roles, and I think we need to begin developing more respiratory therapists who serve as chief executive officers, chief operating officers, VPs of executive directors that are in the C-suite, because we have the clinical background. We're not nurses. We understand how the hospital works from the bedside's perspective, and I think in the United States, at least, we find that that's a voice that's now absent. We see a lot of system leaders and a lot of local hospital leaders that are being pulled from the business backgrounds because this is the kind of the nature of the U.S. healthcare system, but they don't understand, and this is my criticism, they don't understand moral distress the same way that we understand moral distress. And you need to have, I believe you need to have a definite proportion in your executive suites of individuals that understand what it is like to give health care at the bedside, and what it is also like to give health care at the bedside when things go right, and health care at the bedside when things go wrong. So the skill sets that we need to be developing is those hard skills, the budgeting, the understanding of hospital finance, but also the soft skills of not just leading a group of, a shift lead of clinical leaders, but developing people who can lead other leaders. And that is something that I think we need to be developing within our workforce.
Before we move, I want to jump in on that, because Carl said something that I think is so important, and that is that RTs belong in the C-suite. RTs belong in the C-suite. RTs should be leading healthcare systems, and they should be leading the work that we do, because we are skilled, We are knowledgeable. We understand what it's like to work in every single aspect of the services that are provided by these hospitals in a way that many disciplines do not. And I agree, I do not think that you can be told what it is like to care for a patient who dies in front of you. Right? This is something that you experience, and I think you take that with you into those senior leadership roles. So I encourage all of you to think about that if you're in a leadership track and this is something you want. The more RTs we have in senior leadership, the better it is for our patients and the business of healthcare. So I thank you for saying that. I think that's so important. We don't talk about it enough, but RTs belong in all the seats, in all the places that healthcare is done.
Okay, let's say that we capture all of this and we try to implement it. I want to ask Emily, I know you have a presentation on why teams fail, but I'd like you to comment, because if I could get a gang of very successful respiratory therapists that were clinically competent and so on, why did they go over the cliff?
What do you mean by?
Why does the team fail?
I will be talking about this all tomorrow. I think it's a lot of what I talked about before. I think we've all probably experienced in really great departments and really toxic departments. And if you thought about what made one better than the other, and there's probably not one thing that a leader said or did, but it was a vibe, it was the energy between people, it was how nurses treated RTs or RTs treated RTs. And I think teams fail when the leader is not equipped to manage the culture. And I think we misunderstand culture. It's a buzzword, and it's not the number of parties or how much fun. Trust me, I have a lot of parties and a lot of fun in my department, but I will tell you that's not what I'm driving as a culture. We are driving a culture of high accountability, which means we are going to hold a certain standard. We're going to address the poor behaviors. I think that's one of the hardest things as new leaders. We're so scared to have that hard conversation. But when your team sees you tolerating poor behavior and not addressing it, that is the biggest demotivator to your high-performing RTs, and it tells them you don't care about quality. You think you're being nice, but there's a lot of research that shows that employees that view their leadership as holding high accountability actually have higher engagement. So your team wants you addressing the hard things. They want you creating a space where we're going to have those hard conversations. They want a place where you are creating new paths to grow. Do you have a clinical ladder with multiple opportunities and more involvement? Are you letting them have a voice in the work that they do? Do they get to be in committees where they're actually making the decisions? It's not a top-down, you don't make the decisions, you actually elevate your RT's voices. So that Carl was talking about, do they have agency? Are they responsible for the changes that they want to see out there? And there's ways to advocate in your leadership role for your RTs to have that. And so I would say teams fail when you can't create that type of culture. When they are clock in, clock out, see my patients and leave. I'm not by any means saying that we have to believe that work is home, or I always respect that. But when they are there, are they passionate? Do they feel the impact of the work? Do they trust and know everyone working around them, and will always do what they can to take care of their teammates and you as their leader? And there's certain things that you can do and change about your leadership that creates that kind of team.
Thank you.
Can I add on to that?
Yes.
Just a bad leader can destroy culture faster than anything else. And you've got to get, if you have a situation where you have a leader that is poisonous and destroying culture, and it's not always obvious. And sometimes it takes a little bit of discernment to kind of like, okay, this is the real issue. You've got to get that leader out of that position.
Dana, how are compensation, flexibility, and career advancement interacting today?
I think that new graduates in particular today expect you to create a career pathway for them, right? They expect you to help them understand how they can grow, how they can mature, pick up new skills, new job titles, and move along in that pathway towards whatever it is their end goal is. I think compensation comes along with that. But I think more than anything, creating a vision and a career pathway and showing them what could be next or across the continuum of their career is so important. That's something we do. I try to be really intentional about in our organization. So I'm really lucky. Within my hospital system, I have large academic level 1 trauma centers and small community hospitals and children's hospitals and pulmonary function labs, and really can create growth opportunities for folks wherever it is they want to be. There are some people that decide that they're at a point in their life where they no longer want to work at a trauma center and they'd like to work at one of our smaller community hospitals. And that's wonderful. We can create that pathway for them. Others want to become educators, and how do we create that vision and plan for them? Others want to become leaders. How do we support and train and mentor and lift them up? Like Emily and Carl said, to prepare them for that next step. And I think that is the most important thing. I think it leads to engagement. I think it supports them. I think the money comes along with it. But really creating that vision for what could be next, what they could be, and asking them, what do you want, and helping them get there, I think is paramount to success of teams and creating this really positive culture, and recognizing that for them it may just be being the best bedside respiratory therapist they can be, and we need those folks. And so how do you create clinical pathways as well in the same way?
To sort of continue that, for those of you who don't know, the American Association for Respiratory Care provides continuing education for respiratory therapists. And we have found, and listening to our members, that soft skills are very important in terms of continuing education, providing leadership training, and those types of things.
I want to jump on that, though, because
please.
I feel this way. I hate the term soft skill.
I was going to say.
I hate it, because what is soft about having a critical conversation?
True.
It's a hard skill.
True.
It's so hard. What they are is not physical tasks, right? So learning how to hold some accountable, learning how to have a difficult conversation, learning how to lead a team. We call them soft skills, but they're so hard, and they take education and training and experience, right? Just like you did not suction a patient the very first time you ever tried to suction a patient perfectly. This is the same, right? And allowing ourselves space to learn and grow and make mistakes and try again, and having that education is critical. And I think those education sessions are important, but there's nothing that's a substitute for experiential learning and mentorship.
Thank you. We have someone from the audience that would like to make a comment or have a question. It's sound activated. Just get a little closer and talk at it.
Hey everyone, thank you very much for this very insightful talks. We in Saudi face a slightly different, complicated issue with respiratory care. And since we have current and former AARC president, I would like to get your inputs, experience with this issue. The hospitals and medical services encounter severe, moderately to severe shortage in terms of qualified respiratory therapists. At the same time, we have about 15 to 17 bachelor RC program graduating therapists every year. And those graduates usually take some time to be employed, and most of them are currently unemployed. As an association for respiratory care in the US, I don't know if you encounter several issues, or I want to seek your input on how the association can advocate or change maybe the policy to help with this current phase of...
So I want to understand what you're saying is that Saudi currently has a lot of currently unemployed, employable respiratory therapists?
Yes, I don't have the numbers, but comparing with different programs, yes, we do.
And
at the same time, there are severe shortage in hospitals.
In Saudi as well?
Yeah.
So I'm trying, help me understand the issue is why is the hospitals not hiring the...
recruitment issues.
Oh, is it money?
Probably,
yeah,
but
okay.
I just want to ask about the role of AARC, for example, in similar issues when respiratory therapists face such complicated situation.
We switch hats for that because this is where I put my director hat on and when I address these issues. And so in my role back in the States, I had a very large portfolio. I had all of diagnostic imaging, all respiratory therapy, rehab therapies in my portfolio. And so this was a common theme that I saw with many of the professions is that I had one campus that was severely behind market. And when we looked at what was driving the market change, or what was driving why we couldn't hire people, was the pay. And so if people can't get the pay, I'm assuming that these hospitals that can't hire are using a lot of overtime and are using a lot of agency. And there's also the where you start to look at the quality of care being gone, right? So when we look at when we are trying to advocate for staff, we look at, okay, if you paid better, then if you had a better compensation package, then we would not be spending this much on overtime. Then look at the quality issues. What is being missed because therapy is being missed? And then we have, at the association side, we have a tool called the Safe and Effective Staffing Guideline, which is supposed to be a tool to provide for leaders to say, this is based on value-based care, this is the number of staff that you need. So that's a subscription-based service that has been developed over decades to provide a tool to leaders, say this is how we should be staffing. So trying to really kind of understand, that's how the association's been trying to help. We put out the staffing guidelines. We have white papers on how staffing should be done. We have the safe and effective staffing guidelines. We provide tools to say this is the level of care that should be delivered. On the director side, I am making the argument that because the compensation is bad, look at these poor quality outcomes. If you had paid these, if you recompensate these issues, then these quality issues go away. And it could be, it could be ICU throughput, delays in extubation, bounce backs to ICU. In part of my portfolio, probably the best example I had CT techs rolling up to me, and I could not hire a CT tech to save my life. When I've had that problem, I can make the other CEO, the CFOs, the CNOs sweat when I say we have to shut down our stroke program overnight because I don't have enough CT techs to run the CT tech scanner overnight. And what's causing that? Oh, it's a compensation issue because we pay $5 less an hour than any other hospital in the system. So when we come to bargaining, let's fix this so that we can get our CT staff fully staffed up. So I would say that there's several issues that we take at it, and from the association perspective, we focus a lot on providing tools like the Safe and Effective Staffing Guideline to help directors and managers make the case for it. We provide the clinical practice guidelines that says this is what the care should be. So when you have a CFO who does not know clinical and frankly probably sometimes does not care, you can say, no, this is the level of care that we can provide. In some cases, like you look at the nursing profession in the state of California, they passed laws that mandated nursing ratios to stop hospitals from trying to cut staff. So, I eventually will see that bleed into other professions because people let's look at MRI. The American College of Radiology has standards about what staffing should be for an MRI scanner. They have staffing standards for a CT scanner. And so we have a white paper that says how staffing should be determined. Just things like that, we have to come at it from multiple angles because as an association, we don't necessarily tell in a hospital how it operates. But we can provide some guidance to the leaders and how clinical care should be based, and maybe you should be thinking along these lines.
No, I agree. Same. I couldn't agree more. I think the role of the association is to provide the tools and the education to support you as the leader having that conversation. Very unlikely that a hospital executive would want to hear from me to tell them how to dictate care, but what we can do is create these tools, and I think the Safe and Effective Staffing Guideline is a perfect example of that. We have set forth standards for what it looks like and productivity measures around the care that we provide and how we build those in. We've had similar issues with compensation. I was successfully able to do the same thing in leveraging data from other disciplines, other organizations, also pulling in the Safe and Effective Staffing Guide and being thoughtful about the way we provide care. But I think the role of the association is supportive in that way and can provide guidance as well as education around these conversations and how to have them. And I think the other component, which I mentioned before, is mentorship. And I think there are people that have been through this that would probably be willing to support you as a leader in having these conversations. I don't want to speak for my panelists, but I think that they would be willing to say, let me help you talk through this scenario and see how we can best support you in having this conversation locally.
If I may, we want to thank you for your question.
Thank you.
And we can continue answers and exchange of information. All of these people's email addresses are out there, and if we can continue this, it would be a really good thing.
Yeah.
I would also like to recognize that there are a number of physicians right now in the auditorium here, and the medical directors of the RT departments in Saudi, for example, are really important. This goes back to what was said earlier regarding this position. I actually stayed in Toledo, Ohio for many years, primarily because the medical director that took care of the departments that I covered or that I was involved in was there at any time, day or night, to support my efforts and the faculty's efforts. And it is really an important thing for physicians to be cognizant of the fact that we provide good service, but we need you very much to take a side, I guess is the way to put it. We're going to move towards, if there aren't any other questions, we have some closing comments to make.
Did we have a question over here?
Yes? It'll talk. Talk to it. You have to put your mouth by it. It's voice activated.
Okay. Yeah. Okay, thank you for the amazing session. For my question is for the respiratory therapists who are interested in the management rules. Do you recommend pursuing master's degree or specific certifications in business and leadership, or is the clinical experience and the skills you mentioned is more important in your opinion?
I'm sorry, as a respiratory therapist who wants to do what? I didn't
What
catch.
skills and certifications should she have to prepare for leadership?
For a leadership role. Yeah, that's a great question. So my master's degree is in healthcare administration, and I'm a fellow of the American College of Healthcare Executives. That's a board examination that I had to take, and I think that just like the time and dedication that you put forth to academic pursuits associated with the clinical component of our work, you really have to dedicate that same level of dedication and investment in your skill set as a leader. It is a whole nother profession. Just like when you go into education, it's a whole nother profession. You're building on the foundation of your clinical knowledge, but the leadership skills that we talked about are skills. And so I cannot emphasize enough the importance of dedicating time and resources into getting the training associated with being a leader, as well as developing those skills as well. I think there are many ways to do that. I chose to do it through my master's degree, but there are other mechanisms to do that as well.
Yeah. So what I would add is the education, the master's degree in either healthcare administration, business management is a great route. Joining the American College of Healthcare Executives is also another route. I would say do as many, once you get into leadership and into management, you grow in managing your team, and then you take on hospital projects. One of the challenges I see respiratory therapists get is it's sort of like they get cast type into a particular role. You lead a respiratory therapy department, you're therefore not qualified to lead anything else. And that is not true at all. I personally have proven to our leadership, I was able to lead imaging departments. It was rather large imaging departments, but rehab departments. Leadership skills are the skills that you want to develop, but leadership skills are transferable to no matter what area you're over. You're always going to need a subject matter expert for that a particular field. But once you start to grow beyond like leading the respiratory therapy department, then you learn into the whole cast of say, how hospital operations work. And so you have to understand the role that EVS plays, that transport plays, how nursing decides their staffing ratios and supply chain management. And so those, once I mean, there's skills that you have to develop, but I would say if you're coming out of school, first and foremost, you have to develop your good clinical skills. I'd say, at least 3 years, get your degree, and then move into leadership. What we see, I was a co-author on a paper we published that was a survey of leaders. What did they look at for people to be good leaders? And it was taking on projects, providing education. But the skill sets that were really seem as necessary or values that we saw in leaders was integrity, trustworthiness, openness, things of that nature.
I will tackle onto that, and I think to take it even back, whatever your role is now, your leadership skills are starting in your bedside role. I'll tell you, when I see leadership in my preceptors, because what is a better case study than taking a novice learner, teaching them really hard. If they don't do well, you're going to coach them to become better, or you can knock them down and make them feel terrible and want to leave the profession. And you may not be thinking about that, but we're looking at it. And when we see people who can effectively coach, when the way that they bring their team together, leadership is really about your ability to communicate effectively and lead people who have diverse perspectives, diverse communication styles, and how can you bring them all together? Those are also the things that are going to get you put on hospital-wide projects, because the thing that makes you really good at leading a project isn't being a subject matter expert at, I don't know, if we're looking at throughput through from MRI to the OR back to the ICU. They want to look at someone who's effective at bringing a group together, can lead effectively, and drive people to one mission together. And that starts at the bedside. The RTs with every patient, and you're dealing with nurses, physicians, other RTs, other disciplines, you will demonstrate that there. And that is what will demonstrate for others and lead you to a path to growth. And I will say you guys are already starting your leadership development now, and think about how the role that you play on your team. What do you want your legacy and your department to be? Do you want to be the RT that put people down because they made a mistake? Are you the one in the break room who's talking badly about your leader and others? Or are you the ones finding solutions, going to your leadership with solutions? Are you the ones lifting up those who might have had a bad code or made a mistake and saying, that happened to me too. What do you want to do to make it better? Let's go into here. Let's practice this because I know you can do it. So all of you are leaders right now, and I encourage you to take an active role in your departments, and that will honestly open up many more opportunities for you. And if you're in a leadership role now, in management director or anything, raise your hand for any project, because there's no better person that can coordinate every single department for one goal than the RT, because I work with every single ICU, I work with the OR, I know every single medical director, every nursing director. We're so effective at it that's how you can show your value to the institution, and why RTs belong in the C-suite, and why RTs are the most effective at leading cross-functional, cross-institutional projects, because we can communicate well and effectively with a lot of people and drive great outcomes.
I think what Emily is talking about, and Carl hit on it too, is the difference between formal and informal leadership and leading without a title. Mm-hmm. And I think that we all have the capacity and should take a role in that, and being leaders on our team, right? You don't have to be the department director to be seen as a department leader, and I think that's so important. It also lends itself to opportunities. When new projects and things pop up, they'll reach out to those informal leaders and offer them those opportunities. So I think that's a beautiful comment.
Well, we appreciate all the input and the thought process, and very happy to see that many of you stayed with us. So we want to thank you and thank our panelists.
Thank you.
Our first panel and the second panel. So thank you so much.
Thanks.
Okay, supposed to come down, I guess. Okay, I don't know what that means. Yeah. Okay, what is that? I gotta get my stuff. Get your notes.
السلام عليكم ورحمة الله وبركاته. مساء الخير عليكم جميعا. Mr. Hassan is on the spot, and we're trying to meet the time frame we have. So minutes are important, and seconds are essential for all respiratory therapists. Without any further delay, I would like to introduce Ms. Fatma Shimmeri. Ms. Fatma has graduated from Bilmerain University in 2020. She has a master's degree in respiratory therapy and leadership. She is currently the head of the respiratory therapy services within the Department of Medicine at Prince Sultan Military Medical City. In addition, she's a lecturer in Prince Noura bint Abdurrahman University, and Ms. Fatima brings more than 15 years of clinical experience as a respiratory therapist with extensive leadership and academic contribution to the field. Please, Ms. Fatima, the stage is yours.
Thank you. Thank you for the organizing committee for this opportunity. Thanks, Dr. Maher, for kind introduction, and special thanks for Mr. Hassan Al-Uraini for organizing this comprehensive conference. So, pulmonary functioning test is among the most important investigation in respiratory medicine. It helps us to diagnose the obstruction disease, assess its severity, and also predicted the outcomes and indicated in many sites in the clinical, such as pre-operative assessment. But unlike other labs, value such as blood sugar, electrolyte, potassium, or sodium, BFT result, it's strongly influenced by the patient factors such as age, height, ethnicity, and sex. So what that means, we cannot compare the patient result with the normal or fixed cutoff number. Instead, we have to compare the patient result, BFT result, with what we call predicted values. This slide summarizes the history and evolution in the ATS, American Thoracic Society, and European Respiratory Guidelines over the past 2 decades, showing how the accuracy, standardization, and equity has been in interpretation have been improved over all the times. So the first version of the BFT guidelines was published in 2005 and is still widely used across the world because most of the BFT standards are based on these guidelines. So this slide is a quick review for spirometry directed mainly for the trainee and the people new in the field. So the spirometry provides us with the 3 important parameters. The first one, FVC, or forced vital capacity, which is the maximum air that we can exhale it after deep inhalation. And this, for example, in this curve of the volume time, we ask actually the patient to take a deep breath and exhale. In the previous guidelines, at least 6 seconds. And it's shown in the blue line. This patient, for the FVC, the volume he was exhaled, around 5 liters. The second important parameter is FEV1, which is the forced expiratory volume in the first second. Here it's presented in the red line, so the patient exhale in the first second around 4 liters. And the most important parameter in the spirometry is the ratio between the FEV1 and the FVC. For example, here the patient exhaled 80%. What does that mean, 80%? That means the patient exhaled around 80% of the air he was inhaled in the beginning in the first second, which is normal. For the normal and healthy individual, we can exhale the majority of the air. We inhaled it deeply in the beginning in the first second, so around 80 or 85. If the patient cannot exhale or exhale less than 70%, we consider the patient has obstruction. He has obstruction, or he has a problem with the airways. He has airway limitation. He cannot exhale the majority of the air in the first second. So because of that, we diagnose the patient have obstruction if the FEV ratio less than 70. There is update in the guidelines. I will discuss it in the coming slide. But this is the basic knowledge of the spirometry. The trainee should know it. So also, we consider the patient have the BFT result normal if it's put within 80 to 120 of a predicted value. So here, for example, the predicted value, what does it mean, predicted value? Predicted value, what should the patient achieve? When we just put the age, height, and enter it in the system, the patient should give us around 5 liters. But when we do the test for the patient, he achieved only 3 liters. He achieved only 60% of the predicted value. So the patient have low volume. We consider the patient has a restriction in this case. So the major step, the major step change in the BFT guidelines was happened in 2012 after American Thoracic Society and European Respiratory Society introduced the GLI 2012 guideline reference equation. What does it mean, reference equation? Just simply to make it easy or to understand for a trainee, reference equation, that the equation used by the computer to calculate the predicted values. So when you enter the patient data, for example, the age, height, sex, and intensity, the computer will use this equation to calculate the predicted values. So before the GLI 2012, we have many reference equations used around different regions in the world. For example, National Health and Survey used in the North America, ECCS used in Europe. That gives us a huge variability between laboratories. What does it mean? If we do, for example, BFT in one hospital, and we do another BFT in another hospital, and they use different reference equation, that means they will give us different predicted values, and maybe the result normal in one hospital, but abnormal in the result, another result. Because of that, the American Thoracic Society and European Respiratory Society provide us with the one international equation, which is the GLI, Global Lung Function Initiative. The GLI, over extensive data from multiple countries, provide a more comprehensive reference compared to old reference equation. So, here the Global Lung Function Initiative is an international collaboration of respiratory experts. They collected the data from more than 700 individuals from 26 countries across all the age from 3 to 95 years old, and multi-ethnicity, to provide us with the more accurate and consistent for the physician for better interpretation and accurate interpretation. So this slide compare the old reference equation used before the GLI. The GLI was introduced in 2012, and compare it with the GLI equation was introduced in 2012. The main one important advantage of the GLI equation is that it covers a wide range of age, from 3 years to 95. The previous one mainly covered the adult more than the pediatric. Another key benefit is that improve comparability, which is very important, improve the comparability between the laboratories. So if I did BFT in the hospital, and after years I did a BFT in another hospital, they use the same reference equation, I can see or can compare the result, either going better or going worse. So this is the global function initiative equation. For the sake of time, I'm not going to go through it, but it is available on the ATS website. This marks, in 2017, this marks a key transition from presented predicted interpretation to what we call it Z-score interpretation for more accurate and age-appropriate BFT interpretation. So before, how can we, as I mentioned before, how we interpret the BFT, or how we consider is it normal, the BFT value, if it's within 80 to 120. However, this is not considered the age-related physiological. This is a study done in 2014 and proved that the lower limit of normal is not 80%. By definition, 50% of healthy individual should fall below the lower limit of normal. Here in this study, we can see with the age, especially in the 8 years old, the number of healthy individual fall below the lower limit of normal, around 20, which is against the rule. So 80%, it's not really the lower limit of normal. Similarly, we consider before the patient have obstruction if the FEV1 ratio less than 70. But this old or historical interpretation not consider or account the age physiological change, because we know that the FEV ratio is decline with the age. So people could be 80, normal, FEV ratio less than 70. So this will increase or misclassify a lot of older people, especially, as they have obstruction disease. At the same time, may consider obstruction in younger adult. Because of that, the ATS guidelines, the new guidelines, shifted the interpretation way from percent predicted to what we call it Z-score interpretation guidelines. So what is the Z-score? Z-score is a statistical measurement, show you clearly how the patient is far from the normal predicted values. And here in the zone, the green zone, this is the Z-score graph. And then in the green zone, this is the normal range. The lower limit of the lower the lower limit of normal is minus 1.64, and the upper limit of normal is plus or positive 1.64. Any numbers of the patient data be located less than minus 1.64 consider abnormal. So this is again the normal range of the z-score is located between in the green zone minus plus 1.64. Okay, I'm gonna jump to the 2020 strongly emphasized to use the lower limit of normal and z-score in the interpretation. So the lower limit, as we said, is minus to positive. Either any located, it's considered abnormal. So severity of grading using z-score, normal as I mentioned, mild if it's less than within this range, minus 1.65 to minus 2.5. Moderate consider minus 2.5 to minus 4. Severe if it's less than 7, minus 4. Another advantage for the z-score is you can easily interpret or you visualize the patient data, how far from the normal range. So this is the old interpretation. Most of the centers still use the interpretation using predicted. For example, here first we look. This is the traditional or historical interpretation. First, we look at if the FEV1, if it's less than 70, the patient has obstruction. Second, we have to know what is the severity. The severity of the obstruction, we look to the FEV1. Here, from 50 to 70, so the patient has moderate obstruction, and we look to the FVC and total lung capacity, both of them more than 80s. They don't have, which is normal, they don't have restriction, so this patient considered as have moderate obstruction. So let's practice quickly how to use or how to interpret using the z-score and lower limit. I'm going to show you how the z-score graph easy to know or recognize the patient interpretation, even we are not looking to the data of the patient. Here we can see in the first line FVC, second line FEV1, third line FE ratio. So all of the patient data located in the green zone, in the normal range. So this is the patient have a normal result, BFT result. And we can double check here all the result, it's located in the normal range. I put the table for normal range and severity here, just to easy interpretation. Second example here quickly. We just look at the graph. We can see the FEV ratio in the red zone. That means immediately the patient have obstruction. What is the severity of obstruction? We look to the FEV1. FEV1 also in the red zone. How much FEV1? It's minus 2.9. So here we consider it as a mild. Excellent. So this patient have mild obstructions. What about the FVC? In the normal range. So the patient, we don't suspect restriction, for this patient. For interpretation, the patient has mild obstruction. This example, okay.
So we have other audience.
Okay.
Other speaker, sorry.
So I'm gonna conclude in this
Very
one.
sorry, Ms. Fatima.
Okay. So we look at this one. Give me 1 minute. I'm gonna finish this one. So this one, we will interpret this one. The FEV ratio in the normal range. So the patient doesn't have obstruction. However, FVC and FEV1, both low. That means the patient has a restriction. What kind of restriction? If we see the minus 2.76, it's located in the moderate zone, so this patient has a moderate restriction. There is some change also in the 2019 in point of first exhalation. Before we have the time of the exhalation was 6 seconds. Now the patient has to achieve only plateau or decrease in the flow 25 mil per second. And bronchodilator responsiveness, because before we have in the 2000 rules and in 2019 changed from changing in the baseline of the patient to the predicted by increasing 10% of the predicted. So just go and conclude these. So I'm just going to conclude my talk with why accurate BFT interpretations matter, impact diagnosing and severity classification, influence treatment and surgical decision, error lead to over or underdiagnosed. That's why clinical context, we have to compare it with not just looking for the BFT result, we have to look the patient clinical also side to give the patient a good diagnosis. And thank you so much.
Thanks, Ms. Fatima, for your nice presentation. We will not have questions now, and we will welcome our next speaker.
Assalamu alaikum. It's my pleasure and greatest honor to present our next speaker, Dr. Afnan Al-Raimi, with her extensive experience in academia and clinical practice. She's currently an assistant prof at Al-Imam University, and she's holding multiple leadership roles, one of them as the head of the respiratory care clinics at the Family and Community Medicine Center. She is an active researcher who has published in leading respiratory journal with specialty in lung function and pediatric lung function and advancement in lung function measurements. Join me in welcoming Dr. Raimi. Thank you.
Thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. First, I'm grateful to be here. I would like to thank Dr. Hassan Al-Araini, and I'm grateful and honored to be among this team and audience. So today, inshallah, I'll talk about the new insights evolving a forced oscillation technique in pulmonary function testing. So these are the outlines. By the end of the presentation, I'll go through these things, inshallah. Starting with impulse oscillometry, you're going to see me or hear me saying impulse oscillometry, forced oscillation technique, oscillometric or oscillometry. So all these are the same or similar to each other when we're talking about the oscillometry. So starting with impulse oscillometry, they're a procedure that based on physiological principle of forced oscillation technique. We always say that it is a new insight. It's not a new thing. It is an old thing that it was several years ago was introduced by Dubois. So IOS or FOT are non-invasive methods, and both are measuring lung function, lung mechanics, and it's used also in the diagnosis of and evaluation of respiratory diseases. It's mainly impulse oscillometry is like putting some oscillation, higher frequency, it is non-invasive, putting some high frequency oscillation into a normal quiet breathing that results in a quiet breathing with a higher frequency than the normal respiratory rate. So when we say IOS and we say FOT, we say oscillometric, they're not only different, there's not only difference in the machine, it also difference in several aspects, like for example, what kind of waveform we're putting, what are the measurements, is it continuous or not continuous, is one of the devices is more comfortable than the other device. So all these we put it together to differentiate and compare between the IOS and the FOT. Both of them at higher frequencies get along, but at lower frequencies it differs a little bit. So what are the advantages of using FOT or IOS? One of the main advantages is that it's easy to use and it has a fast measurements. And I'll talk about it in the practical consideration section. It's used also when spirometry is contraindicated or when spirometry is not the choice at that time. And it is shown to be sensitive in detecting peripheral airway obstruction, and that what makes it superior a little bit in some of the areas. So
Indication comes, as one of the just mentioned, it's unable to perform spirometry. So around, or acceptable spirometry maneuver, if we want to be in particular. So more than 20% of the patients showed that even they were transferred to perform pulmonary function testing, were unable to perform acceptable spirometry maneuver. It's also used with acutely ill patients, pediatric or geriatric patients, or in neuromuscular disease, where performing forced maneuvers is hard on them. It's also used in diagnosing bronchial asthma that shows normal spirometry, and it is more sensitive. I added here, it is more sensitive. So in some of the patients with asthma, between the attacks or between the asthma exacerbation, the spirometry shows a normal result. So in some of the studies, it was shown those patients between the attacks that showed normal spirometry thought was abnormal. So that is cases. It's also used in special condition groups and in ventilated patients. Some of the devices is implemented within the ventilator to measure some of other lung mechanics. Also, FOT is used in demonstration bronchial response and also the bronchovacation testing, and it showed that it has a lower dose required comparing to other function testing. Mainly, as I mentioned, it is forced oscillation here, a higher frequency that goes into a quiet breathing, forming both pressure and flow changes. Both pressure and flow changes here performs the relation, something called impedance, which is composed of two factors, which is the resistance and the reactance. You may see some of my slides coming saying like ZRS or ZRRS or R, they're all the same, but it is the reflective measure of either resistance or reactance. Here, F is the frequency, where the implementation of this high frequency on which frequency. As you can see here, the resistance is in red and the reactance in blue. So what is the resistance? It's something that, as the other pulmonary function testing or the mechanics, it's in here, they called it the N phase, or the real part of the impedance, which reflects different resistance, like for the airway resistance, lung tissue parenchymal component, chest wall, and the diaphragm. And you can see here that the resistance here starts with R5 and then goes decrease in the resistance while the frequency increases. And that's because the frequency at a lower hertz can go from all over to the smaller airways, but the frequency at a higher hertz only travels to the upper airways. Just mathematically, subtracting the R5 to R20 will reflect the smaller airways or the peripheral airways. So what are the reactants? The reactance is the other part of the impedance, which is the out phase, and it represents the elastic properties and the inertial forces. So as you can see here, the reactance starts low and then increases while the frequency increases. So what is the resonant frequency? The resonance frequency, it's here, the point where inertial forces and the elastic forces from the opposite direction comes to a point where it is 0. And from here, I would touch on the AX, and it's worth mentioning that the AX, this part, which is called area under the curve, which is the area between the resistance at 5 hertz and the resonance frequency, and this is another representation of the small airway diseases. What are the practical considerations? I'll talk a little bit about it because Dr. Pasquale gonna continue on these and give some details on numbers and studies within his slides, inshallah. So the measurements here should be done in a seated position, nose clipped there, the mouth is sealed, and the neck and the shoulder has to be parallel to the devices. One of the main important things is putting the hands on the cheeks, because I'll explain in a moment why should we do this. Now, the patient is instructed only to do quiet breathing, normal tidal breathing. The machine will measure around 20 to 30 seconds, and it will end. That's the study. That's one acceptable maneuver. However, if there is any deviation from the normal breathing, the machine directly will reject it. We need around 3 to 5 maneuvers or measurements to give a good reading or a good average, and the patient has to rest in between these measurements. Now,
one important thing that we have to think of, that this should not be done after a forceful maneuver, like for example, spirometry or a pheno testing. So it has to be done before because it may affect the airway caliber. What if the respiratory therapist got mistaken and did it before the spirometry or did it, after the spirometry? It's okay. You have to let the patient just relax for a few minutes and 3 to 5 minutes around, and then the patient can perform the FOT. Okay, I add this slide, which is avoiding and considering, which results in the best results for the FOT. So one of the things is using high resistance bacterial filter. We want all the resistance to come from the lung, not from any other parts. So adding a high resistant bacterial filter will affect the results. Mechanical load, again, it will be presented in my next slide, with the next presentation. Wearing the belt, wearing tight clothes, or even sitting in an inappropriate position will affect the results. Poor cheek support may actually affect the results because all the vibration is not going to go to the lungs, actually it's going to go to the cheeks, and that will perform inaccurate results. Poor artifacts as tongue, swallowing, speaking, coughing, and any other artifacts like the ones in the PFTs, the regular PFTs, is another artifact that we have to avoid. Now, what are the things that we have to consider? The new guidelines, it's controversial for the coherence, but some of the machines still use it. For the coherence, more than 80 to 90% is considered acceptable. This is not according to the latest guidelines, but again, some of the machines still use it. And we have to consider the coefficient variation of less than 10% in adults and less than 15% in a pediatric. This is a representation of one of the machines that used in FOT. Every machine differs in the representation. Here's the upper part, which is the resistance, and here's the reactance in the lower part. You're going to see the reading here with an indicator that gives you an idea about the lungs. You can also see all the numbers coming with average of the measurements, also the coherence as this device suggests to have the coherence, and also the Z-score, which is important. Now, this is an acceptable maneuver because the resistance starts here and then goes down. Again, the reactance starts here and goes up. You can see the readings here, an indicator, and the coefficient variation at this point is good. However, this is a not acceptable maneuver where it's chaos, where every breath was making, or every test was making a different direction. You can see the resistance goes up, then down, and so on. So this is not acceptable. Even though there are some numbers, the coefficient variation within these are high. One of the things that we diagnose patients with is bronchodilator response, and that's a test with the bronchodilator response. You can see the pre-bronchodilator is the blue, and the light blue is the post-bronchodilator, where there is an improvement of the resistance. The resistance decreases after giving bronchodilator, and also the reactance improve after giving bronchodilator. The indicator part here goes and shows where the patient was and where the patient is after giving the bronchodilator, in addition to the percentages changes. So I mentioned at the beginning of my presentation that this is not a new thing, this is an old thing, but it's not used. So is there any regression equations or predictor? Yes, there are. There are several regression equations and predictors for both resistance and reactance in the field. They consider many factors like height, weight, age, gender, and also the machine use. The height was the strongest predictor, where the gender was the negligible contribution in that. Where the relevance of oscillometry in clinical practice? So they were used, and this device was used in a very different clinical conditions of chronic respiratory disorder. Also, it's used in bronchial asthma and to assess the bronchial responsiveness. Also used in physiological and pathological condition that may affect the respiratory system, but where exactly it is important, used to assess the sensitivity of detecting peripheral airways, because it's actually leading and detecting the peripheral airways, because some of the devices of other testing detect the general of the lung health, not the airways. An assessment of peripheral airways and visibility. These are all the clinical application, or not all, some of the clinical application that are used for performing FOT, but there is still gap in knowledge where there is a differentiation between obstruction and restrictive lung diseases. And in addition to that, in a specific interpretation and for resistant reactants in specific lung condition. There is a lot of guidelines, and we're growing in the field. However, there is no specific numbers and guidelines in several lung conditions. There is an apart, there is an age group of adult and pediatric, but not like a general one for all. What is the future direction for the thoughts in the field is using the AI for both monitoring and diagnosing the disease. Not only that, but it will enhance, we can implement AI into the thought for enhancing the early detection of disease, phenotyping, and personalized management of respiratory condition. Also, we're not working alone. We work with the other, not PVT alone or RC alone. So it is recommended to do a multidisciplinary application for pulmonary rehabilitation and home base. To end my presentation, this is a summary of the spirometry and NIS and FOT. So in the measurements, airflow and lung volumes, it's mainly, and the resistance is measured indirectly. However, by the pressure and airflow, it's calculated the respiratory impedance. These are the measurements of volumes and flow in spirometry, the resistance and reactance in the AX and measurement. We require a maneuver of maximum maneuver, so it is high dependent on the patient, limited on children and children and elderly, but this one requires effort independence, minimal and cooperation. So it's well suited for the children and critically ill. Large airways, both machines are good in detecting large airways. When it comes to the small airways, the FOT goes superior. And for the restrictive maneuver, the spirometry is detectable for the restrictive maneuver, but it's poorly detected where it's mimic the obstruction. And sensitivity for early of the disease, it's more into the FOT, and for both of them has a bronchodilator response, but it's mentioned by the studies that it's more sensitive into the spirometry. Dr. Pascal Week going to present a lot of studies that's done in the field, also with the numbers, so I'll leave that for him, and here I conclude. Thank you.
Thank you very much, Dr. Afnan. Again, you can see that we're being biased here. So, okay. So last, but definitely not least, with his vast experience in respiratory physiology, medical devices, and his background in bioengineers, Dr. Pasquale Pompelio, visiting us from the beautiful land of Italy. He is one of the founder of ResTech. He is currently holding the position of CCO in ResTech. He had multiple collaborations with great institutions like the University of Liverpool and the Guy's and St. Thomas NHS Trust, with handful publications in peer-reviewed journals about lung function and advanced lung function. Please join me into welcoming Dr. Pasquale, and thank you. Hopefully I didn't murder your name.
No, that's perfect.
Good? Yeah, I had training.
Thank you for this great presentation, and for me it's an honor to be here to offer my contribution to your understanding of the oscillometry. So these are my personal information that have been shared already by Dr. Al-Moody and my conflict of interest. Well, I would like to start today with a quote of a famous Italian, I'm Italian, Leonardo da Vinci. Leonardo said that the one that loves practice without theory is like the sailor who boards ship without a rudder and compass and never knows where he may cast. So my plan today is to complement the past presentation by providing you other concepts and at the end be able to be your rudder and compass while you try to sail in the oscillometry sea. So we have already covered this in the past presentation. To summarize it, with oscillometry, we measure our difficulties for the air to go in and out from the lung. We do that by applying small pressure variation, so a small force that is trying to move a small amount of air. We compare the force with the air that we have measured, and we calculate impedance. Impedance is dependent by several mechanical aspects of the lung, and this is the reason why mathematically we split it into resistance and reactance. Resistance is critically dependent by how difficult it is for the air to travel inside the airway lumen. And therefore is critically dependent by what? By the geometry of the tracheobronchial tree and by its anatomy. As such, resistance will be mainly influenced by alterations happening in the large airways, because you know better than me that small airways contribute very little to the value of resistance that you can measure at the mouth. In any case, resistance is important. It's important because it can change in presence of bronchial constriction, can change in case of mucus, can change in any situations where there are factors that change the diameter of the upper large airways, like vocal cord dysfunction, like tracheomalacia. What oscillometry really adds to the traditional technique is contained in the reactance. As was mentioned before, reactance is a measurement of two different mechanical properties of the lung, the inertia and the elasticity of the lung. That are the two properties that allow to the respiratory system to store the energy, let's say. Now, if you measure reactance with a high frequency pressure oscillation, that number would be highly dependent by the inertia of the respiratory system. While if you measure it, well, a low frequency, this will be dominated by the elasticity. Well, from clinical purposes, we tend to ignore the high frequency reactance, and most of the attention is on low frequency reactance. This is because several studies have demonstrated that low frequency reactance is critically affected when you have what I call peripheral roadblock. So factors that alter the possibility to reach the peripheral airways. So this could be small airway disease, could be even alveolar recruitment. Reactance is also altered when you have a stiffer parenchyma, as it happens in interstitial lung disease, in pneumonia. Reactance is also sensitive to the stiffness of the chest wall. So nowadays, reactance, low frequency reactance, is considered an expression of how well the air can reach the periphery of the lung. So in this sense, it complements the resistance that is mainly dependent by the large and central airways. Now, I want to show you the results of two large studies that were published recently. These were two studies similar. One was done with the iOS and the other with a device implementing FOT. Now, they did the same study. So they wanted to compare the presence of abnormal oscillometry value with abnormal spirometry value, a presence of symptoms, or a past respiratory diagnosis. Altogether, these studies involved 70,000 subjects. The results were identical. Both the studies showed that oscillometry is able to detect, with reactance mainly, is able to detect abnormalities happening in the small airway in subjects that have past diagnosis of respiratory diseases with symptoms and normal spirometry. So this is an important study because besides, let's say, testifying this good sensitivity, it also, I think, demonstrates a very important concept. Oscillometry is not an easier spirometry. It's a different technique that can be used together with spirometry, but that measures the lung in a different condition and measure also additional things like the elasticity of the system. That is something that you do not measure with spirometry. Now, this was briefly touched in the past presentation, but for many years, oscillometry was used mainly as a research tool. One of the big problems was the lack of standardization. Now, this problem has been solved in 2020 with the publication of the technical standard for respiratory oscillometry document by the AARC. This document is important because it establishes clear guidance regarding how to perform a test, how to evaluate the test, how to evaluate the quality of the test, and also has some technical recommendation for manufacturers to make the devices more similar. Another key milestone is this. This was published a few months ago. These are the results of an international Delphi study involving 59 respiratory specialists using oscillometry for clinical purposes from 4 different continents. The aim of this study was to establish a common way to interpret oscillometry. They identified basically 4 parameters that actually are 3, because if you see, they consider X5 and AX equivalent. to evaluate the lung function. And they also suggest a way to identify abnormality that basically follows the same rules of spirometry. So they suggest to apply z-score, threshold on z-score, and the same intervals that were presented before for the grading of the severity. Now, something that makes oscillometry different from spirometry is the fact that you can measure lung function over several breaths continuously. That means that you can measure the changes that happens during the breathing cycle, and therefore modern oscillometry devices, they provide not only resistance, total resistance and total reactance, but they can split resistance and reactance in the inspiratory and the expiratory phase. And they provide you also indices like the delta XRS here, quantifying if there are swings within breath changes of resistance or reactance. Why this is important? Well, recent studies, they've all demonstrated that the expiratory phase became abnormal sooner when there is the development of a disease. And this is a direct consequence of the physiology of our breathing. During the expiratory phase, our airways are more compressed. So if you have an obstruction, that obstruction will be more evident during the expiratory phase. So using the expiratory and the inspiratory phase separately will improve the accuracy, but also will allow you to identify pathological conditions like the tidal expiratory flow limitation. So the tendency of the airways, for instance, to collapse during the expiratory phase. That is one of the main factors of the development of dynamic hyperinflation in COPD, for instance. Now, let me expand a little bit some of the concept about the procedure. According to the ERS, you need to do 3 tests. This is similar to other technique. You need to consider the results that you got from the average of the 3 measurements that are similar. So you need to check, the index for quality control here is the coefficient of variability of total resistance. Actually, there are 2 thresholds, one for the adults and the other for the children. Altogether, if you consider a measurement that has 5 to 10 breaths, repeat 3 times means that the entire test will last less than 5 minutes. Now, regarding the artifacts, before going to the artifacts, the ERS stress a lot on the preparation. Now, oscillometry is an easy test, but in any case, a medical test, so you need to follow a protocol. You need to anticipate to the subject that there will be these vibrations because they may find it scary at the beginning. And you need to encourage them to breathe as relaxed as possible. There are two postures that can be used during the test. One is with the technician supporting the cheeks and the other is with the subject supporting the cheeks. A key important thing in the second posture is to instruct the subject to keep the elbow raised to avoid compression of the chest wall because this may change the elasticity of the system. Personally, I tend to prefer this posture here because it's more reproducible. You don't know how well the subject is supporting the cheeks. It is also important to have the neck fully stretched and the head horizontal or in a slight chin-up position to maximize the area of the retrolarynx to avoid the compression of the larynx. Artifacts. Artifacts may be generated by the closure of the glottis, and they will appear as big spikes in the traces. Artifacts may be generated by a wrong posture. Artifacts may be also generated by extreme breathing patterns, like hyperventilation, very high tidal volume, or super frequent breathing activity. The ERS mandates to consider only portions of the breath that are artifacts-free. And this is an example of what you see during a test. So you see that you can measure with oscillometry a continuous change of resistance and reactance. Those spikes are actually artifacts that, as you can see, have been excluded automatically by the machine. And when you have done the test, thanks to this latest publication, now it's possible to draft an interpretation structure of your results. So you do your test. The first step is to evaluate the quality. The second test is the search for abnormalities. How to do that? You look for values of z-score, resistance, and reactance that are outside the normality range. Then you look for the presence of excessive within breath changes. And if you have done a post-bronchodilator assessment, you compare your changes with the threshold suggested by the ERS in the technical standard document. At the end, you will have a picture about the presence of abnormality, obstruction mainly, affecting central or peripheral airways, and about the reversibility of this obstruction. Now, to see all this concept in practice, I've presented here, I have here a real case that was provided to me by Professor Catherine Sassoon. She is emeritus professor at the University of California. Matteo is a young Hispanic man who never smoked, but he has non-productive cough with frequent wheezes. He had asthma exacerbation, he is using albuterol, but his asthma is not under control. Let's see what is Matteo's spirometry. Well, it's pretty normal. You don't see any obstruction, you don't see, of course, any change to bronchodilator. Let's look at Matteo's oscillometry. Well, what you can see here is that Matteo has an abnormal reactance during the expiratory phase. And this abnormality disappeared after the administration of bronchodilator. Well, what is the interpretation of this case according to Professor Sassoon? Well, following the schema that I've drafted before, resistance is normal, reactance is abnormal during expiration, suggesting presence of peripheral disease. This was reversible. This information, that means normal spirometry, abnormal reactance with oscillometry plus symptoms, is suggestive of asthma. So, I'm concluding. At the beginning of this session, my idea was to provide you some sort of information that could act as a compass. I hope to have been able to at least make you curious about this technology, because differently from the past, now this technology is standardized. It is inclusive. You can use oscillometry on all the subjects. It's efficient in terms of time, and as has been mentioned multiple times, it's sensitive to the early signs of the disease, because you know that small airways is where everything happens usually. Oscillometry now is considered new, but it's something that has been on the field since almost 70 years. There are more than 2,000 publications supporting the technique and more than 70 years of technology advancement. So I encourage you to use it, to try it and see how this applies in your practice, to test it in practice if you go on the exhibition hall, and also to go on the poster session and look at this very interesting poster that basically analyzed the evolution from my previous speaker group, the evolution of the oscillometry over the year. That's it. Thank you for your attention.
Thank you very much, Doctor, for your informative slides and lecture. So, do you have any questions to our panel? No? Okay. Thank you very much.
I think we will come back for, we are going for a break, Mr. Hassan. In the program, it's a break, and we come back at 4.
We're on time, yeah.
It's up to you, Mr. Hassan, if you want us to leave or stay. That's...
We're on time, don't worry, Mr. Hassan.
So Mr. Hassan is like my father. He wants us always to work and work hard, but thankfully we have a break.
rahmatullahi wa barakatuh. Welcome everyone. I'm so grateful for the opportunity to attend the AARC conference again this year and connect with the respiratory leaders. It's a pleasure to welcome you all to the Meet Industry session at AARC 2026. This session highlights the role of industry partner in advancing respiratory care practice. And we will start with Vital Air, a global expert in mechanical ventilation, with Dr. Ricardo, discussing ventilation during CPR, friend, or FIO. The stage is yours, doctor.
Hi, everyone. It's a pleasure to be here. So I'm going to discuss the ventilation during CPR. It's a friend or enemy. As a conflict of interest, I declare that I work for Air Liquide Medical System. It's a French brand that manufactures ventilators since last year, March 2024. And for this topic, also I have a conflict of interest because it was what I studied during my post-PhD in Geneva 12 years ago with Dr. Laurent Brochat. So the take-home message is that the physiology of ventilation during CPR is very complex. Chest compression by itself can promote lung injury. The optimal ventilatory strategy during CPR is not yet defined. Ventilation with bag mask is not the optional choice, and often it can be insufficient. And ventilation is not only air going in and going out, but it's a determinant of survival and neurological outcomes in a cardiac arrest patient. Thanks so much, shukran. Any doubts? I will try to convince the take-home message in the next slides. So this is a recent paper about Saudi epidemiology of cardiac arrest, published in Resuscitation last year. 3,600 patients, the rate of ROSC 7.4, survival to discharge 3%, with good neurological outcome less than 0.5. And I talked with EI, and the EI told me that the numbers of Saudi are similar to India and to China. However, worse outcomes compared to US, to Europe, Japan, Brazil, that's my country. But I'm sure that the next year you are going to improve these numbers due to the investment of the king in the healthcare. You are here, we are discussing CPR, and so on. So, about ventilation during CPR, and if you don't do ventilation, this is a nice study in animals, 10 dogs, ventricular fibrillation, CPR without ventilation. So what they analyze the blood gas, and as you can see, in the first 4 minutes, it's okay, you can keep without ventilation. However, after that, the animals start to be hypercapnia, acidemia, and hypoxemic. So only in the beginning, we can provide CPR without ventilation. After, we need to provide ventilation. Recently, it was described what we call CRALE, cardiopulmonary associated lung edema. What's this? Imagine you are pushing the thorax. You are pushing the thorax quickly and deeper. So you are promoting lung injury. As you can see in this CT scan during mechanical or manual chest compression are areas of lung injury, especially during mechanical chest compression, because imagine the power is harder from the machine, and when it happens, it promotes hypoxemia, acidemia, and this editorial, the title is very, very clever. How is the price that the lung has to pay to get the heartbeat? And you have to find a balance between them. And it was described after that, the impact of have RDS, have lung injury during CPR. This I studied in hospital cardiac arrest patients, 200 patients, as you can see, 75% of them evolved with RDS, and it promotes more chance of mortality, as you can see in this line. This in out of hospital cardiac arrest patient, 1,000 patients analyzed, half of them evolved with RDS. When they have RDS, worse outcomes, less chance of survival, worse neurological outcomes. This is a study that I published with the group 12 years ago, that we studied the physiology of ventilation during CPR. It's very complex. I'm going to resume the most important message, that imagine you are pushing the thorax. So the lung volumes go normally below the AARC, and it can promote lung injury, can promote airway closing. So normally during CPR, we ventilate the lungs below the AARC. About the strategies that we have nowadays. First, mouth-to-mouth is cheap, available anytime, but I'm sure that here no one is going to be comfortable to provide mouth-to-mouth ventilation. So, to be honest, it's almost a not good option. Then you can move for bag mask. Probably it's the most used around the world. Of course, it's cheap, easy to transport, but many disadvantages. Can promote gas insufflation. It's not so easy be done by only a single rescue. No monitoring data. What we are providing? What's my tidal volume? What's the pressure? We don't know. And if the patient is not intubated, you have to stop chest compression to promote bag mask. And here is a recent paper published in Circulation that analyzed 2,000 people with out-of-hospital cardiac arrest, and they analyzed the quality of ventilation with this technology, a bioimpedance amplitude, and if it was higher than 0.5 of amplitude, it represents that a ventilation with above 250 milliliters and a duration above 1 second. Let's say a good quality of ventilation. And they divided the patients, after analyzing the quality of ventilation, in two groups. First group, patients with detectable ventilation waveforms in less than 50% of the pulse. So not a good quality of ventilation. Group 2, the opposite. So detectable ventilation waveforms in above 50% of pulse. And as you can see in the results, in more than half of the patients, 60% of them, lung insufflation was detectable in less than 50% of the pulse. And patients who receive detectable lung insufflation have a better clinical outcomes. As you can see, a big chance of ROSC, to be admitted to the hospital, to survive to hospital discharge, 30% against 4, with good neurological outcomes, 10 against 2. So what's the conclusion of this study, very important study, that bag mask ventilation is often ineffective in more than half of the case to provide a good quality of ventilation. And a good quality of ventilation can improve outcomes. And this editorial is very interesting because they show that each brief good that you provide, you increase the probability of survival and good neurological outcomes. So it's very important to provide a good quality of ventilation. This is another study, again, the same message. With bag mask, in half of the case, we don't provide two full insufflations. So it's very common to not provide a good ventilation with bag mask. No ventilate. Of course, it's easy to explain. Only do chest compression. Don't do mouth-to-mouth. Don't do provide ventilation. So it's easy to explain to lay people. Can perform chest compression without interruption, but many disadvantages. It's only effective only when you start early and no long CPR time. Not indicate if the cause of CPR is a respiratory cause and in the pediatric population. Evidence in the literature only with out-of-hospital cardiac arrest patient, and when it was compared to mouth-to-mouth ventilation, that you know is not easy to be performed, is not easy to explain, it's not a good quality of ventilation. Then mechanical ventilation, traditional modes of ventilation. In Europe, normally we keep the patient in a mechanical ventilation during CPR. It's not, why? Because you can release a rescue to perform chest compression. You don't need to stop chest compression. You can use some level of PEEP that can avoid lung injury and recruitment collapse area. Disadvantage, almost it promotes auto-triggering. And if you will not set good, the PEEP, for example, can have negative hemodynamic impacts. And these are recent studies that we are doing in France and Belgium that compare volume control, traditional mode, against the next mode that I'm going to explain. And it's a real case in the field. It's a patient that was resuscitated and the machine was set with 10 minutes by each minute, according to the guidelines. But what happens? The chest compression by itself triggered the ventilation. And finally, there was 30 respiratory rate each minute. And it can be dangerous because the intrathoracic pressure can stay continuously high and impair venous return. Now, CPV. CPV is cardiopulmonary ventilation. It's a mode dedicated for cardiac arrest. What is the advantages? It can optimize blood flow due to thoracic pump theory. I cannot discuss a lot about that because of the time, but mainly if the intrathoracic pressure oscillates simultaneously with chest compression, the compression, it can optimize blood flow. With the use of some level of PEEP, you can protect the lung. You can release a rescue to provide another activity without interruption in chest compression. Disadvantage, maybe not so much evidence in the literature, but now it has one paper that I'm going to show you. So what is this mode? It's a big pressure mode without inspiratory trigger. And when you push the button, it will start according to the guidelines. It's not a revolution. We are going according to the guidelines. FL2, 100%, 10 breaths each minute, each breath take 1 second, it's the guidelines. By default, we put low pressure at 5. It's not PEEP, I'm going to explain why during the presentation, and high PEEP of 20. And start the ventilation. Very easy. If the patient gets ROSC, you push the button of ROSC, you go for a traditional mode. If the patient has cardiac arrest again, you can push CPV and return for this mode. Then I'm comparing here in this figure the conventional mode of ventilation during CPR and here during CPV. As you can see, during conventional modes, you choose, for example, PEEP of 5, always the airway pressure is going to be above 5. And here in CPV, I put low pressure 5, but can reach 0 to allow venous return. And also during conventional modes, a lot of out-triggering that doesn't occur in this mode of ventilation. And this mode of ventilation, the CPV, has a monitoring dedicated for the cardiac arrest moment. As you can see, the frequency of chest compression we have the percentage of chest compression during all my cardiac arrest resuscitation. It should be higher than 60% according to European guidelines. I also have this we call peak-to-peak pressure. That's the difference between the minimal and the maximal intrathoracic pressure during each cycle with chest compression. So high is that, it reflects a better quality of chest compression.
It's already 10 minutes, doctor.
Oh, sorry?
It's already 10 minutes.
It's finished?
Yeah.
Can
you want to extend?
Let's slide. I said that. This is a paper that I said that analyzed 2,000 patients and showed that during compared this mode against Baxepap, this mode had a better chance of ROSC and with good neurological outcomes. So these are my take-home messages, and according to the last European guidelines, nowadays they recommend effective oxygenation and chest compression with ventilation. Thanks so much for attention.
Thank you, Dr. Ricardo. So in our second session, we will then hear from Dr. Majdi Idris, consultant and head of pulmonary vascular unit at Prince Sultan Military Medical City at Riyadh, who will discuss optimizing inhalation therapy for better outcome using air chamber.
Assalamu alaikum wa rahmatullah. Thank you so much for the kind introduction. Thank you so much for the organizing committee to really invite me to be part of this very, very elite. And I feel a little bit awkward as a pulmonologist to talk to basically specialized really RTs in the field. So this is my disclaimer, and this talk is sponsored by PPS. So let's start talking about this really concept of the inhaled treatment. And I think there is clear benefit of using inhaled routing therapy, as you can deliver the drug directly to the lung, lower the dose than systemic dose, and decrease the side effect. And many, many guidelines talk about why this is so important. However, despite that, we know that in real world, many, many patients having poor asthma control. Clearly, there is multiple reasons and the challenges for that, but what's more important is always, if you read any guidelines, it's always the inhaler. Either adherence to the inhaler or the poor technique of using the inhaler. Both local guidelines, SINA, and the international GINA guidelines emphasize on this point. And we know, like from different studies, that most patients are not well controlled when it comes to the asthma. And one of the important points that about 80% of the patients on inhaler therapy are unable to use the device correctly. Very importantly, to know that, which is very sad actually, to know that this is not getting better over time. Still, one of the single most important reason for poor asthma control is lack of technique, inability to use the device to deliver the drug, basically. And when you look at the clinician, now, of course, doctors believe that we are the best of the best, we are the elite of the society. That's true or not true. We can debate on that. But what's important to really show you that we fail to teach the patient about how to use the technique. And if you look at what happened over decades, only 15 to 20% of doctors are adequately trained to train the patient. Even pulmonologists, whom you would assume that they are the best in doing that, only 50 to 60% of pulmonologists are aware of the technique of different devices. Internal medicine, 15%. Pharmacy, nurses, close to zero. So we count on you guys for this. It is you, the RTs, are the best to deal with that. So why using the spacer device whenever we are using the MDI? And the reason is really small, really simple, straightforward. It improves lung deposition and delivery of the drug, reduces the side effect, and overcome this coordination business. So when you look at the lung delivery, you can see that by using the spacer with the MDI device, you can at least double the amount of the drug that is delivered to the distal part of the lung, which is extremely important for the drug to be effective. And we know from many studies that even those well-trained patients, that they do the best in really dealing with the MDI, and they are able to deposit 25% of the drug, about 60% of the drug will stick to the oropharynx and causing trouble. Of course, most patients belong to those uncoordinated, where about 90%, 80-90% will hit the oropharynx, and less than 1% of the drug will reach the lung. Problem: using inhalers with the spacer, you significantly decrease the oral deposition to about 9-10%, and you optimize the lung delivery to about 30%. So this is the best and actually the only technique of helping the patient when they are using the MDI devices. Now, what about the really oropharyngeal basically deposition and safety? As we said, if you are using the drug, the MDI, without a device, about majority of the drug will stay in the oropharynx, and the local side effect causing by the candida infection, really hoarseness, is really a problem. And that can be decreased significantly by using really the MDI with a spacer. And we look at the dental hygiene in those asthma patients compared to the control, and you can see clearly that those patients who are using MDI have almost double the trouble with really dental decays and so on. And that can significantly get better by about 50% by using the spacer device. So multiple reasons to use the spacer devices in those patients. Forget about now the device, let's talk about the spacer. It's also important to realize that spacers are not the same. And each spacer should be considered as a unique delivery system. And physicians should be aware of this concept. It does not mean that you are using a spacer that you are getting the best for that patient. And we know that when you look at the spacers, most of the spacers or the aero chambers are used at home. People do not like to take it basically with them outside. And this is not unique to human. Definitely even basically animals can sometimes using spacer with some studies. Really, there is study on really asthma in horses and cats and dogs showing better control of their asthma whenever they are using the inhaler device. I missed one patient with asthma, the cat of my nephew. She basically, she gave me the cat because she was traveling, and the cat was really coughing. And when she came back, she said, "How is the cat?" I said, "The cat is okay, But she took the cat to the vet, and the vet said she's asthmatic. So I missed the diagnosis. I'm sorry for this. And the doctor gave her Ventolin tablet. Very interestingly, he did not give her the really inhaler and device. So that was not a good doctor. But now we need to go further with the unique inhalers with device that now we have a device that is really 2-in-1 that can be used outside. So take it to go because it can basically protect and you can keep the device inside it, and then it's so small impact and can be used as outpatient. And that has been shown that if you look at the adherence of the patient to the device was increased to about 80 or 90%, because now the patient have it at home and outside, it's small, can lift in the pocket, and that's extremely very, very important. So my take home message to you, ladies and gentlemen, I think we know that asthma control remains a major challenge among pulmonologists. Data in Saudi Arabia showed that 70 to 80% of our asthma patients are not well controlled. But again, if you look at why is the reason, there's multiple causes. But number one cause is the inhaler technique and adherence. And that's extremely important. So we need always to focus, before we start adding drug and use biological therapy or so on, we need to go to the basic, that look at the device, look at the patient if he or she is using the devices. And then we know that by doing that, we are improving the outcome by improving the delivery of the drug dosing to the lung. We are overcoming this coordination, synchronization between activation of the inhaler and taking the breath in. And also, we are reducing significantly the local side effect of the medication. And I think this new device, which is air chamber space so that you can take it with you, you can keep the drug in it, the inhaler in it, you can use it in-house and out-house, has led to significant improvement in really asthma control by improving the adherence to the device. Thank you very much for your attention.
Thank you, Dr. Majdi.
Assalamu alaikum. Due to unexpected circumstances, the next topic, which is tracheostomy tubes, will be skipped, and the next 10 minutes, inshallah, we'll hear a presentation on optimizing airway clearance in ICU, which will be presented by Mr. Aqil Al-Ali. Mr. Aqil Al-Ali is a senior respiratory therapist at King Saud Medical City. Please, Mr. Aqil, floor is yours.
السلام عليكم ورحمة الله. المعذرة على التأخير. I am Aqil Ali, respiratory therapist from King Saud Medical City. My topic today is about clearing the airway effectively, why, when, and how to use high-frequency chest wall oscillation. The first question is why airway clearances matter. It's because the retained mucus is causing a chronic infection, which is leading to recurrent inflammation, leading to airflow obstructions ended by lung damage. These four phases, each one is reinforcing the other, which is called or known by a vicious cycle, and typically seen in the patients who are chronic sputum producer, have ineffective cough mechanism, or in post-exacerbation recovery. So the treatment plan or the treatment goal to irritate or interrupt this vicious cycle through mobilization secretion, effectively reduce exacerbation frequency, improve gas exchange, and enhance overall quality of life. High-frequency chest wall oscillation has been proven. It can work with this kind of patients and can break down the vicious cycle. So what is high-frequency chest wall oscillations? Simply, it is a device contained from three parts. First, air pulse generator connected to inflatable fist through hoses. It rapidly inflates and deflates to oscillate the chest wall. This mechanism is creating a shearing force, or known as high-velocity expiratory flow. This mechanism able to break down the mucus, thinning the secretion, and moving them from small airway to large airway. To set the device, we have only two parameters. First, the hertz. It's a range from 5 to 25 hertz, known as cycles per second. All the pressure, the other parameters is the pressure range from 5 to 20 centimeter of water. It's applied to the patients in 5 minutes interval, followed by a pause to allow the patient to do huff and cough or to use other ACT devices, with the total session duration not exceeding 20 to 30 minutes. When to use it? Generally, if we have a patient who have a large amount, thick, sticky secretion and hard to be cleared, it's suitable for them. For example, cystic fibrosis, this device shown that it's improved sputum clearance and quality of life outcomes. And non-cystic fibrosis, bronchiectasis also, some studies showing better pulmonary infections parameters with high-frequency chest wall oscillation. With the cough, COPD and chronic bronchitis, also it improves expectorated sputum volume and may shorten the hospital length of stay. With the neuromuscular diseases, if it is adjunct with cough assist, it might help the patients, this kind of patients. So to summarize the criteria to select this device, first, failure of or intolerance of other airway clearance techniques, lack of consistent caregiver support for manual percussion, high secretion burden if the production of the sputum exceeding 30 ml per day, history of a frequent respiratory hospitalization or exacerbation, need for patient independence and other and therapy routine. There is some conditions for diseases considered as contraindication for this device. For example, unstable hand and neck injury, active hemorrhage, hemodynamic instability, access port directly under the fist. Also, in some acute pulmonary risk like pulmonary embolism, lung contusion, large pleural effusion or emphysema, active or recent hemoptysis. While could be applied with the precaution with the bronchospasm patients, severe osteoporosis, coagulopathy, recent esophageal surgery, distended abdomen.
if we are running this machine with a patient, then suddenly the patient develop a sudden chest pain, dizziness, desaturation, or new hemorrhage, it should be stopped immediately. How to use the machine? First, patient preparation. Hydrate the patient well to ease, mobilize, and thinning the secretions. Use bronchodilators or mucolytic if it is prescribed. It should be applied before and during the procedures. Also, proper selection for the fist size, which is fit enough but keep allowing the patient for the deeper breath. Settings, frequency will be set from 10 to 15 hertz and low to moderate pressure, then to be adjusted according to patient comfort. The goal is to allow for chest vibrations, or what we call voice quiver, but not causing pain. As I mentioned earlier, the cycle will be 5 minutes interval followed by pause to allow the patient to do half and cough or use PEP or manual suction by the caregiver. After we finish, the patient should be reassessed again. Document your outcome, the outcomes from patient, the sputum volume and tolerance, then following the manufacturer recommendation for device cleaning and disinfection. Yeah, treatment protocol and dosing, I think it is repeated, will be 20 to 30 minutes duration for the session, not exceeding. It could be repeated 3 to 6 times. Program the hertz, we mentioned it already. Next. Okay, but generally this device or this technique are considered safe and well tolerated across cystic fibrosis and non-cystic fibrosis bronchiectasis. Also, it is universally superior to manual CBT and active cycle of breathing trials. Some randomized controlled trials reported fewer exacerbation with high frequency chest wall oscillation versus PEP in children. Also, it reduced healthcare utilization, including fewer hospitalizations and antibiotic courses with adult bronchiectasis. Here a list for different devices and techniques of ACT, airway clearance techniques. Some of them, it need patient active, like patient cooperation and activity like PEP, ACBT, while high frequency chest wall oscillation and manual CBT doesn't need. But some of them consider costly, like high frequency and PEP and cough assist, while manual CBT and ACBT is costless, doesn't need equipment. With all this diversity, advantages and disadvantages, we cannot say that one modality or one technique is suitable for all patients. So in conclusion, the best airway clearance technique is the one the patient will actually do effectively and consistently. No single ACT is superior for all patients. Selection should be individualized based on adherence, physical ability, preference, and a clinical response. That's the end. Thank you very much. And this is the references. Thank you.
Thank you. On behalf of this conference organizers, I would like to thank our presenters, and I think we'll move to session 4, inshallah. Thank you. Have a nice day.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon. Thank you so much for coming today. I'm very happy to be here with you. Today, me and my colleague, Dr. Amal Amir, we will be moderating this session. Abstract session will include like exciting, a lineup of 5 research abstracts. Each presenter will have 5 minutes to present his presentation, and we hope all the best for the presenters. So for the sake of the time, we will start with the first presentation, non-invasive ventilation in sickle cell disease, and the presenter will be Fatma Al-Koebi. So please, if you can come and present your presentation.
Assalamu alaikum. Dr. Jabal, if you will allow me, the first is not ready, so if you want to start with the second one, prevalence and clinical correlates.
Okay. So we will move to the second one, prevalence and clinical correlates and small airway features of PRISM in Saudi Arabia. The presenter will be Ali Tourebi. Please come on stage to present your presentation. You have 5 minutes.
Assalamu alaikum. My name is Ali Tourebi. Inshallah, today I will present to you our study prevalence, clinical correlates, and the small airway features of a preserved ratio impaired spirometry in Saudi hospital-based cohort. Preserved ratio impaired spirometry is defined by reduced forced expiratory volume in first second with a normal forced expiratory volume in first second forced vital capacity ratio. PRISM is a heterogeneous and often under-recognized spirometric patterns. No barrier data from Saudi Arabia, particularly regarding its association with small airway dysfunction. So the aim of our study to determine the prevalence of PRISM among adults undergoing spirometry at a tertiary hospital in Saudi Arabia to compare small airway function across different spirometric patterns, including PRISM subtypes, and to identify factors independently associated with the small airway dysfunction. Our study is a retrospective cross-sectional study using routinely collected spirometry data from March 2021 to March 2024, and we include adults equal or greater than 40 years old with acceptable spirometer. Our sample size was 709, and we used descriptive and interferential statistics to analyze our data. So as I mentioned, our sample size was 709, and after removing 100 duplicate records, result in 609 were evaluated for eligibility, and of these, 17 patients were excluded due to incomplete spirometry. So that resulted in 592. After that, we divided them to 5 groups based on spirometry parameters: normal spirometry, obstructive pattern, non-restrictive PRISM, restrictive PRISM, and restrictive pattern. So this showed the distribution of the group. The 54% of participants was in the normal spirometry, 26 in the restrictive PRISM, 12 in the restrictive pattern, obstructive pattern, and non-restrictive PRISM, each have approximately 4%. This showed the prevalence of small airway dysfunction, and the highest prevalence was in obstructive pattern with 96.2. SAD always observed in non-restrictive PRISM and restrictive PRISM with a percent of 50 and 24 respectively. It was uncommon in normal spirometry, and it's absent in restrictive pattern. How we assess the small airway dysfunction? We assessed by forced expiratory flow 25-75, and we get a median from each group, and the lowest median was in non-restrictive PRISM and restrictive PRISM. And the previous studies show the patients with low FEF 25-75 have high risk of developing COPD in the future. Both non-restrictive prism and restrictive prism are strongly and independently associated with small airway dysfunction, irrespective of demographic data or smoking status. So discussion and interpretation. Prism represents a high-risk spirometric phenotype with a substantial burden of small airway dysfunction. A perceived ratio does not exclude physiologically relevant airway disease, particularly at the level of the small airways. The strong association between prism and small airway dysfunction provides a plausible explanation for persistent symptoms in patients who do not meet the criteria for the classic obstruction. So in conclusion, prism is a common spirometric pattern in Saudi hospital-based cohorts. Incorporating small airways assessment may enhance the clinical interpretation of prism and help identify patients with otherwise unrecognized airway impairments. Future studies should explore the longitudinal implication of small airway dysfunction in a prism. That was my presentation. Thank you for listening.
Thank you, Mr. Ali. And now we'll move to the next presentation, non-invasive ventilation in sickle cell disease and acute chest syndrome, a systematic review and meta-analysis by Fatma Al-Kaibi.
Sorry, we're having technical, so if you want to call Mohammed first.
Okay, so now we'll move to an innovative 3D printed connector for safe switching between maximum inspiratory pressure measurement and mechanical ventilator without patient disconnection by Mohammed Al-Mghallaq.
This one? Yeah. For the house and so on. Assalamu alaikum. Good evening, everyone. My name is Mohammed Badr Al-Mghallaq, and today I'll present to you Allow Me to Breathe, an innovation 3D printed connector for easy switching between maximum inspiratory pressure and mechanical ventilator without patient disconnection. Our outlines for today are going to be introduction, methodology, preliminary results, and the novelty of this project, and of course, what's next and the references. Maximum inspiratory pressure, MIP, directly measures inspiratory muscle strength. It helps clinicals to assess the patient readiness to be weaned from mechanical ventilation, among other paramedics. But however, the current practice takes about 20 seconds of disconnection between the mechanical ventilator and the patient. This action can lead to some serious complications, such as hypoxemia and loss in beat, and respiratory distress. In addition, the action of disconnection may lead the patient to get triggered and then start coughing, spreading his infection to all people around the room, to nearby patients and other healthcare staff. Therefore, this project introduces a novel 3D printer that can connect both the mechanical ventilator and the MIP measurement device without requiring the risky disconnection acts. Our methodology started by multiple sketches and prototypes were made, aiming for lightweight, compact, and easy-to-operate connector. Allow Me to Breathe was our final design, created using Rhinoceros 3D printer software. Printed using the Bamboo Lab printer using the polylactic acid material. Allow Me to Breathe, as you can see, our final prototype design. It's a three-way port, T-shaped, and inside it, an L-shaped stopcock. So now we can just switch between mechanical ventilation and the MIP measurement device without requiring the disconnection. Our experimental setup. Since no commercial setup that simulates MIP values above 50 centimeters of water is available, a respiratory laboratory test model was created to evaluate the connector under controlled condition. We used a 3-liter syringe, PFD syringe, connected to waste plates from 2.5, 5, and 7.5 and 10 kilograms to generate a standardized negative pressure levels. Negative pressures were recorded using Power Breath KH2 digital manometer. Our producers, two conditions were compared, the standard method and the Allow Me to Breathe connector method. Each load condition was tested 10 times So a total of 80 trials were tested. All parameters included the connector, tubing, and angle, and environmental conditions were consistent across all trials. As you can see, this is the video of the experimental setup for Allow Me to Breathe. Weight levels 2.5 and 5 and 7.5 and 10 kilograms simulated inspiratory muscle efforts. As you can see in table 1, we tested each one with 2 conditions, the Allow Me to Breathe and the standard method. As you can see in the significance, there was no difference between them. The significance was at 2.5 and 7.5. The significant difference observed at 5 and 10 kilograms. All different remained within clinically accepted limit. Allow Me to Breathe showed a reliable MIP measurement without ventilator disconnection, supports safer, more frequent assessment, particularly for fragile ICU patients. Our limitation were that the standard lung simulator, ACL 5000, was limited to less or equal to 50 centimeters of water of MIP simulation. So a custom laboratory model developed as an alternative which provide controlled, repeatable pressure generation. But however, it does not fully replace a real patient ventilator interactions. And for our impact, these preliminary findings proved evidence of feasibility, show close alignment with standard practice values, and support the development of a safer and more efficient clinical workflow for inspiratory muscle assessment in ventilated patients. The novelty of this project, so Allow Me to Breathe, is the proposed name for our connector, reflecting the patient's need to breathe safely between tests and enabling rapid switching back to mechanical ventilator in under 2 seconds. And to our knowledge, this is the first connector that allows direct MIP measurement without disconnecting the patient from the ventilator. This innovation lies in its airflow routing architecture, not the measuring principle itself. The compact T-body design intrigued to a two-way stopcock valve that temporarily directs the inspiratory effort to a manometer while maintaining the ventilator circuit. This eliminates the risky disconnection, preserved oxygenation and PEEP, reduces infection risk, shortening setup time, and enabling faster and more frequent MIP assessment and inspiratory muscle training. So what's next? For our next short term, we are trying to find a better material for our design and also trying to
1 minute, please.
Okay. And also trying to do more experiment to make sure that our connector is safe and also efficient. And for the longer term, we are going to apply for a patent and of course do an FDA approval. This was me and my final day research presentation with the Mohiba Research Program at Imam Abdurrahman University, and also me in the National Olympiad for Scientific Creativity. These are the references we use, and this is our work team, Dr. Maher and Abdullah, and of course me, Mohammed Al-Mughallig. Thank you for listening. This was our project, Allow Me to Breathe.
Thank you so much for this interesting presentation. We will move now to the third presentation. The title is Acute Cardiovascular Responses to Hypoxia and Hypercapnia in Healthy Adult, the Role of Carotid Body. The presenters will be Abdullah Al-Rayes and Salih Al-Utaibi. Please come on stage.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. My name is Salih Tebi. I'm here with my colleague Abdullah Rais. So our topic is talking about the role of carotid body in acute cardiovascular response to hypoxia and hypercapnia in healthy adults. So to begin with, the carotid body is a cluster of cells that located in the bifurcation of the common carotid artery. Its main function is to sense the blood content going to the brain.
So as we can see here, this is a sensory cell, type 1 cell of the carotid body. During hypoxia, a cascade of receptors will be activated. This will cause a depolarization of the cell, and it will release neurotransmitter that will send signals to the brain.
These signal will be then transmitted to the spinal cord, and it will lead to the activation of the sympathetic nerve system. This activation will lead to the alteration of the cardiovascular function, lung function, and also will cause some physiological changes such as the mouth dryness and pupil dilatation.
It will also activate the RAS system, which will increase the renin production in the kidney and the ACE production in the lung. It will also have an end product of increasing angiotensin II, which will cause vasoconstriction. As we all know, both COPD and cardiovascular disease are characterized by chronic hypoxia. This will cause a carotid body hyperactivity, which will alter the lung function, and it will have an effect on the cardiovascular system. And it will cause some effects such as hypertension. All the literature have discussed chronic hypoxia.
So what about acute hypoxia? There's all these receptors will going to activate and produce a neurotransmitter, and also acute hypoxia might alter the respiratory function. But what about cardiovascular function? Is it going to increase the blood pressure?
So acute hypoxia will stimulate the carotid body. It will have an effect on the heart. But is it going to increase the pulse rate? Is it going to change the blood pressure? And most importantly, is the duration going to alter the outcome? So in methodology, the participant will come and relax on a chair while we attach them. Pulse oximetry, blood pressure, and power lab. So they will wear a nose clip, and then they will hold their breath for as long as they can, and then 5 to 10 minute rest. After that, they will rebreathe in a plastic bag to induce a combined of hypoxia and hypercapnia, and then 5 to 10 minute rest. After each induction, measurements will be taken. We'll take saturation, we'll take blood pressure, and we'll take pulse rate.
Mean blood pressure, we can see there is no change in the blood pressure throughout all phases.
Well, I think because the RAS system hasn't been activated yet.
That's right. However, in pulse rate, we can see a change in the pulse rate in the phase of hypoxia and hypercapnia in relation with the baseline, and also within groups. In oxygen saturation, we can see a decrease in the saturation in the after hypercapnia phase, and also within groups. So the most important question is there any correlation between the duration and the acute hypoxia?
Well, we found that there are some indications that says the longer they take, the more effect happen on the pulse rate. Also, in mean blood pressure, we found that the more they take, the longer they take, the more changes happen. So, in conclusion, we found that the pulse rate is the most sensitive indicator of acute hypoxia and hypercapnia stress. Secondly, mean blood pressure hasn't been changed because the RAS system has to be activated, and it will take a longer time to achieve that. And thirdly, a combined hypoxia and hypercapnia have the most effect because it activates both the carotid body and the brain center. Lastly, the duration is a key stressor, and it might alter the outcome. At the end, these are preliminary results on 23 males. We are aiming for 100 males and 100 females to get a clear picture on this subject. Thank you.
Thank you so much, Mr. Abdullah Reyes and Salih Lataibi. Now we'll move to assessing the efficacy of innovative prototype of a wearable transcutaneous carbon dioxide monitor in healthy subjects. Lama Zahrani.
Assalamu alaikum. Good afternoon, everyone. My name is Lama Zahrani, and today, inshallah, I will gonna present our research titled Assessing the Efficacy of an Innovative Wearable Transcutaneous Carbon Dioxide Monitor in Healthy Subjects. So, first of all, our inspiration for this research arose from the concern about significant population of patients at risk of developing type 2 respiratory failure. Those patients include patients with chronic obstructive pulmonary disease, neuromuscular disorder, and obesity hyperventilation syndrome. So those patients at risk of developing type 2 respiratory failure, which will gonna increase the emergency department visit, hospitalization, the need for endotracheal intubation, ICU admission, and ultimately will gonna increase the morbidity and mortality and the healthcare cost. So therefore, we aim to develop a device that's capable of continuously measuring the CO2 above the skin. So once the CO2 level increases above the normal, the device alerts the patient to rising CO2 level, and the patient will be able to provide early management and avoid all of this vicious cycle. So the wearable transcutaneous CO2 monitor developed using an SD40 sensor that's capable of measuring the CO2 in part per million units. This is the initial sensor. We assemble the sensor inside a plastic box. After that, we design a 3D printed case, and we assemble the sensor inside of it. So a prospective study conducted using healthy volunteer, and the validation for the prototype conducted in 3 experiments. In the first experiment, the prototype tested against hospital-grade capnography during hypoventilation and hyperventilation maneuver with 3 experiments. In the second experiment, the prototype tested against hospital-grade transcutaneous CO2 monitor in 1 healthy individual. So both devices placed on the skin and the reading collected simultaneously. In the third experiment, we repeat the same second experiment, but at this time we use the 3D printed case. So the main finding during hyperventilation in the first experiment, we noticed that the CO2 level increased gradually and then declined in both prototype and capnography. During hypoventilation, also we noticed that the CO2 level increased in our prototype and in capnography. So the main finding in the first experiment confirmed the successful utilization of SD40 sensor in measuring different physiological CO2 level. In the second experiment, we noticed that the CO2 level using our wearable CO2 monitor showing some fluctuation between 1,000 to 1,500. That's plotted in red lines. So we suspect some potential air leak to the system. And to address this issue, we developed the 3D printed case, and we used it in the third experiment. In the third experiment, the reading became more stable between 1,000 and 1,200, matching transcutaneous CO2 monitor reading between 35 to 45, which is the normal physiological CO2 level in bloodstream. In conclusion, our research presents a wearable transcutaneous CO2 monitor that's capable of continuously measuring the CO2 in bloodstream. Experiments show a significant confirmed agreement between our wearable device and hospital-grade capnography and transcutaneous CO2. However, further research needs to be done to define exact correlation between parts per million and millimeter of mercury unit, because it's a new unit to measure the CO2 level. And long-term study on type 2 respiratory failure to define the long-term impact on hospitalization and mortality and morbidity and healthcare costs. This is the reference, and thank you for your good listening.
Thank you so much for this lovely presentation. Now we will move to the last presentation. I hope it's ready. Non-invasive ventilation in sickle cell diseases and acute chest syndrome, a systematic review and meta-analysis. It will be presented by Ms. Fatma Al-Kuaibi.
Hello everyone, thank you for attending. It is Fatima Al-Kuaibi and I am here to present our poster presentation titled Non-Invasive Ventilation in Sickle Cell Disease Patient with Acute Chest Syndrome, a systematic review and meta-analysis. Sickle cell disease is a hereditary blood disorder in which abnormal hemoglobin leads to red blood cell sickling, which leading to vaso-occlusion and eventually widespread organ complications. So could we say one of the most serious complications of sickle cell disease come from the lungs rather than the blood? The answer is yes. Acute chest syndrome is a life-threatening pulmonary complication of sickle cell disease, often leading to ICU admission and respiratory failure despite standard therapies, with mechanical ventilation further increasing the risk of complications and mortality. Our aim was to evaluate the impact of non-invasive ventilation compared to standard treatment, non-IV oxygen therapy and mechanical ventilation on oxygenation, respiratory function, and the likelihood of intubation. We performed a PRISMA-based systematic review and meta-analysis of studies performed between 2000 and 2024 from over 252 identified records through 5 databases. We only included 20 studies. We included adult and pediatric population, and the key comparison was between NIV versus oxygen therapy, or MV, and the main outcomes were oxygenation, respiratory function, and the need for intubation. We assessed the quality based on the type of the study, either randomized or non-randomized or observational, and we did the analysis using random effects analysis by ReviewMan version 5.4. Our results primarily focus on 3 primary outcomes. Firstly, intubation rates. The risk ratio was 0.52, which means NIV reduced the risk of intubation by 48% compared to oxygen therapy. And secondly, mortality rates. The odds ratio was 3.21, which means intubated patients was at higher risk of mortality than non-intubated patients. And lastly, length of stay. An IV reduced hospital stay by about 3 days. For the subgroup analysis, the benefit of an IV in pediatric patients was greater than adult patients, with a risk ratio of 0.41 versus 0.67 in adults. For the study design, the effect of an IV was reduced in intubation in the randomized controlled trial compared to observational study. So the conclusion, the findings strongly support an IV as a safe and effective intervention with the greatest benefits observed when applied early. Based on its demonstrated benefits on oxygenation and respiratory function, early NIV should be adopted as a frontline supportive strategy, as it is a practical, low-risk intervention that significantly reduced intubation rates, lowers mortality rates, and shortens hospital length of stay. Our limitations: high reliance on observational studies, variability in NIV protocols, and lack of long-term outcome data. Future directions: high-quality randomized controlled trials, standardized NIV protocols, long-term outcomes, and comparison with high-flow nasal cannula. This is the references, and thank you for your attention.
Thank you so much, Ms. Fatma Kaibi, and thank you to all presenters for this great presentations. And now we'll move to Abstracts Award presentation by Mr. Hassan. Thank you.
Thank you very much, Dr. Al-Qahtani and Dr. Al-Amir, for a very nice timely moving through those. And thank you, the presenter. You have been excellent. It has been a while since I have seen an orderly presentation of a fine abstract paper. Now, I want to talk to you about the process, just to tell you how we did the reviews. We started to receive abstracts since July last year, and then keep 3, 4, 5, 6, 7, and then on November, end of November, that was supposed to be the deadline. We received around that time, around 30 or so, which was, or 32. And then in communicating with our colleagues in the profession, they said, okay, it's exam, we need to have an extension. So we went up to 23rd of January, which is very tight to this time. And then, by then, we received 35 more abstracts. And in the end, we have had 68 abstracts. And just by looking at them, I knew that we have a very challenging review process. We will have a challenging review process. So our process, which is Noura and I and Mitu, we basically removed all the names and the affiliations. So only abstract, start in the order. And everybody submitted very nicely, exactly what we asked. So we removed and assigned a number to them. And then we have 68. I selected 3 scholars, been in the profession for a long time. They're all authors and excellent reviewers. So they went and reviewed all of them. And then we sent it to another 3. And I would like to thank, none of them know about the other. They are from different institutions, different places, and they don't know who else is reviewing. And then we have it reviewed by the first 3, then we send it to another 3, just to make sure that those ratings are appropriate. So we have 6 reviews, 6 reviewers. And then we have one decimal, 3.1, 3.2, 1.2, and so on. And then we found it very close. So we send it to 3 more. First of all, we average the 6, and then we have top 10, the highest grades. And then we send it to another 3 reviewers. Again, they don't know those 10s. They don't know where they come from. They reviewed them, and then we asked them to give us 2 decimal, not 1 decimal. So it will be like 2.52, 3.00, 1.25, and so on. And then we sorted them about again, and then we have, I feel, and anybody in his right mind will feel this is the most fair review process. And then we put the names back to the thing. Ironically, none of those people know those. And the last 3 who reviewed, they came up with almost exactly the same rating as the others, as the other 6. Meaning that we really have a quality research and quality paper. So I'm so proud of my profession, so proud of you, younger generation, for an excellent. So today I will have, of course, we have top 10. Of course, we cannot take except 5 for this, for our presentation. But we have, so we put the top 5 today. And then we looked, and in collaboration and discussion with our colleagues, they are all within 0.05 of that. So we considered the top 4 as tie. which they are really tie. So the first 4 are tie, the second 3 tie, the third 3 is tie. So we have the top 10 all tie. The first 4 are tie for the first place. The second group is of 3, they are tie for second place, and the last group of 3 are tie for the third place. Very impressive, to be honest. And I am happy to see. And can you put my slide? I just want to show you the distribution of those institutions where those papers came from. As you can see, the top abstract, the top 10 almost the same with a decimal, small decimal. But the top one, which is 3.00, all the top 4, those in green, top one, they're all 3, they got 3, exactly 3.00. And they're all, and as you can see, they're from Al-Mana, the first one, the second one, they're all the same. Saud ibn Abdulaziz University of Sciences, Al-Hassa, and Imam Abdurrahman ibn Faisal University, Dammam, and then King Saud ibn Abdulaziz University, Sciences, Riyadh. Those are the top tie in 3. So we are very happy with this result. And then we go to the lighter green. Again, King Abdulaziz University, Jeddah, is tie 2. And then Imam Abdurrahman Faisal University, again, from Dammam, is another tie for the second place. And then Katif Health Network, Abdullah Al-Muhanna, is the third tie. And the last 3 are the tie for the third place. Imam Abdurrahman ibn Faisal University, Dammam again, Muhammad Al-Mani College, they have the first and they have tie for the third. Masarra Al-Jaruf, of course. And then Princess Noura from Riyadh. Not only they have the highest registration, but also they have one of the top 10. They also have the top grade in neonatal pre-testing. Now, we're just about to conclude. I'm not going to distribute this and bring you up here, but we have all of them here. So all the top 4, they can stop by Noura and pick all those, pick the top 3. And then tomorrow, at the end, we will review the best display of abstract. To be honest, most of our international and local scholars, they have been around, and I have been around it. They are just magnificent. I have been to conferences, big conferences, everywhere. I have never seen as orderly, as to the point, and so nice looking. Not to mention the science, I'm talking only the display and how nice. I got 68 thinking that we will not get all the 68. So I put 56 panels. And then yesterday they called me, oh, we have 2 people came in. And how many? They said, this is 68. They all came in. So we added 2 more panels for them. So thank you so much. I think we are done for today. We will be all the best of ARC session today is concluded. But is the adult and neonates are already here, done with workshops? Yet? You are here? Not yet, they're all coming. So we will need to thank you so much for your good time being with us. Tomorrow we will announce the best display abstract, and we will announce the spirometry and the major award of visiting all the booths. With that, I thank you all. Excuse me, workshops, are you done? Are you here? Neonatal adult, are you here?